Good morning, everyone. I welcome all the faculties, delegates, and my dear students for our annual Apollo conference and workshop, Probe to Pulse. We are glad to welcome you all. And today will be an interesting academic feast regarding hemodynamic monitoring, POCUS, newer drugs, and about regional blocks also. We have got eminent speakers from all over our Mumbai specialty and even from other places. And we'll first start with Saraswati Vandana. I would like to invite Pranali. Pranali, please come on the stage for Saraswati Vandana. We'll play with the Holy Saraswati Vandana and we'll start the session, please.
Hello. Hello. Yeah. Can we all stand for Saraswati Vandana? Ya kundendu tushar har dhavala ya shubhra vastra vruta ya veena varadanda mandita kara या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवै सदा वंदिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. Thank you.
I would like to begin the first session. Dr. Leena Pawar will be moderating the first session. Dr. Leena, please carry forward.
Good morning, everyone. I'm so glad to be here, and I'm so glad that you all made your Sunday here. So really thanks for that. So we'll begin with our first session for today, that is hemodynamic monitoring. And for that, I invite following chairpersons. We have Dr. Sanjeev Jadhav. Sir is a senior cardiac surgeon at Apollo, and he's also a transplant surgeon with us. So may I please request Sir to be on the stage. Then we have Dr. Manoj Chauhan. He's a senior cardiac anesthetist at Asian Heart Hospital. Dr. Manoj. Next chairperson we have is Dr. Devendra Deshmukh. He's again a senior cardiac anesthetist. Now he's at Lotus, but otherwise we were together at Asian for long. So I'm so glad to see you, Devendra, after so long. Okay, with that, I request the chairpersons to introduce our first speaker, and we shall begin with our lectures. Thank you.
I would like to invite Dr. Yogesh Jhawar. He's an eminent faculty from Nagpur, a professor, and he's a pioneer in starting the transplant program over there as a chairperson for the first session. Dr. Sanjita Madam will be coming late. So Dr. Yogesh, please join on the dais. Dr. Haridas, you can start your first session. Presentation कुठे आहे?
मी आत्ताचं सेव्ह केलेलं आहे त्याच्यात रिपीट ॲड केलं ना. So, good morning to all of you. On the behalf of Department of Anesthesia, Apollo Hospital, Navi, Mumbai, I would like to welcome you all for today's academic event. Today's day is full of academics and other events, so I request everyone to attend it till end. I hope and I'm sure you will enjoy. So I'm starting with the session with basic of hemodynamic monitoring, what, when and why. Again, there are separate sessions on individual monitoring. I will just cover the basic things. So what is hemodynamic monitoring? So it is a real-time assessment of cardiovascular system's ability to deliver oxygen to the tissue. Actually, monitoring answers these questions. Is the heart pumping enough by monitoring cardiac output? Is blood pressure is adequate for perfusion by monitoring mean arterial pressure and CVP, central venous pressure? Is tissue getting enough oxygen? And is the patient is fluid responsive by monitoring the central oxygen saturation and lactate? So these are the key parameters. These are the parameters, and we'll see what the individual parameter tells about and what is the normal range. Mean arterial pressure, it will tell about the organ perfusion pressure, normally 65 to 80 millimeter of mercury. Heart rate and rhythm, it will tell about the cardiac stress, hypovolemia and pain, normally 60 to 100 per minute and sinus. Cardiac output, cardiac index tell you about the blood flow delivered. Normal cardiac output is more than 4 to 5 liter per minute and index is 2.5 liter per minute per meter square. Central venous pressure will give an idea about the right arterial pressure and rough estimate of the volume status. Normally is 5 to 10 millimeter of mercury. Central venous oxygen saturation will tell about the balance of oxygen delivery versus oxygen demand. Normally is around 70%. And urine output, as you know, it tells about the renal perfusion. It is the best marker of perfusion. Normally is minimum 0.5 ml per kg per minute. Now, why to monitor? Why monitoring is required? One is to detect early, guide therapy, assess the response and improve the outcome. We can catch the hypotension early, we can catch the low cardiac output, fluid overload before organ damage. Guide the therapy. It will help us to decide when to give fluid, when to give vasopressors, when to start inotropes and when to give blood. Assess the response once you started intervention, if it is, whether it is working properly, whether it improves the perfusion or not. It will tell, hemodynamic monitoring will tell about this. And last is outcome, reduces the mortality and ICU stay in high risk patients. Now when to do the monitoring and which type of monitoring we should use. Now when and what to use. Again, we cannot directly jump to the PA catheter or TEE. We have to go step by step. So we have divided it into 3 parts: level 1, level 2 and level 3. Level 1 will include non-invasive monitoring. It is used for all patients, ASA1 to ASA4. So this will include non-invasive blood pressure, heart rate, oxygen saturation, clinical examination of the patient, urine output, mental status of the patient, very, very important. These are the first line markers of the perfusion. Now, level 2. Level 2 will include minimally invasive. It is used in unstable and high-risk patients. And that will include artery line, which gives a continuous bit-to-bit monitoring of blood pressure, ABG sampling, pulse pressure variation. And this is mandatory for all the major cases like coronary artery bypass surgery and any critical patients in the ICU. Pulse counter cardiac output will estimate the cardiac output from arterial waveform, and it is less invasive than PA catheter. Now level 3, it is an invasive which is used in high risk and refractory unstable patients. Central venous catheter, which will give rise to the central access, central venous pressure. We can give irritant drugs through this and TPN also. But remember, CVP alone is a poor guide for fluid decision. Pulmonary artery catheter, direct cardiac output measurement we can get from these PA pressures, and it is used less now because of perioperative or peri-procedural complications. Gold standard is transesophageal echocardiography. It is used in the post-operative cardiac patients or any major transplant patient to give the cardiac output, ejection fraction, valves, volume status without extra lines. Now functional hemodynamics, will fluid help? How will you decide? Use this before giving fluid bolus in a ventilated non-arrhythmic patients. In this, we will monitor the stroke volume variation or pulse pressure variations. If it is change is more than 12 to 15%, that means it indicates patient is likely fluid responsive. Passive leg rest test, reversible fluid challenge. If it is more than 10% rise in cardiac output, it will give rise to the That means patient is responsive to the fluid. And next is central venous saturation. It is very important. If it is less than 70%, it will tell about the O2 supply is less than O2 demand. Now common pitfalls. Treat the number. Common pitfall of this monitoring, treating the number, not the patient. If patient's MAP is around 60 or 65 and patient's mental status is not good, that means patient is not normal. So you should not treat that number, you should treat the patient. Over relying on the CVP to guide fluids. If you rely on the CVP for giving fluids in a patient with atrial fibrillation like that, the patient will have a pulmonary edema. So future directions, individualized medicine, moving away from uniform approaches towards multimodal monitoring, and that is tailored to the high-risk patients. Artificial intelligence, the role of machine learning and predictive models such as hypotension prediction index in providing an early warning of hemodynamic shifts. And cerebral oximetry, using near infrared spectroscopy to monitor cerebral perfusion and reduce the post-operative cognitive dysfunction. Take-home points, what to monitor: pressure, flow, oxygenation and volume. When to monitor: escalate with the risk and instability. Why to monitor: to detect early, guide therapy and protect the organ. And use the least invasive methods that gives you the data need to make the next clinical decision. Summary: hemodynamic monitoring involves the measuring the pressure, flow and oxygenation of the blood within the cardiovascular system. It is primarily required in critical care patients and major surgery like cardiopulmonary bypass, valve surgeries, transplant patients. And it will assess the pump effectiveness, blood volume and tissue perfusion. It guides life-saving interventions, monitors immediate response to the therapies. Hemodynamic monitoring, remember, it is a tool, not a goal. The goal is tissue perfusion and organ protection. Match the tool with the patients. Thank you.
The session is open for question and answers. Maybe, sir, we can take 1 or 2 questions.
Haridas, you said PA catheters are used less and less. Can you explain?
Which one?
PA catheters are used less nowadays. What is can you elaborate on this?
It has its own peri-procedure and complication. That means it is the complications which are required while putting the PA catheter also and post-op also. We have seen the patient, there is a PA catheter not inside. We have 2 patients like that. And while putting also, if there is left main patient, it causes RV irritability. Sometimes patient may have a VTAC VP on table.
No, good presentation.
Thank you.
Yeah, it was nice. The only thing, pre-op investigations also we have to look into, basically to define the levels like EAC.
Yes, level 1.
Now, if suppose the EF of the patient is less than 15-20%, so you cannot give fluid challenges to this patient.
Correct.
We already know
Correct.
that what the problem is. So it will be cardiac versus non-cardiac problems, hypotension and all those things. Plus nowadays non-invasive cardiac output monitoring has come up in a big way. They've got advanced algorithms and all that. So instead of like PA catheter, we can look into the cardiac, non-invasive cardiac output monitoring and all those things. So people are using it, but overall you defined it very well. The Vedic and all.
Thank you.
Nice
Thank you.
presentation.
Sir, you told a nice line that our goal should be maintaining the patient perfusion,
Yes.
not treating the number. It was a very nice line. I always tell our student we should monitor we should target the flow to the patient and organ perfusion. And like sir told about non-invasive monitor, we have studied this flow track and Swan-Ganz CCO and these neon codeine that based on the totally non-invasive cardiac output monitoring, but in some the PA catheter based continuous cardiac output always hold the gold standard. We monitor this in the critically step. We require this monitoring, and only invasive monitoring is accurate in that settings.
Level 3.
Yes.
Very nice presentation, Dr.
Thank you.
Haridas. I would like to add one more thing. We should monitor ETCO2 to the all patients in which we are giving the general anesthesia. It will guide you the oxygenation and ventilation properly. So ETCO2 is to be added. in
Yeah,
these
I
things.
missed that, right, thank you. Yes. No, it's not it is a rough guide. It's not 100% we can use it. USG, yes. We can see IVC and collapse and everything, yes. Correct, yes, thank you.
Madam, in that case, whenever the chest is accessible, we can put directly probe on the heart and see the
can see the
volume
volume
status directly. It better guides.
Anybody from audience has any questions? Students here, this is an interactive section. Any doubts, please get it clear right now. The session is open for questions. I mean, we have time, we are quite on time, so. Or should we go ahead with the next lecture? Okay. Thank you, Dr. Haridas. It was indeed a very nice presentation. I request chairpersons to introduce our next speaker. Yeah, before that, we would like to felicitate Dr. Haridas. May I request Dr. Sanjay Jadhav, please, to felicitate Dr. Haridas.
I would like to have a common photo with all the chairpersons. The speaker, please be the center. All the chairperson will have.
हाँ, मैं वही कर रही हूँ. It's ना? Chairpersons, kindly introduce our next speaker, please. Introduce our next speaker.
Next speaker is Dr. Jalaram. He is the assistant professor at KEM Hospital. He has done his cardiac anesthesia DM from the KEM Hospital, and he has acquired gold medal in FIECTA exams. Welcome, Dr. Jalaram.
Thank you for the introduction, sir. So, good morning and greetings from KEM Hospital. So, just to reiterate what my previous speaker just stated right now, we are very much familiar with the Frank-Starling curve about a preload and its effect on stroke volume. Now, what I'm trying to show over here is a superimposition of the Marek-Philipp curve, basically to re-emphasize that we have to give judicious amount of fluid if there is a decrease in blood pressure, mainly because, as we can see, after the steep part of the Frank-Starling curve, there is a plateau, and then that fluid which we are giving is going to be causing an exponential rise in the extravascular lung volume, which is going to be detrimental for these patients. So this is something that we are familiar with, the classification for invasive, minimally invasive, and non-invasive hemodynamic monitoring. I will be covering most of these things. The ideal monitor profile is basically is a monitor which is reliable, which is continuous, which is operator independent, which is cost effective, and which has a rapid response time. Unfortunately, at the moment, we do not have such a monitor at present, but obviously we are going to be reaching there at some point. So more than the classical classification that we are all oriented with, I think as cardiac anesthetist in an operation theater perspective, I feel this classification gives us a more varied and a more better perspective of how we are supposed to approach a patient. So we should look beyond the pressures that we see on a monitor, because we should see, after the pressure-focused monitoring, we should see for flow orientations, like in the form of cardiac output plus contour analysis, tissue oxygenation, and also using ultrasound to know about the fluid status for these patients. So what are the static parameters? So that what we know is CVP and pulmonary capillary wedge pressure. So what are these values? So whenever we have a high value, our instinct is to correct these parameters, like which was stated by our previous speaker. However, what we should understand is that the CVP, for example, is an indicator for the efficiency in which the right ventricle is working. Because if the right ventricle is working well, it will automatically keep the CVP low. That is the systemic venous pressures low. And if the left ventricle is functioning efficiently, that will keep the pulmonary capillary wedge pressure low. So like a decent real-world example would be like the air quality index that we've been frequenting for the past couple of months. So that is basically an indicator for our air pollution level. And just to keep it on a lighter note, it is basically a measurement for efficacy of our very beloved Mahanagarpalika, which is very similar to our very hard-working right ventricle and left ventricle. So CVP is a reflection of the right atrial pressure, and based on a lot of assumptions and conditions based on whether it is in the right position, whether the pulmonary vascular resistance is normal, and whether the mitral valve is working perfectly fine, then we can use it as an indicator for left ventricular end diastolic pressure as preload as we know it. However, we would probably be mocked if we used the CVP today as a static, perfect indicator for fluid status. So should we just throw it away? So I just want to play devil's advocate for a moment and just say that probably absolute values of CVPs are useless in the long term, but a trend of the CVP would give us an idea intuitively of what the right ventricular function actually is. So we should rather look at the CVP trend rather than the absolute values. So the pulmonary artery pressure monitoring is basically through a Swan-Ganz catheter, which is a balloon-tipped catheter which is floated through to the pulmonary artery, which we can wedge into the pulmonary artery in order to get something known as the pulmonary capillary wedge pressure, which I'll be talking to about in a moment. So the latest iteration of the pulmonary artery catheter has a module for continuous mixed venous oxygen saturation. And also, we can see from the tip about 15 centimeters, there is a thermal filament which will give us a reading of a continuous cardiac output monitoring, which is basically an advance from the intermittent fluid cold saline boluses that we were supposed to give earlier, which were giving an intermittent cardiac output monitoring. So this will give us a continuous cardiac output monitoring. So this is basically based off the fixed principle. The fixed principle in simple terms is basically that the oxygen consumption is the product of cardiac output and the arteriovenous difference in the blood. So we use this principle to determine the thermodilution using the Stewart-Hamilton equation. So basically it is following the fixed principle. So what I want you to remember is basically what comprises the numerator and what comprises the denominator. The numerator in the Stewart-Hamilton's equation is basically a product of the volume and the temperature difference between the cold injectate that we are giving and the blood. And the denominator is basically the area under the curve that we are getting from the thermodilution curve. So from this, you can gauge that if a patient is having a good cardiac output, we are expecting a steep rise and a steep fall of the curve. So what does this tell you? So because the area because of the steep rise and fall, the area under the curve will be less. So obviously the denominator will be less, so that will represent as a good cardiac output. So that is how we are using this technique for during pulmonary artery catheter measurement. And a poor cardiac output, similar to like how a Parvis at TARDIS would look like, will have a large area under the curve. So the denominator will be more, and therefore the cardiac output will be represented as a lower value. The insertion techniques and its pros and cons will be dealt with more in detail in the workshops. So it is basically we can use this as a representation for the right ventricular function, the left ventricular function, to determine pulmonary hypertension and its classification, and for cardiogenic shock. Now, why the holy grail of this is basically the pulmonary capillary wedge pressure. So what we are actually doing is that once we float the balloon into the pulmonary artery, we are basically wedging that part. And then once it's wedged, there is a static column of blood which trails from the pulmonary artery through the pulmonary venous system, ultimately which drains into the left atrium. So the left atrial back pressure is then transmitted back through the static column, which is read from the tip of the pulmonary artery. So that is what the value which we are getting is the pulmonary capillary wedge pressure, which we can use as a surrogate for the left ventricular end diastolic pressure for the left ventricular preload. So it has the same assumptions as the CVP, which is required, with that it needs a normal PVR, it needs a normal mitral valve in order to make this assumption. Now we have advanced into, as I said, that we can do a continuous cardiac output monitoring, a continuous mixed venous oxygen saturation monitoring, and this is possible with our hemosphere monitor. So this is an advance from the earlier iteration of the pulmonary artery catheter. So this is basically a pulmonary artery catheter transcutaneous dilution method of using it. So what we have advanced forward to is a transpulmonary technique of an indicator dilution method. So basically we have the PICO and our LEADCO for this. So we need this pulsiocath which is required, which we can use either in the radial artery or in the femoral artery. So how it works is that basically we need a CVP line instead of a pulmonary artery catheter, and the cold saline bolus is pushed from the CVP, and the changes in the thermodilution as similar to the pulmonary artery catheter is measured through this pulsiocath catheter, and which is recorded into the PICO system. LEADCO follows the same principle, however the indicator fluid instead of cold saline is lithium chloride indicator dilution. So the essence of this is that we are using a pulse contour analysis as well. So the thermodilution technique that we are using is basically used as a form of calibration, because the compliance and the SVR for every patient, the impedance of every patient will be varying amongst each other. So the thermodilution technique is only used as a form of calibration. So that is why this form is known as a calibrated form of pulse contour analysis. So pulse contour analysis is basically an analysis of the arterial waveform. So as we know that the upstroke of the pulse wave basically represents the contractility of this patient. The area under the curve of the systolic part of the pulse wave will represent the stroke volume, and the compliance is basically calculated using the Wind-Kessel property of the vessel. So what is the Wind-Kessel property? Is basically that, as you know, that the left ventricle is going to be continuously pumping blood into the body. Now we know that during diastole that the aortic valve closes. So, but that intuitively we know that during diastole as well that the aorta is obviously going to be continuously giving blood into the body, even though the aortic valve is closed. Why is this happening? Is because of the stored energy during systole. That once the aortic valve closes, this stored energy causes a propulsion or a forward motion of blood during diastole. This is basically what is known as the Wind-Kessel phenomenon. So the pulse contour analysis uses this phenomenon to calculate the compliance. It basically samples it for the first 20 seconds of analysis, and that is how it is able to determine the compliance for every patient. And this part, that is the calibration factor, is determined through the thermodilution, as I had stated earlier. So using an integral of all of these things is how we're able to get a continuous cardiac output monitoring via pulse contour analysis. This is the same as what I had said earlier. So this is basically an integration of both of these technologies. So what is the advantage? Basically, we get extra sets of parameters using the PICO. That is, the thermodilution parameters along with its cardiac output will also give us the global end diastolic volume, the intrathoracic blood volume, the extravascular lung volume, and the pulse vascular permeability index. And the pulse contour parameters are similar to what we would expect. So this is basically the property of it, that once we give the thermodilution fluid, the cold saline bolus from the CVP line, because it passes through all these mixing chambers, the PICO technology is allowing us to measure all of these chambers and all of these volumes individually to give us a better idea and a better representation of what our patient status is like. Now, I don't want to bore you much with the technicalities of this, but the only two things that we have to remember is that the mean transit time is basically the time from where we are injecting the cold saline bolus to when half the indicator has passed the point of detection in the artery. That is known as the mean transit time. So when we use this mean transit time to multiply it with the cardiac output is when we get the intrathoracic blood volume. And the downslope time is the exponential downslope time of the thermodilution curve. We basically multiply this with the cardiac output and we are able to get the pulmonary blood volumes. And then using simple algebra, we can basically determine the global end diastolic volume, the extravascular lung volume, and etc. The flow track system, this is an example of an uncalibrated cardiac output monitoring system using pulse contour analysis. That means we do not use the thermodilution technique in this. So how is it able to calibrate it, internally calibrate it for the patient? So what it does is that it based on the principle that the aortic pulse pressure, that is the difference between the systolic blood pressure and the diastolic blood pressure, it is basically sampled at the rate of about 100 hertz per second over the course of 20 seconds. So the machine is able to calibrate about 20,000 samples, and it is able to understand the stroke volume within those first 20 seconds based on the patient's demographics. And we have to obviously enter in the patient's age, gender, and body surface area. So this is an example of the Wind-Kessel phenomenon, which I had stated earlier. So this is the essence of pulse contour analysis for these patients. So along with the pulse rate, the standard blood pressure, which I had stated earlier, is computed through the difference between the pulse pressure of these patients. And the chief factor is the sampling which is done in the first 20 seconds. So it is the product of this which gives us the stroke volume for this patient. So that is how an uncalibrated system using only the radial pulse is able to give you a continuous cardiac output monitoring. So the later lectures will be going more about how we do this exactly. But just to give you in short, we basically see the cross-sectional area of the LVOT, and we measure the VTI using the pulse wave in the area of the LVOT, and its product will give you the stroke volume. And we have to multiply that with the heart rate, and that is how we get the cardiac output. So this is more of an intermittent thing that we have to use, because we have to continuously keep checking the VTI in order to get the value at that particular time. So the esophageal Doppler is able to overcome this problem because it is able to calculate the cross-sectional area based on the patient's demographics, and its VTI is going to be calculated continuously, and that is how we are going to be getting a sort of continuous cardiac output monitoring using the esophageal Doppler. The impedance cardiography is basically based off Ohm's law. So we have bioimpedance and bioreactance in this situation. So what basically Ohm's law is that once we give a known amplitude of current, we are able, then that is equal to the voltage difference across 2 points divided by the resistance. So we use that biologically by replacing the current with cardiac output, the voltage being the difference between the arterial side and the venous side pressures, and the resistance being the SVR. So we have 4 electrodes placed, 2 on the side of the neck and 2 at the end of the thorax. So the outer electrodes are basically the ones which are going to give a high frequency 4 milliamps current is going to be passed through this. So the property of current on itself is that it will always choose the path of least resistance. So inside the thorax, that path of least resistance is always going to be the blood-filled chambers or the blood-filled vessels, which in this case is going to be the descending thoracic aorta. So the current which will then pass through the descending thoracic aorta, and it is going to be measured through the inner electrodes. Now the caveat which is there here is that we know during systole there is more blood which is going to be present inside the descending thoracic aorta because of this ions and because of its plasma level. Because because of that, the resistance is going to be less, the impedance is going to be less, and the conductance is going to be more. So that means during systole, the impedance is going to be one value, and during diastole, the impedance is going to be another value. So the difference between this across time is how we're able to calculate the stroke volume in these patients, and that is how we're able to get a cardiac output monitoring in these patients. So the ECOM tube is special in this case because it has its own electrodes present inside the endotracheal tube, and because of its access to the ascending aorta anatomically, it gives us a better representation of the bioimpedance in these cases. So we have moved on from the bioimpedance to bioreactance in a similar vein as we have moved on from AM signal radio to an FM signal radio. So instead of going according to the amplitude that we use in bioimpedance, we are going according to the frequency and the phase reactance, because that gives us a better noise cancellation frequency. Basically, less artifacts will be present with bioreactance. Next is the partial rebreathing cardiac output monitoring. So the only things that I want you to remember here is that basically we have a rebreathing valve which will allow a certain phases where there will be carbon dioxide being introduced into the patient. So then there is a CO2 flow sensor, which will basically give us the numerator of the formula, which I'm going to show you now. That is the VCO2, and the mainstream capnostat, which will give us the EtCO2 in these patients. So this is based off the fixed equation. So we replace oxygen with carbon dioxide, and the principle works exactly the same. So the numerator is the VCO2, and the denominator is the CVCO2 and the CaCO2. Now, it is based on the assumption that during respiration, the cardiac output will not change in that particular patient. But the values of the VCO2 will change because we are introducing carbon dioxide via partial rebreathing. So when we use basic algebra for this, we are able to derive a formula where we get the numerator, that is VCO2, which was derived from the CO2 flow sensor, and the denominator, that is the EtCO2, is derived from our EtCO2 capnograph. So that is how we are able to get the cardiac output non-invasively in these situations. So this is just a graphical representation of that. So next is our clear side. It is, so just long story short, it uses a volume clamp method and a physiocal method. Essentially, it has an inflatable diameter at the tip of our fingertip, and its job is basically to keep the arterial volume static. So obviously, because our heart is pumping blood, the volume will be introduced into that supposed static blood, the arterial chamber. Now, in order to counteract that, there will be a counter pulsation pressure which is going to be introduced by this inflatable bladder, which is going to be detected by the photoplethysmographic method, and which is going to give us a representation of what the cardiac output or the cardiac status is in those patients. Next is the hypotension prediction index, which basically uses the EA-dyne, which is a representation of the afterload of the patient, the dP by dt, which is the contractility of the patient, and the stroke volume index, stroke volume variation for the preload of the patient. So basically, it moves us from a more reactive to a more predictive way of countering any hypotension in these patients. Last is the foresight, which gives us about tissue oximetry, which compared to the nerves, which uses only 2 precise wavelengths, this will use 5. So mainly because cerebral desaturation has been associated with decreased survival, especially in cardiac patients. So this is another way of going about this. So I just want to end my talk by saying that technology is moving forward, and we should be able to work with it so that we are able to work well with our patients and do justice for them. Thank you.
Yeah, nice presentation. A lot of information squeezed in a small list. Very nice. So we'll take the questions later, I think. So we move on to the next session now.
Thank you. Just wait, let me felicitate you. Okay. I request Dr. Manoj to kindly felicitate our speaker, Dr. Jalaram, please. I request chairpersons to kindly introduce our next speaker.
Good morning, Dr. Meenal. Introducing Meenal, we have long association back to 2005. She was cardiac anesthetist at Apollo Chennai and very experienced cardiothoracic anesthetist and heart-lung transplant anesthetist. Now she is working at HN. Back to Meenal. Thank you.
Good morning, everybody. I would like to thank Dr. Saurabh and ACTA Mumbai for giving me this opportunity. The topic for today is hemodynamic monitoring in shock, LVAD, and transplant. Starting with advanced hemodynamic monitoring in cardiogenic shock. Cardiogenic shock is a state of critical end organ hypoperfusion due to inadequate cardiac output despite adequate intravascular volume. The mortality remains very high, approximately more than 40%. So advanced monitoring is useful in diagnosing the type of shock, in quantifying the severity of the shock, differentiating between LV failure, RV failure, mixed shock, or vasoplegia, in guiding the therapy of fluid, inotropes, vasopressors, diuretics, mechanical circulatory support, to assess response to the therapy and to predict prognosis. Modern management depends heavily on early hemodynamic phenotyping and repeated reassessments. Before invasive monitoring, initial bedside assessment of the clinical features like cold clammy extremities, altered mentation, oliguria, elevated JVP, pulmonary edema, narrow pulse pressure, and mottling. Basic monitoring includes ECG, pulse oximeter, urine output, arterial BP, lactate, ABG, and VBG monitoring. As discussed earlier, the early assessment, we can use non-invasive modes like echo and non-invasive cardiac output monitoring. For continuous trend, arterial line and pulse contour cardiac output monitoring can be used. However, PAC and Schwann-Ganz remains a gold standard. Arterial line provides beat-to-beat blood pressure monitoring, accurate mean arterial pressure, vasopressor titration, and pulse contour analysis. Non-invasive blood pressure often overestimates BP during shock. Various waveform interpretations like narrow pulse pressure indicates severe LV dysfunction, pulsus alterans indicates LV failure, steepness of the upstroke reflects the LV contractility. Central venous catheter provides CVP, central venous oxygen saturation, vasoactive axis. Low central venous oxygen saturation indicates low cardiac output and high oxygen extraction. Echocardiography is the most important tool, initial tool. Guidelines strongly recommend early echo in all the cardiogenic shock patients. The critical role of ECMO is in identifying rapid evaluation of LV, RV systolic function, valvular lesions, tamponade, mechanical complications, and volume status. In case of LV failure, there will be reduced EF, regional wall motion abnormalities. In RV failure, RV will be dilated, septal flattening, reduced TAPSE. Mechanical complications like acute MR, ventricular septal defect, free wall rupture can be identified. And dynamic assessment includes LVOT, VTI, IVC variability, and fluid responsiveness. Pulmonary artery catheter supports management in severe cardiogenic shock. It helps us to differentiate various types of shock. The measures include mean right atrial pressure, CVP, pulmonary artery pressure, wedge pressure, SVO2, cardiac output index, PVR, and SVR. Cardiac power output is one of the strongest prognostic markers. The value of less than 0.6 volt indicates poor prognosis. Similarly, pulmonary artery pulsatility index is used for RV failure. Low index suggests RV dysfunction. Advanced volumetrics like PICO system, transpulmonary thermodilution system measures continuous cardiac output, SVV, global end diastolic volume, extravascular lung volume, and SVR. Global end diastolic volume is a superior preload marker compared to CVP. Extravascular lung volume quantifies pulmonary edema. High levels indicate cardiogenic pulmonary edema or ARDS. Stroke volume variation is a dynamic fluid responsive marker, but it is reliable only with controlled ventilation in sinus rhythm and no spontaneous breathing. The limitations include they are less reliable in atrial fibrillation, frequent ectopics, severe AR, and spontaneous breathing patients. SKY classification of cardiogenic shock divides into 5 stages, and advanced monitoring usually becomes increasingly important from stage C onwards. Hemodynamic determines the timing and choice of mechanical circulatory support which can be used. For example, high wedge pressure and low cardiac index, the solution is LV unloading is required. In RV failure and low pulsatility index, the solution is RV support. Whereas in severe biventricular failure, full circulatory support is needed, like VA ECMO. So the points to remember is to treat the patient and not the monitor. Hemodynamic values must always correlate with skin perfusion, urine output, lactate, mentation, and echo findings. Modern cardiogenic shock care uses an integrated approach as multinodal monitoring, shock teams, early invasive assessment, and phenotype-directed therapy. So these will improve, the integrated approach will improve the survival. Coming to advanced hemodynamics in LVAD patients. Left ventricular assist device are mechanical circulatory support devices used in advanced cardiac failure patients as a bridge to transplant or bridge to destination or recovery. Modern continuous flow LVADs profoundly alter the cardiovascular physiology, rendering conventional pulsatile hemodynamic assessment unreliable. The normal pulsatility is lost, as a result of which there is absent or weak peripheral pulses, the non-pulsatile arterial waveform, standard non-invasive BP cuffs are often ineffective, and hence mean arterial pressure becomes a perfusion parameter. The principle of continuous flow include they are preload dependent. LVAD flow is entirely reliant on the venous return. More the venous return, more is the LVAD flow. Hypovolemia drastically reduces flow, directly precipitating catastrophic suction effects. The second principle is it is afterload sensitive. Elevated systemic vascular resistance creates a wall against a continuous pump. Hypertension severely impairs LV unloading and reduces the cardiac output. There is RV-LV interdependence. The right ventricle is the primary motor feeding the LVAD. Right ventricle dysfunction immediately starves the LV, dropping the pump flow. So we start with the arterial monitoring. Continuous invasive arterial pressure monitoring is an absolute requirement. The target map is 65 to 85 mm mercury. However, avoid map above 90 mm mercury because excessive afterload, that is hypertension, actively reduces the LVAD flow and impairs myocardial recovery. Radial waveforms are frequently dampened due to low pulsatility, and hence femoral arterial access is preferred. Pulmonary artery catheter is indispensable for advanced LVAD management, specifically during implantation, RV failure, cardiogenic shock. The goals would include CVP less than 12 mm mercury, wedge pressure between 10 to 18, minimize the pulmonary vascular resistance, and cardiac output above 2.2 liters. Rising CVP indicates RV failure, volume overload, pulmonary hypertension, or tamponade. SVO2 and RV stroke work index are initial markers of forward flow and RV reserve. Transesophageal echocardiography is a cornerstone of perioperative LVAD monitoring, mandating continuous use during implantation and major procedures. So, TE assesses the cannula position and the alignment, the left ventricular function, the right ventricular function, the septal position, aortic valve opening frequency, if there are any intracardiac thrombus detection, pericardial effusion, and tamponade. The septal shift towards the left indicates RV failure, and septal shift towards the right indicates either hypovolemia or suction effect. Coming to the console parameters, there are mainly 4 parameters which are to be observed. First is the pump speed. This is a fixed variable set by the clinician. It determines the operational baseline. Pump power, it is the energy required to maintain the revolutions. High power consumption is a red flag warning for impending pump thrombosis. Pump flow is estimated value derived from the power and speed. Low flow alerts to hypovolemia, RV function, tamponade or obstruction. Pulsatility index is a measure of native cardiac contraction against continuous flow. Low pulsatility index indicates reduced preload or excessive unloading. Sudden pulsatility index drop suggests suction events or arrhythmias. Special mention about the HeartMate 3, which is the more recently used heart LVAD. It has a technology which utilizes full maglev flow technology, eliminating the mechanical bearings, and hence it reduces the blood trauma. There is a featured program of artificial pulse designed to prevent stasis and washing the pump. The pump automatically drops and increases the RPM rapidly on a fixed cycle. This creates a distinctive washing artifact on the arterial line, and it should not be confused with our usual pulsatility waveform. RV failure is a leading cause of morbidity and mortality following LVAD implantation. RV must pump blood through the lungs to fill the left heart and feed the device. So the diagnostic triad includes elevated CVP, low LVAD flow, dilated RV on TEE with severe tricuspid regurgitation, and secondary signs of hepatic congestion and worsening renal function. So the management includes avoiding both hypovolemia and right-sided volume overload, and aggressive utilization of pulmonary vasodilators, for example, inhaled nitric oxide. And the RV should be supported with milrinone or dobutamine, and it should be escalated to RVAD if the medical treatment fails. Static variables like CVP and mean arterial pressure are insufficient in isolation. The ultimate goal is the end organ perfusion. So hemodynamic tools like passive leg raising to assess the volume responsiveness, stroke volume variation and TE-guided LV cavity measurements, and real-time trends in LVAD flow in response to interventions. Tissue perfusion markers like NIRS and global markers like serial serum lactate, continuous urine output, SVO2 tracking, and trending the renal and liver functions are useful. Hemodynamic emergencies which arise with LVAD are, first is the suction effect. It is because of hypovolemia or excessive pump flow. The TE findings include small LV cavity and the rightward shift of the septum. Second is the pump thrombosis. It causes spikes in high consumption of power. The LVAD flow reduces and there is hemolysis. Tamponade causes increase in the CVP, drop in the LVAD flow, and pericardial effusion. RV failure also creates high CVP, and there is a drop in the LVAD flow, and there is congestion of the organs. So the intraoperative anesthesia goal include maintain preload, that is aggressively targeted volume management, control the pulmonary vascular resistance, strictly avoid hypoxia, hypercarbia, acidosis, which spike the pulmonary resistance, preserve the RV function by judicial use of inotropes and optimization of systemic pressures, rhythm control, maintain the sinus rhythm as the arterial cake provides up to 30% of LV filling, and to maintain the vascular tone. Future directions are implantable wireless hemodynamic sensors for continuous PA pressure tracking, AI-guided LVAD optimization algorithms adjusting speed to real-time physiology, advanced pressure volume analysis integrated directly into tele-ICU systems. To conclude, management mandates a multimodal approach of invasive lines, TE, console data, and end organ markers. Continuous flow demands precise control of preload, RV, reserve, and afterload, and success relies on anticipating and preventing the cascade of suction, thrombosis, and right heart failure. Coming to heart transplantation. Heart transplant is hemodynamically the most challenging for cardiac anesthetists. The anesthetist must be able to manage the end-stage heart failure physiology in the recipient, sudden transition from native failing heart to donor graft, pulmonary hypertension, right ventricular dysfunction, effects of CP bypass, vasoplegia, reperfusion injury, and risk of primary graft dysfunction. Conventional monitoring alone is incomplete as there are rapid physiological shifts. The RV can deteriorate suddenly, and early detection of primary graft dysfunction improves the survival, and hence advanced monitoring is required. The recipient heart can be either dilated or ischemic cardiomyopathy, severe pulmonary hypertension, elevated filling pressures, poor cardiac output and poor reserve, and hence dependence on ionotropes and mechanical circulatory devices, and chronic catecholamine exposure which predisposes them to severe hypotension. Post-implant, the heart is completely denervated, highly preload dependent. The cardiac output depends on the preload and the circulating catecholamines. It is unable to increase the heart rate via autonomic reflexes. Bradycardia is poorly responds to atropine, and it requires direct pacing or specific inotropes like isoprenaline. So the hemodynamic goals are to optimize preload, contractility, RV function, coronary and systemic perfusion, to prevent RV failure, pulmonary hypertension crisis, low cardiac output, and primary graft dysfunction. Early detection of anastomotic problems, tamponade, vasoplegia, air embolism, and graft dysfunction. Coming to the monitors, 5-lead ECG with ST analysis is important to detect ischemia, which can be associated either because of increased ischemic time or poor protection, or because of perfusion injury. Arterial pressure monitoring, CVP monitoring. Pulmonary artery catheter is essential for severe pulmonary hypertension, RV dysfunction, and mechanical support. It measures pulmonary artery pressure, wedge pressure, cardiac output, SpO2, and PVR. High PVR is the single biggest predictor of post-operative RV failure. Increase in CVP and pulmonary artery pressure indicates RV dysfunction and pulmonary hypertension. Increase in the wedge pressure indicates LV dysfunction and volume overload, and reduce in the SvO2 indicates low cardiac output. There are limitations to pulmonary artery catheter use as arrhythmias during insertion, rare but pulmonary artery rupture, and the static parameters are imperfect indicators. In spite of this limitation, it is favored among the cardiac anesthetists. TEES is the most important intraoperative tool. It is used for real-time cardiac function assessment, dynamic volume status evaluation, direct anastomotic assessment, and immediate detection of surgical complications. Before the native heart is explanted, it is used to assess the RV and LV function, evaluate any valvular lesions, patent PFO, identify intracardiac thrombus as it changes the surgical strategy. Severe RV dysfunction predicts difficult bypass separation. Post-grafting, it is used to assess the LV function, the ejection fraction, the regional wall motion abnormalities, and the filling pressures. Right ventricle is the most crucial, monitoring for dilatation, septal flattening, reduced TAPSE, and severe TR. The donor RV is suddenly exposed to elevated recipient pulmonary pressures, as a result of which the RV dilates and the pressure overload, it bows the interventricular septum into the right ventricle. This bowing septal shift causes reduced LV filling, reduces the cardiac output, and reduces the coronary perfusion, and causes hypotension. Coming to mechanics of vasoplegia, it is commonly after CP bypass, chronic heart failure, and AC inhibitor exposure. The systemic vascular resistance falls markedly. Patient experiences profound vasodilatation and hypotension. Mean arterial pressure decreases dangerously in spite of normal or high cardiac output. It is very important to differentiate vasoplegia from the graft failure. In vasoplegia, the cardiac output can be normal or high, but the SVR, MAP, and CVP is usually low, whereas in primary graft failure, the cardiac output and the blood pressure are low, whereas the SVR and wedge pressure are markedly elevated. Primary graft dysfunction is severe ventricular dysfunction occurring within 24 hours of transplantation. It can be either LV failure, RV failure, or biventricular failure. The clinical signs include hypotension, low cardiac output, raising lactates, poor contractility on TE. Early recognition dictates survival. Mechanical support is an option if there is severe pulmonary graft dysfunction, either VA ECMO to give full support, RVAD only for isolated right ventricular failure, or IABP, which will improve your coronary perfusion and reduce the afterload. The recent advances are 3D TE, which improves RV assessment, highly detailed valve visualization and volumetric analysis. Strain imaging detects subclinical myocardial dysfunction and early graft impairment, potential for non-invasive early rejection detection. Artificial intelligence predicts hypodynamic collapse before the clinical signs appear, enables early shock detection and automated echo interpretation. So to summarize, before CP bypass, a thorough assessment of baseline pulmonary hypertension, optimize native RV function prior to explant, and verify all invasive monitoring access. During separation from CPB, intense focus on new RV function and pulmonary artery pressure, assess dynamic volume status and emerging vasoplasia, evaluate initial graft contractility, and after separation, continuous reassess TE and PAC trends, monitor lactate, SVO2, and titrate vasopressor requirement. Post-op ICU, the hemodynamic handoff is continuous arterial pressure, CVP and PAP tracking, cardiac index and SVO2 monitoring. Serial echocardiography evaluates ongoing ventricular recovery, scans for pericardial effusions. The goal is to early detection of rejection, tamponade, RV failure, bleeding, and arrhythmias. So the core takeaways include TE and PAC remains central. No single monitor provides full picture. The RV dictates survival. Right ventricular failure remains a primary driver for early mortality. Prompt early recognition of PGD and vasoplegia dramatically improves survival. Monitoring data is only valuable when it directly guides specific clinical decision making. Continuous assessment of changes outvalues isolated medical numerical readings. Thank you.
Excellent presentation, madam. You have covered entire aspect of the topic. I think organizers are short of time, so question answer will be later.
Any questions from the audience?
I request Dr. Devendra to felicitate Dr. Vora ma'am. पुढे देवेंद्र देवेंद्र Okay, now we'd like to felicitate our chairpersons. May I request Dr. Uday Gandhi sir to felicitate Dr. Sanjeev Jadhav. Thank you. Thank you, sir. May I request Dr. Samir to felicitate Dr. Devendra? Come. Thank you. I request Dr. Saurabh to felicitate Dr. Yogesh.
So Dr. Yogesh has come all the way from Nagpur, and I really appreciate his spent time for us. And he is my hostel mate from UG times.
Thank you, Dr. Saurabh. I request Dr. Shwetali to felicitate Dr. Manoj. Thank you, Dr. Shwetali. With this, we come to an end of our first session. So thank you, chairpersons, for chairing this session.
Our MMC observer, Dr. Varsha Vyas, is with us. I would request Dr. Roshna madam to please felicitate Dr. Varsha ma'am. Please, madam, please come on stage. After this, we'll have a BD session where the BD people will just give out 5 minutes video regarding the session. Please, madam. Both Varsha madam and Roshna madam are our teachers from DY Patil. There will be no tea break, so if somebody would like to have a tea after the BD session, they can continue. We will continue with the session continuously.
Done, ma'am. So good morning, everyone. Myself Ritesh Gupta from BD APM, formerly part of Edwards Life Sciences. So first of all, I would like to thank ACTA Mumbai and especially Dr. Saurav sir for giving us the opportunity to present over here. So I'll quickly take you all through these slides as we have only 10 minutes. So to start with, I'll just start off with the video, which is a very small video, around 2 minutes. So basically, what is the requirement? Why there is a need of monitoring? So as we have seen in few clinical papers, there are certain clinical papers which are stating that around up to 15% of the cardiac surgery patients may have more than one complications, and up to 40% of the patients can come across acute kidney injury. Also, there is a certain paper which is stating that almost 2 out of every 3, which is approx around 68% of the cardiac surgery patients with multiple major post-op complications may have an associated prolonged length of stay. And as we all know that cerebral desaturations are very common in cardiac surgeries, so there are multiple number of clinical papers, right from Yaw, Martin, which are stating that the patient incidence of desaturations during the cardiac surgeries are relevant. Some studies are showing around 90%, some are saying 73, 56. So even if we take the mean of all these studies, so approx 59% mean desaturations are occurring across the studies which have been shown into this particular slide. And why it is important? Because the cerebral desaturations are very critical, as it almost increases the risk of developing POCD 8 times within the first week of surgery, as well as there is an increase of 30-day increase in mortality risk with mean bypass of SO2 under 63%, which ultimately results in the higher length of stay in the hospital. And is it treatable? Yeah, it is very much treatable. Reversing cerebral desaturation leads to improved outcomes. And there are certain clinical papers. There was a clinical trial which was done in comparison to the intervention group as well as the control group. And the finding which they have found is that in the control group, the incidence of congestive decline was very much higher as compared to the intervention group, as well as the length of stay was very much lesser in the intervention group as compared to the control group. So goal-directed fluid therapy protocol can reduce the risk of AKI after cardiac surgery. And as stated in the earlier slide, around 40% of the cardiac patients, surgery patients experience AKI. And out of those, up to 60% of mortality in patients with cardiac surgery associated with AKI requiring dialysis. So the evidence for PGTT in cardiac surgery is growing, and if we talk about, there was a study, around 50 studies with 14 plus meta-analysis were done, and what they have found, the conclusion was that around 60 to 70, there was a reduction in 60 to 70% of the patient in the morbidity, and around 1 to 5 days of reduction in the length of stay when they were using the PGTT in cardiac surgeries. So it's the same slide which talks about the PGDT as mandated by ERAS cardiac surgery. As we all would agree that hypertension is very much relevant in cardiac surgeries as well. There were certain clinical papers like Sun by Hassel and by Aronson, which all are saying that hypertension is very much relevant in the cardiac surgeries. So as we have the monitor called as Hemosphere. So on that you can have all the 3 things, right from the preload, which will, with the help of stroke volume variation, then the contractility, the new parameter which has just come, dP by dt, and the afterload as well, with the new parameters called as EADYNE, the dynamic arterial elastance. So do we have any clinical evidence? So yes, we have multiple clinical evidence in cardiac surgeries as well. This is with relevance to the PGDT in cardiac surgery. There was a study, a randomized control trial done, and they have found that there was a reduction of around 17% in the morbidity and the reduction of almost 2 days in the length of stay when the PGDT was followed in those kind of cardiac surgery patients. So the new parameter which you know, you must have heard about the HPI, hypertension prediction index. So we do have clinical papers in cardiac surgery as well. There was a clinical paper done with the name of use of hypertension prediction index during cardiac surgery. The conclusion was that the HPI predicted hypertension episodes during cardiac surgeries with a high degree of sensitivity and specificity. So what are the options which we have in all across? So right from the OR to the ICU, you can, the monitor can be used Hemosphere all across. And these are the product range which we are having right from non-invasive to minimally invasive to invasive. So in non-invasive, we have two sensors which are called as clear sight, which works on the volume clamp method. And the second one is the Acumen IQ curve, which works on the arterial waveform analysis with the help of the machine learning algorithm. So you'll get all the cardiac output, stroke volume variation, including the HPI, DP by DT, as well as EA dyne, non-invasively. Then in minimally invasive, we have two sensors, which are termed as flow track sensor, which almost most of you would have used it by just connecting it to the existing art line. And then the higher version of that, which is Acumen IQ, which works on artificial intelligence and gives you 3 additional parameters named as HPI, DP by DT, and EA dyne. And in invasive, we have the gold standard, which are the Swan-Ganz catheters. In Swan-Ganz also, we have multiple range in Swan-Ganz. The advanced one is called as Swan-Ganz Combo V, with the help of which you will get continuous cardiac output, mixed venous oxygen saturation, plus the end diastolic volume and right ventricular ejection fraction. So these are the options which are available with us. And as it is wise saying that it's not the monitor or the device that makes the difference, it is the clinicians and the decisions he or she makes with the information provided that change the patient's outcome. So thank you very much for this opportunity. Thank you.
Thank you, BD, our main sponsor. I will request Dr. Sanjita Madam to please felicitate Mr. Vimal. He's from our BD senior person. And I will request Dr. Uday to please felicitate Ritesh from the BD. Please come on the stage. After this, we will proceed for our inauguration. I will request all the ISA office bearers as well as our ACTA office bearer to please come forward for the inauguration. Before that, I would like request our ACTA President, Dr. Sanjita Madam, to speak few words about our ACTA and our activities. Please, ma'am, come on the stage. A big clap for our...
Good morning, everyone. I welcome on behalf of ACTA Mumbai to all the delegates and faculties and senior members over here. So as the theme is suggesting that the probe to pulse, but then I was thinking why it is not pulse to probe, because all the information is going from the hand on the pulse to the probe, then why it is in the reverse direction? So maybe a new generation is thinking like that, the probe is telling us what pulse is saying, but we are from the middle generations where we used to have a hand on pulse. Our teacher used to say, how is the volume, what is the rate, have you calculated for a minute? So that is why that was my thinking. So why all these academic activities of ACTA Mumbai There are certain hospitals and teaching institutes, they are coming forward and they are doing these academic activities. And one of the very informative and important activity of today, it is a hemodynamic monitoring from the non-invasive to the minimally invasive and to the most invasive like CCO catheter with the Swan-Ganz catheter. So it is necessity nowadays to have information whether it is a cardiac surgery or non-cardiac surgery, how it is implicated to the this monitoring to the patient, because now the lifespan or the life expectancy has increased up to 75 years in all Indian individuals. So they may come up after the cardiac surgery is getting done, whether it is a CABG or an angioplasty or a wall implantation or a wall replacement, then the grown-up cardiac congenital heart diseases, whether they are repaired or unrepaired. So we should have a well-versed with the hemodynamic monitoring, that is advanced hemodynamic monitoring with having the artificial intelligence. Here, one question to the Edward, that when they are saying that there is a HPI which is predicting the hypotension even in cardiac surgeries, so they should also come up with the some app or some app base that this information go to the app and it will tell you what is the incidence of the AKI or the other system injury in this particular patient. In whatever has happened, but then what is the incidence? So we can intervene in the before that, like if suppose AKI predicting AKI, but if we come to know that there is a 2 to 4% risk is there in this patient because of all these hemodynamics, so we can intervene earlier. And I think that should come to Edward people, Vimal. So you should come up with the thing that you should predict in that particular patient to patient, because you are having this data, you have a hypotension prediction in. So that's why. Okay, thank you, and thanks Dr. Saurabh for giving me opportunity to share my words, and thank Apollo Hospitals for giving an opportunity to conduct this ACTA Mumbai activity. Thank you.
So this is the first program in Navi Mumbai where both ACTA and ISA have come in collaboration to bring a good academic program for all of you students. I would like to invite now the ISA President Madam to just speak few words about the ISA activities in Navi Mumbai. They recently conducted a plantation drive on the Environment Day yesterday, and it was a widely acclaimed program for a good cause.
Good morning, everyone. Welcome you all for this wonderful CME. First of all, I want to congratulate the organizing team for conducting such a good CME, mainly focusing on the recent advances in anesthesiology and critical care. On behalf of the Managing Committee of ISA Navi Mumbai, congratulations again. As we all know, the healthcare system is evolving day by day. The newer drugs, newer instruments, and newer skills. So it is very essential for all of us to improve our knowledge for the better and the safer patient care. But as Madam said, never to forget the pulse. Always the best monitor is the vigilant anesthesiologist. So it is a very good opportunity for all of us to improve our knowledge by so many CME lectures and the hands-on workshop by the best of faculty. And about Navi Mumbai branch of ISA, we are conducting many academic and non-academic events like webinar, CME, and conferences and calls. And also, our aim is to improve the quality of anesthesia practice for the patient and well-being of the anesthesiologists. We have conducted many non-academic activities also, like last week we had World Environment Day trek and the tree plantation, as Dr. Saurabh said. And in the near future, on Blood Donor Day, we are planning to conduct the blood donation camp. And on World Yoga Day, that is on 21st June, also we'll be celebrating. I request all of you to actively participate and support us. So anyway, this is a great opportunity for all of us to learn the hands-on skills and improve our knowledge. So best wishes to the organizing committee and all the delegates. Thank you.
So our most wanted person, Dr. Vishwas, has just came, our Secretary ACTA. I would request all the office bearers of ACTA and ISA to come forward for the inauguration, please. Dr. Uday sir, please accompany them. I would request Uday sir to do the honors of felicitating the ACTA post holders. Dr. Uday sir will please felicitate Sanjita madam. would request Dr. Vishwas to please come on the stage. Dr. Uday will felicitate. Dr. Amish, please come on the stage. विश्वास सर इनको देखिए आप खड़े रहो सर सर ये अमीश सर I will request Jessie Madam to please come on the stage to felicitate ISA post holders. Please. Dr. Olivina Madam, please come on the stage. Dr. Anjana, please come on the stage. Dr. Manoj, you also be there on the stage. After this, we are starting the session, the interesting session. Dr. Namrata will be talking about the cath lab adventures. It will be a very interesting session where we will discuss about all the cath lab procedures and the structural heart disease procedures where we come to see various complications. Dr. Namrata, you ready? For these sessions, I will request the chairpersons, Dr. Uday Gandhe, Dr. Vishwas Sathe, Dr. Sachin Sanagar, Dr. Amish, and Dr. Sanjita to please come on the stage.
Thank you, Saurav, Leena, and the team, and thank you, ACTA Mumbai, ISA, Navi Mumbai, for the nicely organized session on Sunday. The first lecture is by Dr. Namrata Kothari. Never seen a passionate cardiac anesthesiologist working in cath lab like her. She is very much interested in cath lab procedures and structural heart. So over to you, Namrata.
Good morning, everybody, and thank you, IACTA and ISA committee for inviting me to present this topic at this conference. So today's my topic is cath lab misadventures in structural heart interventions. So this allows learning from the complication, near misses, and unexpected challenges. Why should we discuss the misadventures? Structural interventions are increasingly complex. Complication can occur despite meticulous planning. Early recognition and multidisciplinary teamwork improves the outcome. Sharing experience prevents the reoccurrence. Every complication is a lesson disguised as a challenge. Now, structural heart interventions, as you all know, includes transcatheter aortic valve replacement, mitral valve replacement, mitra clip, tri-clip, valve-in-valve, valve-in-ring procedure, ASD, VSD, left atrial appendage closure, device closure, and paravalvular leak closure. Now, cath lab misadventures can be categorized like patient-related, device-related, vascular, and team related or imaging related. So patient related are arrhythmias, coronary occlusion, annular rupture, air embolism, anaphylaxis. Device related are device embolization, malpositioning of the device, or failure to deploy device. Vascular are perforation of the vessel or bleeding from the vessels. T is very important to carry out all the structural interventions, so improper window of the TE and unable to visualize the leaflets properly can lead to malplacement or inadequate capturing of the leaflet, leading to the various complications. Inappropriate measurements of the TE can lead to oversizing or undersizing of the device. Team-related complications can be communication failures or equipment unavailability. Now coming to the most common misadventures in the structural heart arena is arrhythmias. During TAVR, when you are deploying the valve or pre-dilating the valve, annulus, or post-dilating after the valve placement, there is a possibility of compression of AV node, bundle of His, and left bundle branch, leading to the new onset left bundle branch block, AV block, complete heart block, bradyarrhythmias. While performing the procedures, wires and catheters within the LV can cause ventricular tachycardia, ventricular fibrillation, while wires in LA or RA can cause supraventricular tachycardia and atrial fibrillation. During valve deployment, there is a possibility of the coronary occlusions. If it happens so, it can cause ventricular tachycardia, ventricular fibrillation, bradyarrhythmia, and asystole. Now, during the TAVR, if new onset LBBB is very common arrhythmias, but if it happens so, it is asymptomatic, no treatment is required. Complete heart block, if it develops, immediate temporary pacing is required, and if it persists for longer period of the time, permanent pacemaker should be implanted. Ventricular arrhythmias due to wires and catheters are temporary, but if it persists, defibrillation is required. Atrial fibrillation during the transeptal puncture is very common. If it is temporary, no treatment, permanent antiarrhythmic drugs and defibrillation is required. During the valve deployment, there is a possibility of the coronary obstruction. If it happens so, can lead to the fatal ventricular tachycardia, ventricular arrhythmias, and you may require defibrillation plus CPR. So every structural heart intervention should be performed with immediate pacing capacity and clear strategy for managing the conduction disturbances, as arrhythmia can range from benign ectopic beats to fatal heart blocks and ventricular fibrillation. Now coming to the mechanism of most fatal complication that you see during the TAVR is coronary obstruction. Mortality is as high as 40 to 50%. So why it happens? During valve placement into the native annulus, during native TAVR, the displacement of the calcific leaflets can cause coronary obstruction. In case of valve-in-valve TAVR, the upward displacement of bioprosthetic leaflets creates a cylindrical cage and seals off the coronary blood flow. At times, device protrusion into coronary ostia can cause coronary occlusion. Calcium spicule embolizing into the coronary vessels can lead to coronary embolization. Aortic root hematoma due to annular injury can cause coronary obstruction. Now, as an anesthesiologist, one should know to read CT image and CT findings to identify high-risk anatomy for transcatheter aortic valve replacement. So key CT findings that is important for anesthesiologists to know is aortic annulus size, coronary heights, ST junction diameter, and sinuses size. So the high-risk anatomy for transcatheter aortic valve replacement is small aortic annulus. lowest available size of the valve, if the size is bigger for the small aortic annulus, there is a possibility of patient prosthetic mismatch leading to the annular injury. So in such cases, self-expanding valve placement is better and can prevent the annular injury as compared to the balloon expandable valve. Now, it is important for anesthesiologists to know the coronary heights. From annular plane, left and right coronary ostia height is measured. If it is less than 10 millimeter, there is a possibility of the coronary occlusion because the valve skirt height is 8 millimeter, which is through which the blood cannot pass. The other thing is narrow sinuses. If sinuses are narrow and you place a new valve into it, the native valve leaflets get displaced upwards and it can obstruct the coronary ostia. Narrow sinutubular junction. If there is a narrow annulus and narrow sinutubular junction, it can cause sinus sequestration and obstruction to the coronary blood flow. Apart from the other parameters like valve to coronary distance, valve to STJ distance, leaflet height versus coronary height, and calcium distribution across the annulus and across the leaflet is very important to know for pre-procedural planning. Now, if the coronary obstruction do happen during the valve displacement, you will see sudden hypotension, ventricular arrhythmias, severe LV dysfunction, and even cardiac arrest. So as an anesthesiologist, you should be ready to escalate the vasopressures, start CPR, defibrillate, and reconfirm the findings with the TE. Now, what is a possible preventive strategies that cardiologists can do to avoid the coronary obstruction is most popularly known as a chimney stenting. So what do they do is when they expect the coronary is going to get obstructed, they place the wire and park the stent beforehand into the coronary and then deploy the valve. And after the valve deployment, if the coronary obstructions happens, they pull the stent to the ostium through the leaflet, expand the stent, and re-establish the coronary blood flow. Other pre-planning can be a basilica procedure. It is an electrocautery procedure. The full form of the basilica is bioprosthetic aortic scallop intentional lacerations. So through using electrocautery, we split the aortic valve leaflet into two, so V gap is created. And through this V gap, coronary gets perfused. So coronary occlusion can be prevented. Now this is one of the case where it was valve-in-valve tower, where there was a possibility of the right coronary artery obstructions, and it was prevented by doing a chimney stenting. So first fluoroscopic images shows bioprosthetic valve in situ, and right coronary artery flowing normally. Now here the right coronary height was 7 millimeters. So it was anticipated that right coronary can get occluded after the valve placement. So in second image you see the wire placed into the RCA. In third image you see the stent already placed, wire and stent parked into the right coronary artery, and the valve is deployed. As the valve got deployed, right coronary got obstructed, anesthesiologist got busy with resuscitating the patient and CPR, while the cardiologist placed the stent into the right coronary artery, and right coronary blood flow was re-established, patient's life was saved. Another risky complication is annular rupture. Usually it happens when aggressive valve oversizing is done, or annulus is very calcific. Dilatation of such annulus can cause annulus rupture. So signs will be, patient may develop sudden hypotension, pericardial effusion, pulseless electrical activity arrest. On TE, you will find pericardial effusion and extravasatation. Management is pericardiocentesis, hemodynamic resuscitation using blood transfusion, cardiopulmonary bypass, and emergency surgery. Catastrophic pericardial tamponade can occur during the structural heart intervention, especially during the transeptal puncture, left atrial appendage closure, mitral interventions. It can, if we create an RV injury and at the time of annular rupture. On TE, there will be a rapidly enlarging effusion will be seen, RV diastolic collapse will be seen. Clinically, patient will be having a high CVP, hypotension, tachycardia, and pulseless electrical activity. Management is pericardiocentesis, blood transfusion, reversal of the anticoagulation, and emergency surgery. Device embolization can occur anytime. It is more common with the ASD device closure. Contributing factor is deficient ream, improper sizing of the device, and excessive manipulations. So now it has to be retrieved percutaneously. If you can't retrieve the device percutaneously, surgical exploration is required. Device embolization can be seen with the valves, clips, and occluders also. If aortic valve gets displaced into the aorta, it can cause aortic obstruction. If it displaces forward, it can lead to LVOT obstruction. Malplaced aortic valve can cause severe regurgitation and hemodynamic collapse. So snaring and removing of the valve or surgical retrieval of the valve along with emergency bypass support during the when the complication happens is needed. LVOT obstructions mainly seen in transcatheter mitral valve replacement. Risk factor associated with LVOT obstructions are small LV cavity, long anterior mitral leaflet, septal hypertrophy. So these are the predicting factors where the LVOT obstruction is more likely. Patient may develop severe hypotension despite good EF, and there may be a dynamic obstruction which worsens with the inotropes. Treatment is a volume resuscitation, beta blocker, reduce the inotropes, and if hypotension persists, put in on ECMO. Acute severe regurgitation. This happens when one fail to deploy clip or due to device malposition. And patient can go into the flash pulmonary edema, RV failure, and cardiogenic shock. Anesthesia goal should be to avoid bradycardia, maintain the forward flow, and optimize the RV functions. RV failure in tricuspid procedure. In case of a severe tricuspid regurgitation, when triclip is applied, there is a sudden afterload dynamic, sudden change in the afterload dynamics, and this leads to the RV failure. So chronically volume overloaded RV, when clip is applied, the afterload dynamics suddenly changes, putting patient into the pulmonary edema. So clinical signs will be high CVP, low pulmonary artery pulsatility, and low cardiac output. Management will be use pulmonary vasodilator, dobutamine and milrinone. The blood pressure should be supported using noradrenaline and vasopressins, maintain the sinus rhythm, avoid hypoxia and acidosis. Thus, the anesthesiologist's role in preventing this disaster is very important. Pre-procedural, all anesthesiologists should review the CT personally, identify high-risk tower anatomy like coronary height, annulus, and calcium distribution. In case of the TMVR, the predicting risk factor for the LVOT obstruction should be identified. Discuss the bailout strategy beforehand. Prepare invasive monitoring and vasoactive drugs beforehand. Intra-procedurally, continuous TE vigilance is must. Early recognition before the actual collapse happen, and closed-loop communication with the interventionalist. Rescue readiness, ECMO should be available, defibrillator pad should be applied beforehand, blood products should be available and ready, and surgical conversion pathway should be clear. Key lessons learned are, it is very important to have a heart team discussion day before, and one should discuss the CT finding and echo in detail. And it helps to anticipate possible complication and prepare the rescue plan. T is your early warning system. Team communication saves the life. prepare for the surgical conversion, and every complication deserves a structured debriefing. Coming to the conclusion, success in structural heart intervention is not defined by the absence of complication, but by ability to recognize and manage them effectively. Anesthesiologists plays vital and crucial role in patients' well-being and success of the intervention. Thank you very much.
I think we have time for one or two questions. Anybody from audience wants to ask?
I would like to ask, for every structural heart disease procedure, do you keep OT ready with the perfect?
Yes, at Lilavati we keep all, there is a surgeon standby and OT is also booked. And we coincide the OT booking timing with our cath lab timing, and we don't take otherwise.
Because most of them, because of logistic issues, sometimes there is a delay for the proctor to come and then the OT timing is shifts. Even for device closure at our place also, we make sure that OT is ready, because complications come unwarranted. And
Yes.
we have seen that most of the time for emergency procedure, in some institutes the OT was not ready and we had to rush to the other OTs.
See,
Surgery is there himself has helped us rescue complication in the cath lab, and he might throw light on the complication which occur in the cath lab, because nowadays the procedure in cath lab, the volume and the complexity has increased, and for them it is a routine thing, but we as the anesthesiologists, we have seen that most of the time complications occur, and that time the cardiologists, they are stuck and they are like always calling the surgeons, and even surgeons are getting back. In many institutes, even the surgeons have seen that they are some other place and they come rushing when the complication occurs.
So,
Yeah, sorry. I think this is criminal not to have a surgeon, perfusionist and OT standby while these complex procedures are going on. And I know because I work in Lilavati also, they do have a OT which is vacant with everyone standing by, a surgeon in the campus, in cath lab rather. So I think that should be the protocol. You should sit with the administration of the hospital and make sure these rules are applied strictly. Just one question, Amrita, what monitoring do you do in the cath lab for all these complex procedures? Is it some routine monitoring? You do anything else extra?
see, I have set up a protocol that I always put a central line, okay, and central line and artery line for all tower cases, okay. Secondly, for triclip and mitra clip, I try and put cardiac output monitoring. So recently I did one triclip case. We actually did 3 triclip cases. Out of that 2 were unsuccessful. The interventionologist could not place the clip. So, but the third patient which we recently did was 92-year-old man, whom there was severe tricuspid regurgitation, moderate mitral regurgitation with 2 CAVGs in the past and EF of 35%. Now this patient was posted for the triclip. So for this patient, I use continuous cardiac output monitoring. Why? Because after placing the triclip, there is a sudden volume dynamics changes. So earlier there was a severe regurgitation, tricuspid regurgitation, lot of volume was going back. But now, after placing the clip, forward flow increases. So this patient has a moderate MR, which became severe MR the moment the clip was placed, and patient went into flash pulmonary edema. And simultaneously on my CEO monitoring, it was showing me the systemic vascular resistance, which was 1200 before, has increased to 2200. So this flow dynamics sudden change, if the monitor is there with you, it gives you insight that how to react. So I gave NTG at the rate of 100 to 150 ml per hour to tide over those crises of the severe increase in systemic vascular resistance. And probably that curtailed down the pulmonary edema also. So this is how—
cerebral oxygen monitoring? You use hemisphere for cerebral oximetry?
Yeah, I do use hemisphere as in some of the tower procedures where, especially in valve-in-valve procedures, I prefer to use cerebral oximetry. The reason behind is there is a possibility of embolization of the tissue to the brain, because these valves are degenerative valve, and when you are placing another valve, with that friction, the tissue can get dislodged and go to the brain. So it is vital and important to monitor cerebral oxygen saturation during the procedure, so you can identify actually something has happened on. But in most of these valve-in-valve cases, they place a sentinel device for cerebral protection, and nowadays a new device is introduced which is called spider device. The spider device, it opens up like umbrella, like IVC filter, it opens up like umbrella into the carotid artery, and it catches all the tissue and debris that is coming from the heart and prevents the stroke. So these are the two devices used in valve-in-valve procedure to prevent the cerebral embolization, and in these patients I will prefer to use the cerebral oximetry also to detect early.
Can I ask one thing from the chairpersons? I want your opinion regarding this. Recently, I have lost one child who was 9-year-old and came for the pulmonary catheterization. Patient was known case of idiopathic pulmonary hypertension, and case was taken by cardiologist. They just wanted to see the pressures in the all chambers. This was their saying. And they said that they won't just stand by anesthetics, they don't want any anesthesia. But intraoperatively, when they started the procedure, patient started moving. So they said give some sedation, so midazine fentanyl as per weight was given. Now during the procedure, patient started throwing the blood from the trachea. And you know that hemorrhage has occurred and we were not able to save the patient. Patient just went into the severe pulmonary hypertensive crisis and bronchial hemorrhage. So I just want to know, we could have prevented this, or if what was the reason it has happened, and if it has happened, then can we do something in this situation?
Should have given the like general anesthesia.
General anesthesia means it was just supposed to be, pressure was supposed to be checked. So they said they don't want anything, they just want standby. So started the pulmonary femoral puncture was done, and then patient started throwing the blood from the trachea. So 100% the pulmonary vessels got ruptured during the procedure. So can we do something? Our cardiologists can do something in this situation?
Already the complication is...
So its complication has already occurred. What you need to do is maintain the oxygenation.
What I mean to say, was it necessary to check the pulmonary pressures in this case, number one?
So they can do one. Here I have to answer that. See, a cardiologist has all the invasive armamentarium available to them. They can pass a simple catheter to the pulmonary artery and measure the pressures pre and post, and even during the time of the complication, and they can give you insight that whether the pulmonary hypertension is there, or there is that
we have a very good
this is a known case of pulmonary hypertension.
Well. So why
the pressures has to be checked?
Ma'am, I want to add to this case. See, we are doing, diagnostic procedures for all the PAH patient routinely. And any diagnostic procedure for severe PAH patient should be considered as a very high-risk procedure. So usually we take a high-risk consent. That is the first part. Wherever there is a severe PAH patient coming for diagnostic act, first is high-risk consent. Second thing, we keep ICU bed ready, standby bed ready, because these patients can get intubated anytime. Intubation is the key. Early intubation and starting nitric oxide, milrinone, or some noradrenaline might help in these patients. With all these measures plus ICU backup, they go home. Usually, it's a reversible thing. It's not like, we can leave them alone when there is a severe bleeding. They do revert with all these measures. But key is availability of nitric oxide. If you can manage, intubate the patient, start nitric oxide, give milrinone, and add NORAD, SOS is the key to manage these patients.
Yes, nitric oxide should be available in the cath lab also, not only into the cardiac operation theater, because when you are dealing with the severe tricuspid regurgitation and all, these patients have a very high pulmonary, they have a pulmonary hypertension. So for the treatment of triclip procedure also, you require inhaled nitric oxide. So,
So if we do not have the nitric oxide, then we should.
it is as good as operation theatre.
Operation
Actually, it
theatre,
should
it
be
is
a
not less
hybrid.
than. So
I'm
we
sorry.
should not take it.
Yeah.
The approach should be like in an operation theatre, you are giving anesthesia or any monitored anesthesia care.
Yes.
So that's the take-home message.
Yeah.
And few of the procedures like TEVAR, then the RSOV device closures, just to
Yeah.
complete the list.
Yes.
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 And
Like-
even BMV like thing, because
Yeah.
even
Yeah.
the non-cardiac anesthesiologists are also giving standby, they are attending these cases.
Yeah.
For them, that if the immediate, the acute MR happens, because for BMV, many hospitals, they may not keep the OT standby.
Yes.
When in those situations, what all you should, so one
So
checklist,
yes, yeah, I
have
understand.
been
I
there.
understand. I
Yes.
understand. But BMV, yes, I agree with you. In BMV can cause acute MR also when overdilated. So you should have a surgeon standby. With me, it has happened that even during the ASD device closure, device snapped and torn LA roof. Okay, and we need to do the pericardiocentesis. Took the patient to the theater, emergency CABG, emergency open heart surgery. Yeah, it is way forward, yes. Okay. Thank you so much. Thank you.
Madam just mentioned that during BME also there are OTs are currently not kept as a standby, but in Apollo we are keeping practice that each and every case is discussed in the hard council meeting prior to posting in the cath lab or prior to in OT. It involves surgeon, cardiologist, anesthesiologist along with intensivist. So everybody is on the same page before any complicated case is taken. And we also make sure that whenever such a case is done, not only OT, even surgeon is also standby and surgeon is not operating in another OT. Surgeon is totally free.
Yes.
And that our anesthetists usually take care that
Yes.
surgeon is free or not. Every time
Yeah.
they will check.
So I would like to add that what is not happening currently right now is heart team discussion. Actually the concept was to have a two surgeon, one interventional cardiologist, one non-interventional cardiologist, and anesthesiologist all together should discuss the case beforehand and then take up the case. Right now cardiologist straight away take up the case. Surgeon has no clue what the case has been taken up, and the anesthesiologist is like, he doesn't have all the because we are not doing that many number of the cases, we don't have the perspective how the procedure will go ahead. We do have a book knowledge, but not actually practical knowledge to deal with those kind of complications. So heart team discussion is the most important thing with the relative, in presence of the relative as a team. Thank you very much.
Noticed that makes a lot of difference.
Yeah, that
like
makes a
once,
lot of difference.
BME also, once we had a interventional puncture of the aorta and tamponade also, but we could save immediately the patient. Instead of the septum that had gone little up and punctured the aorta.
Okay.
But still we could save the patient immediately because everybody was ready. I think Dr. Saurav, he was also there that time.
It was a
Yes,
pre-Diwali
sir.
day, I remember.
Yeah.
We could
Yeah.
wheel the patient in 5 minutes from our cath lab and our OT is in just front of each other. So we just wheeled the patient. Dr. Sachin put a patient on the emergency bypass. We did not do a replacement, but we did I think so we did a repair of the valve. Okay, thank you. It was a very meaningful discussion and it was a very common procedures we are doing. I would request Dr. Sanjita to please felicitate Dr. Namrata for the fantastic talk. The next talk will be delivered by Dr. Khushbu. She is going to talk on the important aspects of regional blocks in MICS. MICS has come a long way. Most of the surgeries we are doing nowadays is the minimal invasive. So regional plays a very important role in it. I would request Dr. Vishwas to just introduce, or Dr. Amish to please introduce Dr. Khushbu.
So, our next speaker is Dr. Khushbu Dharmani, and she is going to speak about the importance of regional anesthesia in minimally invasive cardiac surgery. Over to you, Khushbu.
I think there is some problem with starting with the slides, but yeah. So I'll be talking on blocks in cardiac surgery, particularly minimal invasive cardiac surgery. So just a small poll, like how many of us are, and there are a lot of people from ISA, so how many of us are doing thoracic blocks? Can we just, that's great. And in cardiac surgeries? Okay, so I think that's a quite good number, but definitely it's lesser. So we just highlight certain important blocks. There are many blocks, as we know now, and it's improvising, and as our knowledge about anatomy is increasing, we are just improvising and improvising. So we'll discuss about certain blocks, and rest we can discuss again later. So as we know, pain in cardiac surgery is really debilitating, and it can cause a lot of pulmonary complications, cardiac complications, and increase the length of stay in the hospital. And since we are talking about hemodynamic monitoring, we know that a incompletely managed patient or a patient who's constantly in pain can have abnormal hemodynamics. So understanding that pain has to be treated rightly is also important, because it can affect the hemodynamics in the perioperative period. So in cardiac surgery, we have the standard sternotomy incision, and in MICS, we do a mini sternotomy. We can have a right or left anterolateral thoracotomies and a clamshell incision, but that is not in the MICS. But managing pain management in these requires an understanding of the nerve supply of the chest. So before that, we know that it is highly recommended, the ERAS protocol, which is recommended as in other surgeries for cardiac surgeries also, and the 2026 guidelines actually recommend strongly including these blocks in the cardiac surgery. So the numbers have to increase, as we are seeing many anesthetists are doing, but it has to increase. But still there is a lot of low compliance and people are a little hesitant. So let's see what is it. And a very important study proved that pain management as compared to other surgeries is very, very unsatisfactory. Like if you ask the patients what is the problem, so they are really not satisfied that the cardiac surgery was really painful. So this outcome, or this, if the surgery was really good, everything went off well, but the pain management was really troublesome. So I think the blocks in cardiac surgery is like Mr. India for us, like, it's, oh my God. So we just feel that the hemodynamics have to be managed and blocks can be, theek hai, dekha jayega. So let's see what is it, like, is it firstly, do we actually believe in our blocks as cardiac anesthetists? I think when we transitioned from general to cardiac, we were, experts at managing a lot of blocks. But I think when we come to cardiac surgery, we slightly take a backseat. We feel that the most important Fenta patch takes over everything, or the opioids take over everything, and so much of blind trust in opioids that we feel that maybe it's okay if we just skip it also. As long as the patient is doing well and going home, it's really unimportant. Surgeon cannot be put in the role, because I feel they are always with us, behind us we don't know, but definitely there is some role, but we have to get in more and more. Or what is it? Is it our boredom, or like, let's see what the reason is for low compliance. On a serious note, for guidelines in cardiac surgery for the blocks, the location, these are certain issues that are unclear, that how much is the coverage that it will give us, what is the timing of the block, should we give it prior or post or whatever, how much volume are we supposed to inject, which is as standard to other surgeries. There's always a confusion. Who's going to perform it? Is it the surgeon, or are we supposed to perform, or should we call somebody else? There's always a discussion. Is it going to be an added expense? Oh my God, another catheter, somebody has to be called, there is an ultrasound, or who is going to do it? So these are all the queries because of which I feel there is a low compliance, and the studies show that we don't adhere to the guidelines and evidence-based answers of going for these procedures. To overall tell you about certain blocks that we discuss here, highlighting are the parasternal blocks, which will give analgesia to the anterior part of the chest wall. which will relieve some part of the sternotomy pain and certain other procedures. We have the IPP and PSP, that is the interpectoral and pectoserratus block, which is also called as the PEC1, PEC2, and the serratus plane blocks. These are the newer names. And the ESP blocks, which is the most gold standard now, because we have studied it a lot and a lot of studies, and we perform generally in cardiac surgery. Then we have the SAP block, which provides analgesia to the anterolateral part of the chest wall. Okay, so this is just put in together, so I'm sure it's really confusing. Let's see the chest wall innervation as we discuss. So the anterior and the posterior part are supplied by the spinal nerves and a part of the brachial plexus. The upper part, as we can see, the anterior part, we have the motor supply from the brachial plexus, the medial and the lateral pectoral nerves. Then we have the long thoracic, intercostobrachial, and the thoracodorsal nerves. So these supply the anterior and lateral part of the chest. And we have the spinal nerves, T1 to T12, that exit the foramen and give a dorsal rami and the ventral rami. I'm sure the newer ones are more well-versed with the anatomy. So we have, just to be in short discuss about this, it is the dorsal and the ventral. The dorsal supply the muscles of the back and the joints and everything. The ventral rami will continue as the spinal nerves, which will give off the branches. As we can see here, this is one nice picture of Dr. Sandeep Diwan, who's a very good regional anesthesiologist, and a very nice cadaveric view of, you can see the spinal nerves exiting, giving off lateral cutaneous branch and anteriorly anterior cutaneous branch. So these are the nerves which we are going to block by the various blocks, which will give analgesia for our procedures depending on what is the site of surgery. So for simplifying it, as we discussed, we divide it into the anterior blocks, that is the pectoralis, the IPP and PSP, and the parasternal nerve blocks. The posterior chest wall blocks, that is we exclude epidural here because especially for cardiac surgeries, we are very, very worried about the hematomas, so we don't talk about it here, but many people do perform it. So posterior chest wall blocks include paravertebral block. Again, it has still chances of hematoma, and a deep hematoma can cause really some symptoms in the postoperative. So we try to avoid it, but nevertheless it has been reported to be performed by many anesthesiologists in cardiac surgeries. And there is a variant which has come, which we can discuss at the end: intercostal nerve blocks and erectospinal nerve blocks. So as we saw, we just see the analgesia coverage. As we can see, the transverse thoracic plane block and these are the parasternal intercostal plane blocks. Then is the pectoral blocks, the serratus anterior plane block, and the back and the front with the erector spinae blocks. These diagrams I've included so that it remains with us what is covering what. So as we see the probe position. Where is it? The probe in the mid-clavicular region at the second and the third rib for locating the pectoralis muscles, and in between them you can give around 0.2 ml to 10 to 15 ml of drug in the pectoralis. You can just tilt the probe and find the pec minor and the serratus, and we can deposit the drug there. So the advantage is in the pec, it blocks the medial and the lateral pectoral nerves, which are the branches of brachial plexus, and along with that, added analgesia on rotating and inserting it between in pec minor and serratus is, as we know, blocking T2 to T6 cutaneous branches, as well as the other long thoracic and thoracodorsal nerves, etc. So these are the chest wall blocks. In summary, the probe position, as we can see, and the local anesthesia is deposited. The serratus anterior plane block requires analyzing the thoracodorsal artery, whereas in the PEC 1 and PEC 2 blocks, we need to identify the thoracoacromial artery. Here we can see we have to be vigilant of the thoracodorsal artery. It's a plane block, so it requires a larger amount of anesthesia, a larger amount of volume, around 30 to 40 ml. Depending. So there are two variants. We can insert the needle above and below. These are the superficial and deep serratus anterior muscle block. Again, it's completely depending upon the experience and expertise of the anesthesiologist. This is the interpectoral, again, just showing you the position here, how we place it, and then just turn laterally and then deposit the drug between the two muscle and the plane. So this is from the general other cases where we do, but this just gives you an overview of what are we covering again in a tabular manner, where we can see the pecs one, the interpectoral and all, covering all the part of the brachial plexus and some part. And here we can see the cutaneous branches along with it covered by the serratus plane block. Then we come with this parasternal intercostal plane block, which is again the surgeons are little afraid about this block, is because there is a very important, if we see, this is the sternum in the center, and there we can see the most target. What we can see is the mammary, that is the internal mammary. So that is the one that is being harvested in the coronary artery bypass surgeries. So be very aware that this has not to be touched. So this is how we perform a post-operative block by under ultrasound guidance. There we can see the TTM, that is the transversus thoracic plane. That is a little deeper. If you insert, that is a superficial parasternal block. So the superficial, we don't have a mark, this thing. So the superficial parasternal is between the pec major and the external intercostal muscle, that EMM and IMM. Below that would be the lima, as we can see that side up on the extreme left hand side, and below that is the TTM. So there are two planes where we can insert our needle under ultrasound guidance. Is it coming? Yeah. Yes. So we can see this. This is the superficial parasternal block, where between the pectoralis major and the intercostal muscles, we can deposit the drug here. If we go slightly deeper, we'll be inserting in the plane between the intercostal muscle and the transversus thoracic muscle. So around 0.2 to 0.3 ml of 0.2% ropivacaine can be deposited. But again, we have to be very, very vigilant of this very important artery around here. So this gives a short, again, revision of the analgesia covered here in the anterior part, anterolateral part, and the anterior above part of the chest. This is just a rectus sheath block. We can give it identifying the rectus muscle. In the needle is yours, the probe is yours. Just identify the rectus muscle, and in the sheath you can insert local anesthesia for the drains. Now we come for the posterior chest wall blocks. They are very important. Reason is that advantage is that it will cover a part of the anterior. So we want, once we do this here, it just gives you analgesia from the anterior and anterolateral part of the chest. But when a patient is undergoing cardiac surgery or minimal invasive cardiac surgery or thoracotomy, the pain is just not located there or restricted there. It's going to be on the back and sides and everything. So the posterior chest wall blocks include the paravertebral block. As we know, we can see, again, this is a very important figure I've taken with all rights and permission from him. We can see a nice paravertebral space here, which we can see the spinal nerves exiting, and we can see the dorsal and the ventral here. So both are nicely covered by the paravertebral block. That is the advantage. And we can see, we just have to put the ultrasound probe and enter into the, it can be in a sagittal manner, just as I think many of us used to do previously as the click. We get the click, that is the clicking of the superior costotransverse ligament, and then we can get it. But now with the ultrasound, we have a nice vision of the SCTL, and we can prick it. So we can see here, we can enter the paravertebral space very nicely. Next is the intercostal block. As we know, we just advance towards the rib, paramedially, and then aspirate, hit the rib and give. But this again requires multiple injections, so it's rather not a very great block unless it's a rib fracture or trauma case. Now the most important is the erector spinae muscle block, the most curious and the interesting block. So it's what is erector spinae? It's a group of muscles lying closely knit in a fascia. And what they have said is that when you hit this and when the drug spreads here, it spreads very nicely craniocaudally and gives, the drug reaches from T1 to T9 and T11 and gives analgesia nicely where the dorsal ramus is included, as well as the drug spreads into the anterior part, that is the ventral rami. So that is the crux of understanding here. We see that this is the needle entering here. We hit the transverse process. All you require to understand is the bone that we hit and the muscle plane and fascia. So we hit here and then we distribute the drug here. I'll show you a live video where we have. Yeah, so we can see this erector spinae. This is the transverse process, hit it, and we can hydrodissect the plane and it will nicely spread, give good analgesia. The mechanism is the drug will seep in through here and enter the paravertebral space without causing any hematoma or entering the any coagulation problems. The new this thing is to give it here in the mid-transverse position, which we can discuss if required. So this is the analgesia with the intercostal blocks, paravertebral, and the EPSP. So the advantage is that, like I said, good posterolateral and anterior coverage, catheters can be kept inside and gives good analgesia and good craniocaudal spread. So as we can see with the good erector spinae, we can see the drug is distributing in the paravertebral as well as in the epidural space as well. So this is the costotransverse foramen, from where there is a medial and lateral slits through which the drug seeps in, and correctly placed, or if you want to place it. So there are two ways. Again, this is the old anatomy where we thought that it doesn't seep in, and this is the new anatomy where we understand that there are slits in the costotransverse ligament by which the drug spreads completely and very beautifully in the paravertebral and epidural space. So this is one minute. I'll try to just see if this plays. Yeah, so I don't know if audio will come. So I'm trying to show that as you go laterally, 1 second. So this is the video where we see as the, all are playing together. This is the view where we can see that as the, is it playing? Yeah. This is where I have put the needle and I have tried to spread the drug. You can see the hydrodissection here. Can we appreciate? It's hydrodissecting the plane. But this is a superficial EPSB where I have placed, just hit the transverse process and gone. Now we have the mid-transverse injection where we can actually go and hit below. But again, that's again as much expertise as you have, slowly hit this thing. And we can see here how I'm threading in a catheter here. I've placed it and then I place a catheter. This is a 50 mm needle or 100 mm as per as the size of the patient, but this was a very lean patient to take away, that's why. And we can see the catheter I have threaded, keep the catheter inside, and then we can nicely see it in the space. So yeah, these are the, in summary, just the paraspinal blocks, which are, safer, better because of the anticoagulation, safer from all the aspects. And we are, so with me giving like more than so many blocks, there is not reported much of any complications of hematoma. So we can see here the erector spinae plane block, and again, like I said, a variant of it, midpoint transverse process block, where we slowly want to come closer to the paravertebral space, but don't want to cause hematoma. So we try to block the ventral rami as well, because then we get a good analgesia from the anterior aspect of the chest wall as well. So these are the other plane blocks as we discussed. These are for sternotomy, minimal invasive surgeries, what are the blocks that are applicable. Even for tower or cath lab procedures, we can, once you know the anatomy, you have the probe, you have the needle, you can understand the area of coverage and carry on with the block. So let's focus on going on with the ERAS-based care as we know, and actually understanding it and following it, like rather than just saying it. And focus from the, let's go towards the ERAS care than the traditional care. So sorry I didn't keep the highlights on their eyes, because I wanted to show that they're actually happy. Their eyes are smiling, and they're on the same day of cardiac surgery. This is an 80-year-old gentleman after MICS, and his eyes are actually smiling, so I didn't want to hide that. This is the Baxter pump which is there, and after surgery they are extubated and they are nicely sitting and doing their spirometry, and second day almost they are maybe in the ward or home. Thank you. So previously we tried, but it's like because of full heparinization and anticoagulation, it's always a risk. So it's
to avoid the
central neuraxial block, yes. So it's
to avoid the epidural hematoma, which
yes.
can occur with this.
So that's the most dreaded complication
Absolutely.
of these procedures. It was a good talk, and then I have taken a few pictures as well. So which needle you are using here?
The 22, the 2E needle, the 2 needle.
16 gauge.
Yes.
Okay, and the catheter is the epidural catheter?
Yes, the Contiplex catheter.
The anterolateral thoracotomies, they have a more pain than the posterolateral thoracotomy.
Anterolaterals have more
Yes,
pain.
anterolateral. And the thing is, one more, when you are inserting or giving the regional blocks in these patients, do you take the separate consent that from medical legal point of view, because during dissection also during thoracotomy, sometimes the intercostal nerves, they may get injured, and that should not cause that the neuropraxia has occurred because of your regional anesthesia.
Correct.
Or analgesia. Do you take the separate consent?
Yes, so ma'am, we have a consent paper where we have to tick mark all the, if we are going to perform any regional anesthesia. Beside that, I discuss with the patient so that they are prepared. Anyways, all the blocks for MICS, what we perform, ESP blocks, are done after induction. So after induction, we turn the patient lateral, and because these are all cardiac surgeries, we can't afford to be having them agitated or anything. So after induction, we turn the patient lateral, and certain people also do it in prone in many institutions in Chennai. So we turn the patient lateral and put the block, and consent. Yes. So we inform the patient that we are going to put so and so, because after surgery he will know that something is there on my back. So he suddenly shouldn't feel that this thing.
Form, do you mention
Yes,
separately?
yes, with a regional anesthesia and a nerve block. Then we have, and a catheter will be. Patient is informed very well with the consent.
Specifically for this minimally invasive cardiac
that
surgery.
Baxter pump in that patient, where is it connected to? What is the block that you are given? And the masala of that Baxter pump, can you
This
share?
is the erector spinae plane block.
So can you tell what is that you use in that composition?
0.2% ropin.
Ropin. No opioids?
At 7 to 10 ml per hour.
No opioids?
We can add fentanyl, but here, as much possible, we are in cardiac surgeries, we are trying to avoid
just 0.2%.
fentanyl. Yes, we want to go for opioid free, and I have realized initially I used to add 100 mics fentanyl to this thing, but I realized that the pruritus or vomiting is still present with that, so I've completely excluded it, and the 0.2% ropin gives excellent results.
Without a patch?
Without a patch, and all these patients that I have shown are without patch. So I give when the first time I'm putting the block, I give 25 ml at that time, and after that, it is continued as an infusion.
Nice.
Yeah.
Thank you.
Specifically.
So ma'am, for sternotomies, I give the parasternal block with discussing with the surgeon, of course, again, how was the lima and all. And also I give the spectoserratus block for the cardiac sternotomies. But for MICS, I only give a erector spinae block. And the surgeon gives, at the end of the surgery, the surgeon gives some intercostal block at his end. For sternotomy, I give it after surgery because pre-op, they are going to dissect the lima, so everything it's not going to be useful at all. For normal cardiac surgery, post-op, and for MICS, pre-op. Yeah. So because I give when I give initially, I give 25 ml initially, so that is there. When after that, instant 25 ml of 0.2% ropin. And because it's a volume-based block, it's an interfascial block. So because it has to block completely, after surgery, we immediately connect the infusion, which goes on at 7 to 10 ml per hour. So it's a continuous infusion. Maybe after 2 hours. Certain patients we have extubated on table also, but because all our patients are 80 years and 70 years, so we extubate in 2 to 3 hours. Also, if it's a poor ejection fraction and MICS, because we are doing higher end MICS, we do extubate next day also. I wouldn't deny. The infusion is continuously on, but there are rarer substrates. We try to extubate them as early as possible. No, paravertebral, so I give, like I said, there's a mid-transverse injection where we initially I was very much just at the transverse process, but now I take the plunge, and because I've given so many, I know that we can go a bit beyond my aim is to cover the ventral rami as much as possible. So dorsal you're always blocking, but ventral is a little problematic. So try as much possible to block the ventral. So the studies have said that a good mid-transverse injection is almost, the drug seeps in because of the slits in the SCTL. You can see the slits as we showed. So it's almost equivalent to paravertebral. So no need to go for a deep paravertebral injection where a problem of hematoma would be disturbing. Here, as much as we are away, it won't cause much problem, even if there's a hematoma. No.
I agree with Vaishali that if we have to give the paravertebral block, should be given pre-operative.
Pre-op. We give ESP also pre-op.
You just put a catheter with the USG guide.
Yes. So ESP, why we give it in prone and lateral? Because the studies and the cadaveric studies have said that the dye diffusion has been very good when it is lateral, when the patient is lateral or prone, it spreads craniocaudally. So with amazing results of craniocaudal spread in the prone and lateral, we go for a ESP which spreads very nicely, almost equivalent to a paravertebral.
Regarding these regional blocks, that is, I can say, really game changer for the post-operative recovery of the patient. Because see, initially when also we started our minimally almost 5 years back, and there we used to give only the serratus anterior block and intercostal block. But I notice, and everybody will agree, that pain of minimally invasive cardiac surgery is more than sternotomy. That happens post-operative period. You are happy you have done minimally invasive. When you go for the rounds, patient will complain of too much pain. Second thing, when minimally invasive is done, it is a single lung ventilation. So due to the pain, next day patient will not be doing proper spirometry, and again the complications related to atelectasis, all those things happen. So when we also started to have these blocks and everything, so we have also started giving erector spinae block, and I have noticed patient complained absolutely no pain.
Yeah,
I'm saying no pain. Because initially we tried everything, Boehler patch, fentanyl infusion, everything, all masalas, but what worked best is erector spinae block.
And till now I've never noticed any hematoma also, because we are safe from the our point of view also, guideline.
And see, as madam you mentioned that slide, I remember what are the hesitation points to give regional blocks. Okay, that's
because that's there, that's true. That's That's a
but what I noticed for our we call Trimurti, Dr. Saurabh, Dr. Leena, and Dr. Haridas, they usually see all the patients post-operative till the time they are in the ICU. So when they saw that after giving erector spinae block, patient complains of no pain. So I remember that patient also, that patient was HOD from Cooper Hospital. He was operated minimally invasive. And when they go for the rounds, then they told me patient is complaining of absolutely no pain. Zero pain.
Yeah, they have almost zero
And so that extubation is faster.
Yes.
Second thing, complications associated with no spirometry. Those are reduced.
Absolutely.
And till now, I have not come across any patient who is given erector spinae block and patient is not extubed between 3 to 4 hours.
Same.
So that definitely makes a lot of difference. And now it's our by default block is ES block by default. And all are giving nicely, and recovery has definitely changed.
Yeah.
Okay, so we can end the session. I would request Dr. Sanjita Madam to please felicitate Dr. Khushbu. It was a very interesting lecture. And all of the person can come on the dais. Please, everybody can accompany. There is a change in schedule. Dr. Vijay is coming late, so we'll be ending this session, and after that we'll be having a session on pediatric as well as remifentanil, along with the interesting case scenarios. When Dr. Vijay comes, we'll take his lecture. I would request Manjula Sarkar Madam to please come on the stage to felicitate the chairpersons. Along with Dr. Shilpa Madam, please come on the stage. Thank you. The next moderator will be Dr. Kalpana. Dr. Kalpana, you will be moderating the next session. Khushbu, group group pick the speaker, please. Sanjita madam, Dr. Manjula will felicitate you. Vishwas sir. Dr. Shilpa madam will please felicitate Dr. Vishwas sir. Okay, madam है ना पीछे. Dr. Sachin, please come on the stage. Dr. Sachin is our dynamic MICS surgeon. Please give a big clap for him. He has done a very good job starting our MICS program. Dr. Shilpa madam, please felicitate Dr. Sachin. Dr. Amish, please come on the stage. Dr. Amish is our treasures and he is looking after our ACTA efforts. Dr. Shilpa, please stay on the stage. So next interesting session is on pediatric as well as newer drugs. First, Dr. Shankar Kadam will give the speech. After that, Dr. Sovik will be there. Then we'll have interesting case scenarios. Dr. Kalpana will moderate the session.
Good afternoon, everyone. For the next session, I would like to invite Dr. Manjula Sarkar to come on stage. She is a professor and in charge in Department of Anesthesia at D.Y. Patil University, Navi, Mumbai. She has more than 25 years of teaching experience in the field of anesthesia. She is eminent author for more than 50 publications in Index Journal, and she has a significant role in development of cardiac anesthesiology as a super specialty branch. Thank you. Next is Dr. Shilpa Bhojraj. Dr. Shilpa Bhojraj, she is a highly experienced anesthesiologist, primarily affiliated with Breach Candy Hospital and Safi Hospital. She has also won many awards, such as anesthesiologist for expertise in the field. Dr. Vaibhav Dhabe, he is a specialist in pediatric cardiac anesthesiology, currently working in Narayana Health, SRCC Children's Hospital, Mumbai. Dr. Sushil Raut, he's a distinguished pediatric cardiac anesthesiologist at BJ Wadia Children's Hospital, Mumbai, whose expertise has significant contribution to care in children with complicated congenital and acquired heart diseases. And most importantly, he's a better half of our department. Chairperson, can you introduce the speaker?
Good morning, Yena. Good morning, Yena. Good morning. So, without delay, I would like to invite first of speaker, Dr. Shankar Kadam. He is a lead consultant pediatric cardiac anesthetist and intensivist at Kokilabin Dhirubhai Ambani Hospital. And his experience is 19 years in this field. He has many publications and many presentations in his credit, And his area of interest is pediatric cardiac intensive care, fast tracking, nutrition, and running. So welcome, and over to you, Shankar.
Yeah.
Acha,
Yeah.
okay. Okay, now let him say this.
Yeah. Hello. Thank you, ma'am. Thank you for the kind introduction. First of all, I would like to thanks Dr. Saurabh, Dr. Leena, ACTA, and ISA for giving me the opportunity. I am honored to be here and stand on this dais. So I work at Kokilaben Hospital. I am associated with Kokilaben for last 16 years. We are doing close to 1,000 pediatric cardiac procedures. It includes surgery and cath lab procedures. We have dedicated 25-bedded pediatric cardiac ICU. We are doing all sorts of cases, including Norwood, Pochen, Roscono, switch. And our mortality consistently stays below 5% for last many years. So, before going into the cardiac and pediatric cardiac, I would like to tell you that, we at this stage of life, we should get involved into some sorts of physical activity. And of any physical activity, walking, jogging, or running is the easiest one because it just needs determination. And I tell you, your early morning run or walk will give so much dopamine which stays with you for next 24 hours with your next, morning run. So I advise, it's a free advice. So yeah, you can take it or leave it. So our success in pediatric cardiac surgery is no longer measured by survival. The challenge is delivering survival with neurological integrity, quality of life, sustainability, and equity. So there was an era when we used to defer the patient with HLHS, or we used to send them back from emergency. Sometimes they will be admitted in the ICU and we used to send them back. But that period has changed. Nowadays, many centers, many leading centers, they operate HLHS. Initial stage, first stage of Norwood, we face a lot of challenges. Many a times, chest will be open for, 5-6 days. They might go on ECMO, prolonged ventilation, infection, QPQS. We go through a hell lot of problems at first stage of Norwood, but they do go home. And many of them come back for second stage, that is Glen. And third stage, again, many of them come back for third stage. Many of our post-Norwood surgeries are going to the school now. So pediatric cardiac anesthesia and intensive care has evolved dramatically over last few decades. And we have moved from basic survival to the precision physiology. The prolonged ventilation has changed to eras, that is enhanced recovery. And earlier days, like ICU was managed by isolated specialists, but nowadays there are integrated teams to manage these patients. Yet important gaps remains. There is a shortage of manpower at many places. Because this is not the lucrative branch, it's not money-making branch for the hospital, they don't try to employ the adequate people. So most of the centers face manpower issues. Training is inadequate or it's not uniform. Affordability remains the main issue, main deterrent for doing all these pediatric cardiac procedures, especially category 5 and 6 patients. Most of the programs are supported programs. So, we do have to support these programs for a few more decades, I believe. There are issues with neurodevelopmental outcomes. The studies are lacking for long-term analysis. And there is a burnout among the practitioners. We used to work, these types of ICU in earlier days where chaotic, all the patients will be side by side. There won't be any space to move on. But most of the, leading centers, they have provided, good facilities for these patients with, special beds, special place, with all sorts of monitors in these ICUs. So earlier days, the main aim of the ventilator was to deliver the breath, but modern ventilators, things have changed. The modern ventilator do protect the lungs, they optimize the circulation, and they help us to make the decisions. Even there are a lot of changes in cardiopulmonary bypass machine from 1975 to 2026. The newer machine, they more look like an aeroplane's cockpit with all the monitors, inline monitors, and other gadgets. So we have evolved. We have evolved from a period of high mortality to survival of more than 95%. We used to face a lot of patients with late diagnosis and associated issues, but most of the cases are getting diagnosed in fetal life. And those who escape fetal diagnosis, they get diagnosed at the neonatal period. Prolonged ventilation used to be the norm. I have seen in my initial days ventilating the patient, knocking them out and ventilating for 48 to 72 hours was norm in many centers, but that has replaced by fast-tracking extubation. There used to be a limited monitoring, but now we do have NIRS for almost all patients. We have bedside and echo machines available in the operating room, along with advanced hemodynamic monitorings. There is a significant change in mortality. The mortality, especially for category 4, 5, and 6, has dramatically reduced from 50% to close to 10% or 15% at leading centers. We have mortality close to 20% in our center for category 5 and 6 patients. Other mortalities like category 1 and 2 is negligible. If you have a mortality in category 1 and 2, that's not acceptable at many centers. So this is another graph showing significant drop in mortality in category 5 and 6. Category 1 and 2 remain almost same. So we are no longer merely providing anesthesia for surgeries. We are managing continuously evolving cardiovascular physiology in these patients. The biggest progress is not in the monitors, not in the machines, not in the techniques, but it is in understanding of cardiovascular physiology. We talk in terms of QPQS when we manage these patients in the ICU. We do manipulate SVR, PVR when we are in the operation theater or when we are managing these patients in the ICU. We do diagnose PH and manage severe PH crisis in the theater and in the ICU whenever need arises. We talk about ventricular interdependence. We know about the parallel circulation, and we take care of these patients whenever they come and give us the challenging situations. We talk about Fontan physiology, and we talk about coronary perfusion dynamics nowadays. So there are few changes in, there are a good amount of changes in monitoring. Even monitoring revolution has occurred. Nowadays, we use NIRS for almost all patients, especially, and that's norm in patients who are undergoing total circulatory arrest. It's very helpful. It gives us, it tells us to change few settings when we are in the operation theaters. Change the situation, change the cannula. We have to change the strategy if the NIRS goes down in the theater. We do have a functional echocardiography. Most of us are blessed to have echocardiograph, which is available round the clock for managing these patients. We do have TEG and ROTAM. At our place, we do as and when required, but many centers, they are doing TEG and ROTAM routinely. Point of care ultrasound has become part and parcel of our management. Lactate kinetics has played a significant role in improving the results in these patients. And we do assess the dynamic preload whenever need arises in the operation theaters. So we have moved from static numbers to the dynamic physiologic interventions. I can say that, last decade or last 15 years or so was echocardiographic era. All the, anesthetists, intensivists, the critical care physicians, they are well versed with echocardiography nowadays. They help us to make the surgical decisions. Many a times, the residual lesions are diagnosed in the operation theaters. Immediately we go on pump, take care of those lesions, and then we try to come out. Volume, echocardiography help us to assess the volume in the theater, in the ICU. They help us to see the ventricular function. Usually we see the ventricular function, we see residual lesions in the theater and decide about early extubation in these patients. PH management, echocardiography, echo has a significant role or very important role when we manage patients with PH. And they help us to take the ECMO decision whenever need arises. So the modern pediatric cardiac intensivist is increasingly a hemodynamic echocardiographer. And echo has become a stethoscope of modern cardiac intensivist. So there is a major paradigm shift. Earlier, like as I said, we used to ventilate like whenever a patient arises in the ICU, 24, 48, sometimes 72 hours of ventilation, 72 hours of paralyzation was the norm, but that has changed. Nowadays, we try to extubate the patient either in the theater or in the ICU. I mean, sometimes, this extubation and the shift in our strategy has helped us to reduce the opioid use. It helps us to mobilize these patients, these babies in the ICU. The fast tracking has helped us to continue our goal-directed ICU recovery. Early feeding is a norm. Usually, whenever we extubate the patient in the theater, we start the feed within few hours after the surgery. There is a reduction in the delirium. So good surgery, good regional block, usage of multimodal analgesia and teamwork has given a successful fast tracking in pediatric cardiac surgeries. So that has successful fast tracking has reduced the ICU stay. It has reduced many ventilator complications. It has reduced hospital stay, and resource utilization is better with fast tracking. So fast tracking is a physiology dependent, it's not ideology dependent. There is a rapid growth, as Dr. Khushbu mentioned earlier, there is a rapid growth in usage of regional blocks in these patients. We do use a parasternal block, ESP block, serratus plane block, rectus sheath block. But as our patients are pediatric patients, we mainly rely on the caudal block. So all these blocks have helped us to reduce the opioid requirement. They help us to improve the pulmonary mechanics. Early extubation is a norm, and sometimes early discharge and improved ERAS is seen with all these techniques. Modern dedicated ICU, we have different goals nowadays. Neuroprotection is the primary goal. Minimization of sedation is the secondary goal. We try to reduce the delirium. We try to improve the sleep of our babies whenever we are in the ICU. Most of the times it's a family-centered care. We are allowing parents to stay with the patient even if chest is open. At many centers, they are there around the clock. This has improved the results. This has reduced the mortality. And most of the ICUs are development-sensitive ICU. So we no longer support the organs, we are promoting the recoveries. We are now increasingly judged not only by mortality, but also by neurodevelopmental outcomes. So in leading Indian programs, routinely perform various neonatal surgeries. We are well versed with hybrid procedures. ECPR is a norm at many places. ECMO retrieval is done. Pediatric VAD programs are active at many centers. Transplantation is routinely performed. India has also made remarkable progress in neonatal surgeries, ECMO, transplantation, and advanced ICU care. We could achieve this because of better surgery, good cardiopulmonary bypass machine, availability of echo, availability of modern ICU care, and teamwork. So there is excellence. Excellence does exist in India, but the access to the patients is uneven. We are centered towards these 5-6 metros. So there are, though the picture is rosy, but there are still challenges. There is uneven distribution of the expertise. That's giving issue at many places. Late presentation still present in India, and many centers face problem because of late presentation. Financial constraint is the biggest problem, and many centers are facing workforce shortages. Burnout and emotional exhaustion is very common among the physicians. So, the issue with the neurodevelopmental gap, we are not sure about the cognitive outcome. We have not done many long-term studies, especially in India. We are not sure about the school performance. We are not sure about the behavioral disorder in these babies. Sedation effect, long-term effects of sedation, we are not aware. ICU delirium is common, but with ERAS, it's coming down gradually. And we're not sure about long-term quality of life in these patients, though many patients are going to the school, colleges, but long-term outcomes are, we're not sure because we're not studied them widely. So the future is, future is bright. There is a huge role for AI-assisted hemodynamic monitoring and manipulations. At our place, like I can see the all patients monitored by sitting at home. Even sometimes we get a call at 4 in the morning saying so-and-so hemodynamics are not good. So we are reached to that level. There is a role for predictive analytics. Hybrid interventions are going to go up gradually. Our care is brain focused nowadays, and we need to be more integrated. So the future of pediatric cardiac care will not be defined by technology, but by the teams that perform the survival into the life. Thank you. Thank you, Team Apollo, for giving me the opportunity again. Thank you, ma'am.
Thank you, Dr. Shankar, for excellent presentation to show the evolution of pediatric cardiac surgery patients. It was possible because of the multiple progress in multiple fields, in multiple directions, and because of the teamwork. So we have reached to this stage, but still we are facing many lacking points, and I'm sure that in future we will overcome these. You want to come?
Excellent presentation. I just wanted to add a question. Do you all conduct camps in rural India where you pick up the patients and get them to Kokilabin?
Yeah, ma'am. So, ma'am, our cardiologists, consultant cardiologists, associate consultants, they do conduct the camp in rural India. Rural Maharashtra basically. We go to Latur, we go to Dharasiv, we go to Solapur, ma'am. Then Jalgaon OPD is present. Apart from these OPD, we have one OPD in Baroda and one OPD in Jaunpur, UP. So, yes, Satara, so Satara has stopped for some reason, ma'am.
Sir, just developmental outcome of the kids. Are we doing anything for it at your institute?
Actually, ICMR funded program is ongoing, but that will take long time, and that's just at basic level. So India is lacking in these long-term studies. We are not sure about their school performance. We are not sure about behavioral disorders which we face. Because see, if you see a Norwood patient, his chest will be open for say 5 to 6 days. Then we will be giving lot of sedations, lot of hypotensions we see in the theater and in the ICU also. All these effects, they'll have some effects on the brain. We're not sure because we lack long-term studies in these babies.
Sir, this NIRS and all, are we using in ICU also? Like if the patient is say high risk, kuch arch repair care, so are we shifting the patient with NIRS in ICU?
So we have, we have 2 theaters, dedicated theaters to cardiac surgeries. If we are not using and if it is required in the ICU, we do use. Otherwise, same, probe we can continue using in the ICU.
And we are using it for brain function monitoring only.
Yes. So most, it's helpful whenever during the cannulation, you will see a sudden fall in NIRS values. Or sometimes during the TCA, if TCA is prolonged, it goes down immediately. So that gives our surgeons nowadays decides this TCA time depending upon the NIRS. If it goes below, very low to the basic, say 50% of the basic, then usually our surgeon go back on circulation, they perfuse for some time, and then they again initiate the TCA.
I think for neurophysiological improvement, if you want to see, then we should need the separate team to assess and to follow up and all. By considering that you are working in theater and managing these cases, it is difficult. You cannot do that. So that is the manpower lacking is there. Thank you very much. Thanks.
I think, shall we invite the next speaker for the next talk? Yeah.
I would like to request Dr. Sushil Raut to felicitate Dr. Shankar Kadam. Dr. Sushil. Dr. Sushil. For next presentation, I would like to ask chairperson to introduce the next speaker, Dr. Soumik Ghosh. Dr. Shilpa.
Where is the CV? Your CV is not coming up. Okay, anyway, we have Dr. Ghosh, na? So, Dr. Soumik Ghosh, who is going to be, he's from DY Patil, and he's going to be talking on remifentanil. Exactly. The slide is not displayed.
Good afternoon, everyone. So I'm Dr. Souvik from DY Patil Hospital.
So on behalf of the chairpersons, I have pleasure in inviting you to talk to us on remifentanil.
Yes.
Personally, a drug which I've read but I've never used, so I'm sure it's going to be very interesting.
Okay. So I like to congratulate Apollo Hospitals, Navi, Mumbai, and ISA for inviting me here, and I'm really honored to be here. So now with modern day anesthesia, we are quietly ensuring that patient safety is fast and the faster recovery is very important for every patient. So I do not have any relevant financial relationship with commercial interest. Okay. So why remifentanil? So because remifentanil has very quick onset and offset and very safe in renal and hepatic impairment, excellent control of blood pressure and heart rate, and reduce anesthetic agents and relaxant. Even in some of my case, I don't use any relaxant or even propofol or ethomidate. I don't use induction agent also. I can intubate the patient with only on remifentanil as well. And transient side effects and almost 3 decades of experience. Like Remi is introduced to US, they started using it in late 90s, and in India it has come last 1-2 years back, and we are using it for almost 1.5 years. And better use of OT and OR time, and each minute saves around lot of money for other patients. Just imagine one case is getting over, and immediately you are in next case is coming in the OT. So you can do instead of 7, 8 or 9 or 10 cases a day. So regarding the pharmacokinetics, it's a strong mu receptor agonist, antagonist by naloxone, Equilibrium between plasma and its effect site compartment is around 1 to 1.5 minutes, and it metabolized by ester hydrolysis with termination half-life of around 3.8 to 8.3 minutes. Major metabolite of remifentanil acid is no significant effect after metabolization and not affected by pseudocholinesterase deficiency as well. So remifentanil is available in 3 forms in India. One is 1 mg vial, 2 mg vial, and 5 mg is not available in India. So mainly 1 and 2 mg we are having it in our setups in India. And how we are going to prepare the drug? So I use it in 0.9% saline or DW for you can keep it for 24 hours, and concentration mainly you can keep it as 50 mics per ml or 20 mic per ml. 1 mg, if you use a 1 mg vial, you can dilute into 20 ml saline. That will give you a concentration of 50 microgram per ml. And if you are using a 2 mg vial, then you 4 ml dilute into 40 ml. So it will be total of 50 microgram per ml. Okay. So mode of drug delivery, this has to be infusion only. We never use boluses. And you can use it via TCI pump, which PK models are already, pharmacokinetic models are built in, and it acts as artificial intelligence, and it like a GPS. Everything is in, you just need to put the data, and it will do their job automatically. And you can use it in normal infusion pump also. So I'll tell you the tricks and hacks how we are going to do it in normal infusion pump as well. So when you use the TCI pump, you just enter the drug, you choose from the TCI list that this is the remifentanil, and after you choose, you need to select the TCI mode. So it can be either effect mode or it can be a plasma mode. Better to use in effect mode because it acts on the mu receptors in brain. So you choose the effect mode basically. And then you need to put 4 hemodynamic, 4 demographic data of the patient. One is the height and weight. Then you can put the E target, how much effector site concentration you want, like 1 nanogram per ml or 2 nanogram per ml, and the concentration of drug and max rate of so and so. So in TCI, we use 2 models. One is Minto, which can be used for 12 to 90 years, and or Elevate model, which can be used for 1 to 99 years. And start with effect site concentration of 1 to 2 nanogram per ml and during the pre-oxygenation, and then increase to 4 to 5 nanogram of effect site concentration gradually and during the induction. Usual intraoperative dose is around 4 to 6 ml. During that concentration, patient will be fully sedated and they will tolerate the tube absolutely fine. There should not be any hemodynamic problem at all. So advantages of using TCI, this is pre-calculated in 3 compartment models, and with the clearance they will calculate how much ml per hour it will go. So the machine will automatically calculate and it will deliver the drug to the patient. Ability to increase analgesic depth quickly, and machine gives automatic adjustment as per the patient need. And consider nociceptor monitoring as well. Okay. So if you do not have a TCI pump, then there may be a lot of difficulty to calculate how much ml per hour we are going to give it. So there is a very simple formula, weight in kg into 0.12. That comes around 0.1 microgram per kg per minute. So that will give you the ml per hour per minute. Okay. So suppose a patient is coming with you and 70 kgs. You can calculate it as per 70 kgs into 0.12 is equal to 8.4 ml per hour. So that comes around 0.1 microgram per kg per minute. And maintenance, you can increase the dose up, you can double the dose, 0.2 to 0.3, and you can use it that way. I'll just give you an example so you will understand how to do that. So passive TCI with a simple infusion pump practice. So what we can use the SimTiva app. There are a few apps. I like that app called SimTiva app. That will give you the concentration, how much ml per hour you have to give. And it will automatically, you need to put it in the normal syringe pump and you can use it. And there are Tiva Trainer, iTiva Anesthesia Plus, and Keep IV Cannula in View, Anti-Flux Valve. So these are few other softwares which you can use to calculate the rate. So this is, I'm using the SimTiva app. So in the SimTiva app, you can put the age, the 4 demographic data, age, weight, height, gender, and the model. You can choose the model, and remifentanil, Minto, the concentration of the drug, whatever you are preparing, either 20 mics per ml or 50 mics per ml, and it will automatically calculate the BMI. And next, you can see you have to choose the CP targeting or CE targeting or manual or intermittent bolus, and it will show you the ml per hour, how much ml you have to give per hour in the normal pump. So common side effects of remifentanil is, like you can see, it's ultra short acting, so all the side effects will be self-limiting mostly. Bradycardia when we are using with dexmedetomidine or beta blockers. Apnea and during you are using it for the induction, it will cause apnea, so you need to pre-oxygenation and ventilation is needed most of the time. Or when you are using it for sedation purpose, 1 to 2 nanogram per ml CP target, then you have to ask the patient to breathe during pre-oxygenation. And it can cause hypertension with other agents. And so one thing is very important, is remifentanil is very short acting, so all the side effects we're going to wear off very soon, so nothing to worry according to that. So short or long acting opioid, according to the surgery, you need to use. Ensure long acting analgesia once you are shifting the patient out of the theater, and local anesthetic or surgeon, and you need to give regional blocks before you, shifting the patient to ICU. You can shift the patient on remifentanil infusion as well, and regular adjuvants you need to be given. So you can see this graph of consequences half-life. So if you are using it remifentanil for even hours, 4 hours, 5 hours surgery, if you are using it, then also patient will wake up just after you stopping the infusion. Within 4 to 5 minutes, patient will be awake. Maximum 10 minutes, the patient will be awake. You can see in the graph with diazepam, fentanyl, dexmedetomidine, other infusion, they take hours to, wake up. So you can see that remifentanil, the concentration half-life is very low. It's around 4 minutes only. So if you are using it for 8 hours, so the patient is going to be gradually awake within minutes. And this helps for even fast-track cardiac outcome. So why it can be used in excellent hemodynamic control? So it reduces blood loss, it causes hypotensive anesthesia, it can ease across the specialty of anesthesia, you can use it for every cases. Reduce use and avoid use of muscle relaxation like scoliosis, thyroid, parathyroid, everywhere. Laparoscopic, robotic, and even thoracic, cardiothoracic, neuro, all cases you can use for all the surgeries. You can use for airway surgeries also, it is excellent, and it avoid unnecessary use of longer acting opioid like regional and others, and saves over time almost significantly. So key benefits of remifentanil in cardiac anesthesia. So this is the ultra short acting, and enables rapid recovery and early tracheal extubation, and fast-track cardiac anesthesia, you can immediately do it. Rapid onset and offset, allows precise intraoperative titration, ideally for hemodynamic unstable patients. Then reduce mechanical ventilation time, because meta-analysis shows more than 139 minutes shorter ventilation than normal conventional approach. Shorter hospital stay, reduces hospital stay days also. Cardioprotection significantly reduces post-operative cardiac troponin I levels release, and also hemodynamic stability you can see greatly with the minimal histamine release, and maintains stable heart rate and BP, attenuates stage response to CBP, and also response to intubation. Organ independent metabolism, so that will also help in renal failure patients or in hepatic impairment patients. And suppress stress response, elevated blunts, normal hormonal stress response during CBP and surgical insults, and reduce nausea, vomiting, lower incidence of nausea, vomiting compared to other opioids. So fast-track advantage is there. Remifentanil is more effective than fentanyl and sufentanil, reducing the time to extubation and the recovery area stay in fast-track protocols. So due to its rapid onset and proactive post-operative analgesia, long-acting opioid overlap is needed, and otherwise it can give you rebound pain. Given your expertise in cardiac anesthesia and critical care, the properties make remifentanil particularly valuable for ICU patients for myocardial protection and also cardiac surgery cases. So take-home messages. So it's a standard dilution is 50 microgram per ml. Always use an infusion, TCI or mLs per hour. mLs per hour is 0.12 into body weight. Usual TCI dose is around 1 to 5 nanogram, Minto or Elevate, any of the model you can use. keep IV access visible and anti-reflex valve should be there. Apnea and bradycardia is one of the side effects. Flush the line always and ensure long-acting anesthesia before at least 10 to 15 minutes after stopping the REMI. So you can see this in this slide. So in 2010, everybody used to see this 100 rupees, 1000 rupees note, 2000 rupees note. Nobody would have thought that time ki there will be UPI coming up. And if I would have tell you in 2010 that there will be some system from where you can use only your phone and you need not carry your wallet at all, that is kind of drug remifentanil. I know in future, most of you will switch to remifentanil gradually and it will be the future. I want to talk about little more, one more slide. Just another new drug is coming, which is called remimazole. That has a pharmacodynamic property of midazolam and pharmacokinetic property of remifentanil. So you can see here the sedation time is absolutely 10 to 14 minutes. So all cath lab procedures, all MRI procedures, short procedures can be done with only single drug. And even surgeon can give this drug alone and they do not call the anesthetist or us. Okay. And the elimination half-life is very short, 37 to 53 minutes. Metabolism is also estrus depressant like remifentanil, and it doesn't have any respiratory depression. It has, but at very high doses. So patient will breathe on their own, and patient will be sedated, and you can do whatever you want to do with them, like upper GI scopy, ERCP, everything can be done with only one drug. And it is already FDA approved. My friends are US, they are using it in sedation for all the cath lab procedures and other procedures. But this is very short acting, cannot be used in the ICU. So even ICU procedures can be done. You can put a central line or you can put any blocks under this coverage of remimazole. The dose is around 2 to 5 mg bolus over 1 minute. And I think soon it will be available in India. We are also working on it. Sir is also working on the drug for it to bring it in India very soon. Okay, thank you, sir. Thank you.
Thank you very much. Any questions from the audience for the speakers?
So in ICU, ma'am, with normal infusion pump, you can just use that 0.12 into body weight, and you can use it for prolonged hours. Like you can use it for 8-10 hours also. And if you have TCI pump, I would prefer using Minto than Eliveld, because Eliveld contains propofol also, which can cause propofol infusion syndrome. You are using it for more than 48 hours. It is in micro. Yeah. Yeah. No.
So if you are calculating in microgram, that means you are giving very high dose of remifentanil.
No, I'm talking only about remifentanil. I'm not mixing. Yeah. No, 8.5 ml per hour. That is ml per hour. And
Concentration is 1 in 20 or 1 in 2 in 40. So it's 50 microgram per ml.
or you can make 1 mg dilute into 50 cc. So that is 20 microgram per.
I see all over worldwide, it is 1 in 20, 2 in 40. That is the standard.
Standard.
And they don't use this infusions at all. It is only TCI.
TCI.
Remi is meant only for TCI.
Yes, ma'am.
And you cannot intubate patient only on the Remi. It is propofol
And Remi also. Itomirate. Ma'am, sometimes I do intubate with Remi with minimal dose of ethomidate, like 4 to 5.
So you can't intubate only with
Only means.
because if you give very, and for inductions, you sometimes need very high dose up to 8 nanogram per ml.
7 to 8 generally. CP targeting.
So in that case, you find tremendous bradycardia.
Bradycardia and muscle spasm also if you go beyond 8, 9. Yeah.
So ideal practice is like you start little propofol and then start Remi. So you don't get just one.
Yes.
Just when your patient is under, you can give raw.
Yes.
Other thing, how do you monitor whether patient is fully asleep?
So you can use.
No,
So we just check their sensor human response. We tap the patient and ask whether they're awake or not. We use pupillary reflexor.
Patient is under. You are on Navi. Patient is under. How do you know patient is fully asleep, or in anesthesia, how do you know patient is fully asleep?
We use bees also. In some, we use bees also. So their bees, we are maintaining below 40.
And the other one is process EEG you can use.
Yes.
This will give you how much is, like whether he's asleep, but process EEG will tell you exactly how much dose do you need of remifentanil.
Yeah, definitely.
So you can save lot of drugs.
Yes, ma'am.
And in Elevate, there are three models, Schneider and Minto, or Elevate for both.
Yes, ma'am.
So with Schneider, you get high response, high propofol delivery, and Remi, but later on it maintains very smooth
Reco-
of effect.
Yes, ma'am.
So that you don't have to give too much Remi and Propo.
Yes.
But in Elevate, you need high dose of both the drugs.
Both the drugs, yeah.
So the delivery and the consumption is more as compared to Schneider and Minto. And the advantage of Elevate is there is another company, Argomed.
Yes.
If you, like it is, they have some sensor. If you put Elevate in the top one, propofol, the same everything will be patient's age, height, weight, everything will be calculated.
Yes.
So that is the advantage.
Yes.
Nowadays abroad all these pumps are like automatic.
Automatic.
There's a sensor, like if your age is 70, 100 kilos, height is some 170 centimeters, so the same thing will be calculated, and it will calculate the dose of Remi.
Yes, ma'am.
Excellent presentation. I think we wind up the session. You monitored your glucose levels?
Yes, also because
It's
Remi
better with Remi compared to
yeah,
fentanyl?
Remi controls it prevent the insulin release also. So it's you can get hypoglycemia with remifentanil.
I just want to comment one thing, that when you are shifting the patient, if you are giving remifentanil, so you have to continue the remifentanil during shifting also and taper after reaching to ICU. Otherwise, your blood pressure is going to rise because you are not giving anything else. Or you have to give something else before shifting the patient.
Yes.
So to prevent that thing, you have to take care of the patient.
Yes.
Thank you.
I would like to request Dr. Vaibhav to felicitate Dr. Soumik Ghosh. One minute. So I would like to request Dr. Meera and Dr. Kanchan to felicitate chairperson. So we move on to our next session on interesting case presentations. For chairperson, I would like to invite Dr. Santesh Kaushik. He is a renowned cardiothoracic and vascular surgeon in Apollo Hospital, Navi, Mumbai. With over 30 years of experience, he is highly regarded for the performing thousands of complex heart and vascular surgeries and has trained at prestigious international institute, including Boston Medical Center and Royal Melbourne Hospital. Dr. Vaishali Badge. She is a highly experienced senior consultant cardiac anesthetist. She is active executive committee member of AECTA, and she has many degrees from UK and ICMO from Paris. Dr. Ashwin Solankamble, he is associate professor in JJ Hospital and Grant Medical College, Mumbai. He has more than 15 years of experience and contributed to handling numerous complex medical cases. Dr. Santesh, I would like to call upon Dr. Latika for the case presentation.
Good afternoon, everyone. I am Dr. Latika, and I am the junior most cardiac surgeon here at Apollo. Before I begin, I would like to thank Dr. Saurabh Tiwari sir for this opportunity and for the exceptional surgical learnings that I get from Dr. Santesh Kaushik sir, Dr. Jadhav, and Dr. Sachin. So this case is a rare surgical salvage case which had a late onset infected RCA pseudoaneurysm following PCI. Hello, sir. So when we hear about post-PCI complications, most of us instinctively think in terms of hours, days, or perhaps a few weeks. This patient challenged that assumption. He was a 63-year-old gentleman who presented 1 year after balloon angioplasty and stenting of the RCA. His symptoms were deceptively non-specific: persistent right-sided chest pain, intermittent low-grade fever, malaise, and approximately 10 kgs of unintentional weight loss over 3 months. He appeared cachectic, but then importantly remained hemodynamically stable. Blood cultures were inconclusive, making the diagnosis even less obvious. What immediately raised concern for us that with the combination of constitutional symptoms and prior coronary instrumentation, most of us initially would pursue our diagnosis as malignancy, chronic infection, or some underlying inflammatory disease. However, imaging revealed something different and far more unusual. Cross-sectional imaging demonstrated a massive multiloculated cavity measuring 9.6 into 5.6 centimeters extending along the RCA course with massive mass effect on the RA, RV, and the right AV groove. There was associated pericardial thickening and reactive effusion. This is the coronary angiography. The left-sided circulation. And this is the RCA. So the coronary angiography now demonstrated complete RCI occlusion with a large pseudoaneurysm. This was the first teaching point of this entire case. Delayed infectious coronary complication exists, and they may masquerade with constitutional symptoms rather than actual cardiovascular disease. The question that drove our management was not whether this was infected, because it most certainly was, but how much anatomical destruction had already occurred and whether definite surgical reconstruction was even possible. For me, this was the central diagnostic lesson. Unexplained fever, weight loss in a prior PCI occasionally should make us think about infected coronary hardware even when the intervention was performed a year earlier. The imaging findings transformed this from a diagnostic curiosity into a surgical problem. The CT demonstrated a large multiloculated pseudoaneurysm. At nearly 10 centimeters in length, this was not a focal coronary abnormality. This was effectively an infected mediastinal process centered in the RCA territory. Coronary angiography added another crucial piece, complete RCA occlusion with a large pseudoaneurysm and no flow through the vessel. At this point, several management options could have been considered. Could prolonged antimicrobial therapy would suffice? Or could percutaneous drainage be an option? Or could endovascular exclusion be considered? In our view, the answer was no. The imaging strongly suggested a chronic abscess formation surrounding previously implanted coronary hardware. Once you have a large infected cavity, probable biofilm formation, and complete coronary destruction, source control becomes the primary principle through surgery. What was particularly striking in retrospect is how accurately the imaging predicted the operative challenge that we will see now. For experienced surgeons here, the case reinforces a familiar principle, that imaging is not merely diagnostic. The CT scan was already telling us that conventional cannulation and straightforward RCA reconstruction will most likely not be possible. The operation would need to be designed around the anatomy revealed by the scan. So of the three surgical principles that I have learned in this case, this is perhaps the most immediately transferable. Preoperative imaging demonstrated a large inflammatory mass compressing the RA. We anticipated difficult exposure and a potentially hazardous dissection around the RA and the RV groove. Standard central cannulation became, from the outset, risked entering a very hostile operative field. Hence, our solution was deliberate. Before sternotomy, we proceeded to definitive dissection of the femoral vein and exposed and prepared it. After obtaining safe exposure of the aorta then, after performing the sternotomy and careful adhesiolysis that we will just see, cardiopulmonary bypass was established under femoral venous drainage, under TE guidance, and central aortic cannulation. Why this matters is because of this particular anatomy, decompression will create the working space. It reduced tension on the compressed right-sided structures and improved safety during subsequent dissection around the pseudoaneurysm. This was not a technical maneuver, it was a strategic one. The broader lesson in this case now is that cardiopulmonary bypass strategy should be customized to the pathology that we had encountered in this case. The anatomy will dictate the setup and not the other way around. What we see on the screen here, this is the femoral venous cannulation, and there you see the aortic purse string where we've only managed to open a very short part of the pericardium and taken the aortic purse string. Now, this was the moment in the operation that none of us expected. After institution of the bypass and cardioplegic arrest, we continued extensive adhesiolysis along the right AV groove. The pericardium was markedly thickened and densely adherent over the aorta, over the RA, RV, and the RCA territory. As the dissection processed, we entered a large epicardial cavity filled with thick, purulent material extending longitudinally along the course of the RCA. The vessel itself was completely destroyed. There was extensive infective necrosis, chronic occlusion, and complete structural disintegration of the RCA. Reconstruction, hence, was no longer an option. Then came the most defining finding. Within the abscess cavity laid the previously implanted coronary stent, not partially exposed, not protruding through the wall. It was completely self-extruded into the purulent cavity. For surgeons, this finding provides direct pathological evidence of what chronic infection does to coronary tissue. The vessel wall had been so thoroughly destroyed that the stent no longer had a vessel to actually reside in. At this point, the operation became one of source control. Every infected and necrotic component had to be removed, extensive debridement and irrigation was performed, and the dilated RCA ostium was identified and subsequently closed using pledgeted 4-O proline. The lesson here is straightforward. Once extensive infective destruction is present, attempts at preservation becomes less important than radical eradication of diseased tissue. This was not coronary reconstruction then. In this video, I want to show the dense pericardial adhesions that we were seeing over the right-sided structures. This was before we arrested the heart. And here in this video, you can see the RCA stent that was completely lying out of the RCA. In fact, there was no RCA that is actually visualized here. It was that abscess cavity and the stent that was extruded out of it. The final challenge was determining how to restore myocardial perfusion once the infected RCA had effectively ceased to exist. So in this video, this is just the ostium of the RCA that was eventually just closed off inside that abscess cavity. And these were the specimens that were collected. So after debridement, it was clear that the native RCA was unsalvageable. The artery was chronically occluded, structurally destroyed. Reconstruction of infected tissue would no longer be durable nor safe. The critical question became whether a suitable distal target would remain. Fortunately, despite extensive proximal destruction and inflammation, the posterior descending artery was preserved sufficiently to permit bypass grafting. So a reverse saphenous vein graft, as we see here in this image, was grafted and anastomosed to the distal PDA, and proximal inflow was obtained from the aorta. This decision actually sounds straightforward in retrospect, but those who perform this operation regularly know how difficult it is to find a usable distal target in a chronically inflamed field. The tissue planes are distorted, the landmarks are gone, and the risk of incomplete debridement competes with the need to achieve durable revascularization. Fortunately for us, this patient recovered remarkably well. He was extubated within 6 hours. All his inflammatory markers were normal in his postoperative period. The culture specimens that were sent for histopath and the cultures revealed Pseudomonas and non-tubercular mycobacterium, for which a prolonged antibiotic therapy was given. At 2-month follow-up, this patient came to us with significant weight gain, no symptoms. The echo revealed no recurrence of the pseudoaneurysm. So I would like to leave the audience with a single principle from this case, that rare cases are valuable because they expose universal truths. It was the reminder that even a seemingly remote PCI can become the origin of a devastating infectious process, and that successful salvage depends on adapting surgical strategy to anatomy, biology, and infection simultaneously. Thank you.
So because of time constraint, we'll take question. No, sir. More case presentations are there. So Dr. Shantanu. He's there. I will request Dr. Ashwin to felicitate Dr. Latika. I would request Dr. Shantanu Marketkar to present his case.
Good afternoon, everyone. I'm Dr. Shantanu Marketkar, MD Anesthesia. Today I'll be discussing about a case of a patient with a long QT syndrome who was posted for FES surgery, functional endoscopic sinus surgery. So this is basically about a patient, 37-year-old male, who was scheduled for FES septoplasty due to extensive sinonasal polyposis with DNS and had a chief complaint of right periorbital pain and swelling. So on pre-anesthetic assessment, we knew that this patient was a known case of prolonged QT syndrome on tablet Nadolol 40 mg OD with his recent ECG showing sinus bradycardia and a normal QTC interval. Other than that, he had no other past surgical history, no any other comorbidity. He had no significant family history of a prolonged QT syndrome. This patient, however, weighed 102 kg and had a BMI of 31.4 kg per centimeter square, which posed a considerable risk for airway, anatomically and physiologically speaking. His airway examination revealed an adequate mouth opening with MPC of 3 and a heavy bulky jaw. On investigation, however, his complete blood count, his coagulation profile, his serum electrolytes and serum creatinine were within normal limits. His potassium was around 3.5 at that time. Cardiology clearance was obtained with advice to continue tablet Nadolol perioperatively, avoid any QT prolonging drugs. Defibrillator was to be kept standby. And on examination, his pulse, his vitals, and his cardiac and respiratory was within normal limits. So the goals of anesthesia we had kept in our mind was to maintain hemostasis was the priority, to avoid any hypoxemia, hypocapnia, hypercapnia, or any high pressure ventilation, to anticipate and avoid any sudden hemodynamic fluctuations in heart rate or blood pressure, and to maintain normothermia throughout the surgery. A calm and quiet environment was especially required for this particular case, with alarm volumes lowered, especially during induction and emergence. A prompt correction of all the electrolytes was to be done. For induction of a general anesthesia, we pre-medicated this patient with injection midazolam 1 mg for anxiolysis in preoperative area itself. We shifted this patient to OT with all standard monitors, ASA monitors attached. Oxygen was started to pre-oxygenate this patient. AD paddles were applied, defibrillator was checked and kept ready. An 18-gauge IV line was secured and a plasma light was started. Patient was administered with injection fentanyl 100 microgram to blunt the intubation response. Anesthesia was induced with injection propofol 150 mg in slow graded doses till loss of consciousness, and tracheal intubation was facilitated with injection rocuronium 50 mg. Vocal cords were sprayed with 4 puffs of 10% lignocaine spray, and patient was intubated with a cuffed endotracheal tube 8 number. Anesthesia was maintained on oxygen plus air, sevoflurane 1% to around 1.5%, and injection propofol infusion 100 microgram per kg per minute as a TIVA. Body warmer was attached. The patient was put on PCV-VG mode, and the patient was given intermittent maintenance doses of rocuronium and fentanyl for adequate analgesia and relaxation. The patient was administered injection dexamethasone 8 mg and paracetamol 1 gram intraoperatively, and injection magnesium sulfates were kept standby for any intraoperative cardiac event. Intraoperatively, this patient behaved very well with us, except for the fact that there were intermittent episodes of bradycardia with heart rate falling right up to 50 per minute. However, no active intervention was done at that time. A vigilant monitoring was done with adequate hydration and titrated anesthesia and analgesia. The patient was promptly also monitored for any vagal response to surgical stimulus. The patient was reversed with injection Sugamadex 200 mg. The patient was extubated deep to avoid any rapid emergence response. Patient was shifted to a recovery in a calm environment. Our patient didn't have any complaints of pain, nausea, vomiting, or breathing difficulty. However, we had kept injection metoclopramide and injection tramadol as a rescue analgesic and antiemetic. Due to continued bradycardia with heart rate as low as 45 to 50 per minute, this patient was shifted to ICU for observation after consulting cardiology. And after close monitoring for 24 hours, this patient was shifted to ward and later discharged. The patient was advised Holter monitoring by cardiology and follow-up in the OPD. So let's discuss about this case. So what is long QT syndrome? Before understanding what is long QT syndrome, we need to understand what is QT interval. So QT interval is basically measured from the onset of QRS complex until the end of T wave, and it reflects both ventricular depolarization and repolarization. Now the thing about QT interval is it is inversely varies with the heart rate. So longer at slower rates and shorter at faster rates. So for that what we need is a corrected QT interval, which we calculate from the Bézet formula, which is basically QT interval divided by the square root of RR interval. And you can see a tangent is drawn from the peak of T wave in the figure. And the T peak to T wave and TPE is measured. Understanding the pathophysiology of long QT syndrome. So basically, before that, we need to understand what is the physiology of cardiac action potential for the cardiac myocytes. So there are basically 5 phases. Phase 4 being the phase where the potassium efflux happens and the resting membrane potential is maintained at minus 90 millivolt. In phase 0, there is a rapid sodium influx. In phase 1, there is a potassium efflux. In phase 2, there is a influx of calcium with efflux of potassium, which maintains a plateau phase. And in phase 3, there is a calcium channels close, and there is only a potassium efflux, which brings the resting membrane potential back to minus 90. So where this QT prolongation exactly happens is the phase 3. As you can see in the image on the right side, these are basically the susceptible genes which get affected in congenital LQTS, and most of them are clustered over in the phase 3. What happens exactly is that this increases the propensity for early after depolarizations, some of which reach the threshold potential and can lead to torsade de pointes. So congenital LQTS is basically a potentially inherited cardiac channelopathy which manifests as a prolonged QT interval and a polymorphic VT, which is characterized by torsade de pointes. There are around 17 susceptible genes, out of which type 1, type 2, and type 3 are the most commonest. Type 1 LQTS is basically a T wave with a broad base, and it is most commonly triggered by an exercise, most commonly swimming. LQTS type 2 has T waves with a low amplitude and an additional hump or notch. This is most commonly triggered by an auditory stimulus. For example, when the patient wakes up from sleep from an alarm clock or something. And LQTS type 3 has a long ST segment. T waves occurs late and pointed. This is basically associated with a delayed onset in patients. So what is acquired LQTS? It is basically a preferred expression. So the LQTS which happens because of medications or electrolyte imbalances or disturbances, that is termed as acquired LQTS. Although most cases of acquired LQTS do not have any genetical base, but around 10% of the patients with drug-induced QT prolongation may have an underlying LQTS causative mutation. So before moving further, the most important thing for us for any case is the pre-anesthetic checkup. So as it is as important for trade of Southeast Asia, it's the same thing. The straight of PAC is as important to us as anesthetists. No patient can reach the surgery table without passing through the straight of PAC. So in the pre-anesthetic checkup, we need to follow certain points. We need to take illicit history of any affected family member who has a history of sudden cardiac death or has been diagnosed with a prolonged QT interval or a prolonged QT syndrome. Other than that, we need to find out any triggering factors like sports participation, which cause the patient to have palpitations, arrhythmic syncope, or in certain cases, sudden cardiac death or cardiac arrest. After obtaining a comprehensive and personal history, we need to do an ECG, 12-lead ECG, which will give us the QT interval in that. And there is something called the Schwartz score, which will give us the probability of what is the probability of this patient having LQTS syndrome. So it goes like this, that there is a low probability, which has a score of less than 1, intermediate probability, which is a score of 1.5 to 3, and a high probability, which has a score of more than 3.5. And it takes into account the following points, like the history of LQTS, unexplained sudden death in the family, congenital deafness, the QTC calculated from the Bezet formula, or incidences of torsade de pointes, T-wave alterance, or bradycardia. So in preoperative anesthetic management, basically we need to assess again the metabolic. We need to keep the metabolic and electrolyte hemostasis, that is hypokalemia, hypomagnesemia, hypocalcemia, hypothyroidism. All these should be corrected prior to the surgery. Chronic beta-adrenergic therapy, which in our case was injection tablet nadolol, it should be continued as it is the mainstay of the treatment of congenital LQTS. And this therapy inhibits both prolongation and dispersion of repolarization, reducing the rate of malignant arrhythmias. And apart from that, we as anesthetists should avoid any QT prolonging drugs perioperatively. So a risk-benefit analysis should be made among these drugs, and we should hold off the drugs which are to be completely avoided. So which are these QT prolonging drugs? It's a very massive list, and I'm sure it will be very difficult for all of us to remember all of this. So to narrow it down, there is an article in BJA which has concised and made a table where they have mentioned the drugs which are related to anesthetists. And there are, on the left-hand side, there are preferred agents. Then there are the agents which should exercise caution in. And then there are the agents which should avoid altogether. The agents which should avoid altogether are dexmedetomidine, epinephrine, ketamine, sufentanil, succinylcholine, pancuronium, glycopyrrolate, atropine, and a spinal anesthesia to the level of T10 and epinephrine. So to discuss further about the drugs, So opioids are said to be considered to be having no effect on QTC interval when used at clinically relevant doses. Apart from that, it has also been shown to attenuate the QTC prolonging effects of laryngoscopy. The antiemetic drugs like 5-HT3 are very popularly used antiemetic drug. Ondansetron is known to cause QT prolongation in perioperative doses. So that is to be avoided. Instead of that, we could go to alternatives like dexamethasone. Dexamethasone has the potential to suppress the LQTS phenotype.
I think you've exceeded your time. Can you just cut down?
Okay. Yeah. So this is basically succinylcholine has been shown to increase QTC syndrome, and non-depolarizing muscle relaxant do not cause QT prolongation. Rocuronium is a good alternative, and Sugamadex has extensively been studied to cause no significant effect on QTC. So this is basically the intraoperative drugs which can be used safely. Intraoperative management, which we have discussed further, it is the same which we had given. So what could have gone wrong was the patient could have landed in torsades de pointes. This torsades de pointes could have degenerated into ventricular fibrillation, and in worst cases, it could have caused in cardiac arrest. So the management of TDP was basically IV magnesium sulfate, a single dose of 2 gram or 8 millimoles. In cases where there are multiple self-terminating episodes or hemodynamically stable patients, the transverse overdrive atrial pacing could have been done, and in pulseless arrhythmia, CPCR guidelines should be followed. So just to conclude, there are many cases which have unremarkable perioperative courses, but however, the risk of arrhythmias, particularly TDP, cannot be overlooked, and a detailed PAC and vigilant monitoring and recommended management through various case reviews would help clinicians tackle this perioperative scenario. Okay, thank you.
I would like to request Dr. Thomas to felicitate Dr. Shantanu. Next case will be presented by Dr. Srirag. He's our first year DNB student.
Good afternoon, everyone. My name is Dr. Srirag. I'm first year DNB student. Before I start, I want to thank the organizers, ACTA, ISA, and Apollo Anesthesia Department for giving me this opportunity to present. Today, my topic is about concurrent TURP syndrome and perioperative myocardial infarction in an elderly patient. So, background is that TURP syndrome and perioperative myocardial infarction are uncommon but potentially fatal complications in non-cardiac surgeries, particularly among elderly patients. While TURP syndrome results from systemic absorption of hypertonic irrigation fluid, PMI is frequently due to myocardial oxygen supply demand imbalance or acute coronary occlusion. The concurrent presentation of these entities is exceptionally rare and diagnostically challenging. So the case is an 81-year-old male scheduled for TURP is due to benign prostatic hyperplasia. So the preoperative anesthetic assessment showed that the patient was a known case of hypertension, and he is taking tab amlodipine 5 mg OD. He has normal ECG and normal echocardiogram, and cardiology clearance was given for surgery. He has no past surgical history or any other comorbidities. His airway examination revealed adequate mouth opening with MPC grade 2. And other blood investigations, including CBC, coagulation profile, and creat was within normal limits. The choice of anesthesia is subarachnoid block. Due to its little anesthetic is required. Physiological disturbance is minimal. Patient remains awake, and mentation can be assessed regularly. Respiration is affected only to the minimum. Early recognition of complications will be present, and peripheral vasodilation helps reduce circulatory overload, and overall morbidity and mortality is low. So this patient was induced with 25 gauge Quincke's needle under all aseptic precautions with injection bupivacaine heavy 0.5% with a volume of 2.5 cc. Spinal level of T10 was achieved. Warming blanket was placed to avoid hypothermia. Hemodynamics were well maintained. Lithotomy procedure was given. TURP was performed under spinal anesthesia, and the irrigation during the procedure, 1.5% glycine was used. Approximately 40 minutes into the procedure, the patient developed acute chest discomfort, bradycardia with heart rate of less than 30 BPM, hypotension, repetitive yawning, and drowsiness. Oxygen saturation remained 98% on room air, and the patient was alert and oriented. The initial management, the procedure was immediately halted to prevent further glycine absorption. Standard anesthesia protocols were followed throughout, including ECG, NIBP, and pulse oximetry monitoring. The patient was administered with ephedrine, and 500 ml of normal saline. A repeat 12-lead ECG was performed, which showed an ST elevation in leads 2, 3, and AVF, which was consistent with acute inferior MI. An ABG was taken, which revealed the serum sodium of 105. Given the absence of seizures, confusion, or respiratory compromise, intubation was deferred to avoid increasing myocardial workload. Instead, 3% hypertonic saline was started at 50 milliliter per hour, targeting a correction of 1 to 2 milliequivalents, not exceeding 8. Subsequent management is that an arterial line was taken, and for continuous blood pressure monitoring, tropi was sent, and it was found to be elevated. Hemoglobin was normal and ruling out significant bleeding. The patient was immediately transferred to cardiac catheterization within 20 minutes after symptom onset, and informed consent was taken from relatives. The angiography revealed a triple vessel coronary artery disease with a 90% occlusion of the RCA territory. The drug-eluting stent was placed under the monitored anesthesia care. The patient remained stable throughout. Outcome, the patient was monitored in the ICU post-procedure. The sodium levels improved to 125 within 12 hours and normalized to 135 by day 3. The ST elevations resolved on repeat ECG. He remained hemodynamically stable, required no inotropic support, and was transferred to the ward on day 3. And was subsequently discharged on day 7 with normal neurological and cardiac functioning, and advised regular follow-up with cardiology and urology. So TURP syndrome. So in resection of the prostate, what happens is that there's an extensive network of venous sinuses, which allows the irrigation fluid to be absorbed into the systemic circulation. So TURP syndrome, this causes an hyperdynamic circulation and circulatory overload. Approximately 1 to 8% of TURP surgeries may have TURP syndrome. Recent larger studies have demonstrated lower incidences of between 0.78 and 1.4% with mortality rates of 0.2 to 0.8%. The development of the syndrome can be from 15 minutes of state procedure to 24 hours post-procedure as well. The syndrome of overhydration consists of triad of signs, which can be seen as bradycardia. There can be elevated systolic and diastolic blood pressures with increased pulse pressure, and cerebral agitation and depression due to low sodium. So based on the sodium levels, there can be differences in CNS and ECG effects as well. For example, 120 milliequivalents, the patient starts showing as confusion, restlessness. ECG changes will be wide QRS complex, whereas in 115, somnolence and nausea, wide QRS complex with ST elevation, and 110 and less, the patient will have seizures, coma, and ECG effect shows ventricular tachycardia or fibrillation. The major components include the patient will have dilutional hyponatremia, causes cerebral edema, and symptoms such as yawning, drowsiness, nausea, confusion, or seizures. There can be a signs of fluid overload leading to increased cardiac workload, pulmonary edema, and hypotension. And because of based on which type of irrigation fluid used, in this case it was glycine was used. So glycine toxicity can also be developed, contributing to CNS symptoms such as drowsiness and confusions. What are the risk factors for developing TURP syndromes? The surgical time is more than 1 hour. So if there's longer the time, longer the irrigation fluid which will be absorbed. Height of the bag of the irrigation fluid, resected prostate size, if there's any large blood losses, perforation of the bladder because it causes rapid absorption of the irrigation fluid from the peritoneal cavity and also the blood, large amount of fluid which used, and poorly controlled CHF. So the management is when there's a signs of TURP syndrome, stop the procedure and start giving them hypertonic saline, and diuretics can be given, and cardiovascular and vasopressors support should be given. In this case, 3% saline was initiated without delay and intubation was avoided, balancing the risks of airway instrumentation in a hemodynamically fragile patient. So this patient with perioperative myocardial infarction. So PMI may result from plaque rupture or myocardial oxygen supply demand mismatch. So any surgery will have a stress response and inflammation, and pain will cause stress. And also this patient was undergoing a spinal anesthesia, which will have a hemodynamic imbalance. And also when the patient is undergoing any analgesias or narcotics were given, that can lead to hypoxia, or any bleeding can lead to hypoxia, which also decreases oxygen demand, so that the oxygen demand and supply will be damaged. So in this patient, the likely triggers were the fluid overload, severe hypernatremia, and bradycardia and hypertension, reducing the coronary perfusion. Timely ECG interpretation and rapid PCI were critical for myocardial salvage. So the diagnostic challenges. The overlapping features of TURP syndrome and PMI, which is bradycardia, hypotension, chest discomfort, complicated initial recognition. However, yawning, an early neurological sign of hypernatremia, and sodium of 105 supported TURP syndrome. The sudden appearance of ST segment elevation on ECG confirmed acute inferior STEMI, prompting urgent cardiac intervention. So the conclusion, this case demonstrates a rare life-threatening overlap of TURP syndrome and acute MI, prompt recognition of early signs, careful titration of hypertonic saline, and timely PCA were essential to a favorable outcome. Most importantly, it highlights the critical importance of eternal vigilance by the anesthesia provider in recognizing evolving complications and coordinating multidisciplinary care. Anesthesiologists must maintain a high index of suspicion and act swiftly to prevent escalation of seemingly subtle signs into catastrophic outcomes. Thank you. Bye.
After this, we'll have a last talk by Dr. Shalini, and then a very interesting session of a non-academic of life outside OT, and then we'll proceed for lunch. Please bear with us because it will be worth waiting for that life outside session. So just bear with us for 20 minutes more.
Dr. Vaishali, please felicitate Dr. Shirag. I will invite Dr. Shalini Rathore to present her case.
Good afternoon, everyone. My name is Dr. Shalini. I'm doing my cardiac anesthesia fellowship from HN Reliance Hospital. I'm presenting a case. It's a successful perioperative management of refractory cardiogenic shock during CABG. So this patient was a 75-year-old male with multiple comorbidities. He had a history of IHD. Previous PTCA was done in 1995. He has a diabetes, hypertension, Parkinson's, bipolar, hypothyroidism. This patient was presented to ER with epigastric tightness and profuse sweating. There was acute, on ECG, there was acute anterior wall ST elevation MI. Coronary angiography was done and it shows LAD 99% stenosis, ostial RCA 90% stenosis. Emergency POBA to LAD was performed. After balloon angioplasty, persistent symptoms and severe LV dysfunction prompted urgent CABG. Pre-operative assessment, ECG showed ST elevation in lead V1 to V3. There was a reciprocal ST depression in lead 2 and AVF. Echocardiography suggestive of EF of 25 to 30%. There was akinesia of septum, apex, infralateral wall. There was grade 2 diastolic dysfunction, mild MR, and normal RV function. Other concerns were there was pulmonary congestion, creatinine was on a higher side, troponin was more than 6,000. The high-risk features include there was recent MI, severe LV dysfunction, elderly age, and multiple comorbidities. So our anesthesia strategy, the goals included to maintain coronary perfusion, avoid myocardial ischemia, optimize preload and afterload, early detection of ventricular failure, monitoring radial and femoral arterial lines, PA catheterization, CVP monitoring, transesophageal echo, and urine output monitoring. Preparedness included vasopressors and inotropes were kept ready, blood products were available, and mechanical circulatory support backup was ready. So intraoperative events, patient was remained hemodynamically stable during diagonal and LAD grafting. LAD endarterectomy was performed due to diffuse disease. Now during cardiac positioning for OM grafting, the patient developed severe hypertension, bradycardia, and poor tolerance to cardiac displacement. Initially managed with epinephrine boluses and escalating the norepinephrine and adrenaline infusions. Despite such high pharmacologic support, persistent hemodynamic instability necessitated IABP insertion. So IABP provided temporary circulatory support. However, instability persisted due to inability to tolerate cardiac manipulations, heart manipulations, and severe ventricular dysfunction. So decision was made to convert from off-pump CABG to on-pump CABG to ensure hemodynamic stability and facilitate complete revascularization. Following graft completion, there was severe biventricular dysfunction, which was confirmed on TEE. There was refractory cardiogenic shock, failure to separate from cardiopulmonary bypass. So decision was made to to initiate aortofemoral VA ECMO. Outcome was successful separation from CPB. The patient was transferred to cardiac ICU on VA ECMO, IABP, and mechanical ventilation. Post-operative course was complicated by re-exploration in view of high drain output, which led to massive transfusion, acute kidney injury, thrombocytopenia, respiratory insufficiency, fluid overload. All these were managed with goal-directed fluid therapy, blood component therapy, ventilatory support, and multidisciplinary care. Outcome, successful VA ECMO decannulation on postoperative day 3, IABP removal and extubation on postoperative day 4. Gradual recovery of renal function was achieved. Hemodynamic stability without inotropes. The patient was discharged after rehabilitation on postoperative day 20. Learning points, early recognition of refractory cardiogenic shock is crucial. Advanced monitoring guides timely intervention. IABP and VA ECMO can serve as an effective rescue therapies. Cardiac anesthesiologists play a central role in decision making. Multidisciplinary management improves outcome. Thank you.
So I would request Dr. Santesh Kaushik to felicitate Dr. Shalini. Dr. Mona. I would request Dr. Saurabh and Dr. Suravi to felicitate chairperson. आ जाओ उसको बोलो ना आने के लिए डॉक्टर अश्विन का है ना डॉक्टर अश्विन मेरा नाम बोला था आपका नाम दिखे नहीं कैसे बुला रही
Dr. Garima will felicitate Dr. Vaishali Madam. Dr. Garima will felicitate Dr. Thomas sir also. Thank you, chairpersons, for please coming for the session. Our next session is a very interesting session. It is about life outside OT. So we, as anesthetists, we try to cultivate many habits outside the OT also. So you will see that what we can do outside OT also, and it is a very interesting sessions. I would like all the chairpersons to please come on the dais. Dr.
Hello everyone, I am Dr. Garima Khandelwal. I know all of you are too hungry and the intense academic session also leads to hunger. But this is very interesting session. Dr. Pranali ka pehle. So after informative, advanced and intense academic session, let's come out of the theaters, switch off the monitors and switch on the life. Inside the OT, our world is monitors, vitals, protocols, but outside it, doctors are marathon runners, founders, singers, dancers, and whatnot. So the next session devoted to our colleagues, our seniors, who motivate us on the day-to-day basis for the life outside anesthesia operation theatre. I would like to invite chairpersons Dr. Jessie Venel ma'am. She is HOD, MGM Kamote, and ma'am ko kaun nahi janta. Ma'am is an example of livelihood. Ma'am is a hardcore traveler by heart, enthusiastic tracker, and very active ISA member. Dr. Jessie Venel ma'am. I would also like to invite Dr. Rochna Bakshi ma'am. She is Professor D.Y. Patil Medical College and Associated Hospital. Ma'am is very strict in OT, but outside OT, ma'am is amazing yoga enthusiast, amazing dancer, and very active person. And we just partied with ma'am a lot. So welcome Dr. Rochna Bakshi ma'am. Dr. Mona Jadhav ma'am, I would like to invite Dr. Mona ma'am. She's also Professor D.Y. Patil Medical College. Ma'am is an amazing, amazing gardener, traveler, nature lover, bird watcher, and tracking enthusiast. Ma'am के WhatsApp updates देख के हमें भी flamingos से प्यार हो गया है. So let's welcome all of our chairpersons. And I would like to request Mona ma'am. I would also like to invite Archana ma'am to please come on the stage and chairperson. Ma'am is head of department, Terna Medical College. Ma'am is also a very fun-loving person. We recently encountered in morning walks and tracking and everything. So let's welcome this session. I would like to request Mona madam to introduce our speaker.
Yeah, the first speaker is Dr. Pranali Patil. She is a senior consultant at Apollo Hospital for a decade now. She is an enthusiast, passionate singer and long distance runner. Look at her attire.
Thank you.
She is participating actively in the long marathon as well as half marathon. I know she goes and participates every year in Satara marathon, which is one of the hardest in Maharashtra. So Dr. Pranali. Yeah, Ladakh marathon also. So, Dr. Pranali, yes.
Thank you, thank you. Hello, am I audible? Audible?
Yes.
Friends, I want to ask you one question. Raise your hands if you tell your patients, family members, colleagues that you should have well-balanced life. Have good sleep, have work-life balance. Now keep it raised if you followed it last week. Okay, I can see few, but then many have not raised their hands. So exactly, we are so bad at prescribing ourselves. We really don't follow the advice which we tell our patients. So today I'm going to talk about my passion, which kept me off the burnout in OT. Okay? Slide. So studies show, we all know this, but just for documentation, studies show that 10 to 41% of anesthetists meet the clinical criteria of burnout syndrome. And after the pandemic, it has even increased to 68%. It is that bad. We don't even realize that we are actually having this burnout syndrome, and then just days go by. So the whole idea of this talk is to why anesthetists need passions outside OT. Of course, to prevent burnout. We face one of the highest burnout rates in medicine. Hobbies create psychological distance from clinical stress. A doctor should have more than their specialty. We can't be doctors all the time. We should have something more than that. So external passions reinforce a whole new identity, which sustains long-term fulfillment. I have realized in last 10 years that as I started running, it has created some empathy towards patients and somewhere that pain, you know, when I'm hitting that pavement and I'm just out of my breath, it has just transformed me as a person. It also creates mental sharpness because of the cross-domain thinking. And when doctors live full lives, they inspire patients, residents, and peers to prioritize well-being. So as Mona introduced me, I'm basically anesthetist who's doing a day job, who spent 12 hours in the OT, and in the early morning I'm hitting the pavement, and the evening you will find me doing some riyaz or doing some show. Not every day, but I try to do is as much as I can. All of us as anesthetists we make sure our patients breathe very well for 12 hours. And then when we come home, we realize that we forgot to breathe ourselves. So these are some things. I have not mentioned all the races, but I've tried to do as many as I could. So this is a small video. I don't know how to play. Yeah. Ek minute, this is, sorry, I think this is a, 1 minute. Yeah. Can anyone help me with this? हाँ, ये वीडियो ऑन करना है. And sound also. This is my running group. This was my first half marathon. Tata Ultra Marathon. This is some training run. This is after Kaveri Ultra Marathon. My first Tata Mumbai. First half marathon, I landed up getting podium. My family. So when one woman is educated, the whole family is educated. And in my case, when one woman runs, the whole family runs. My husband, my son, both are marathoners. So initially, they were mocking at me for running, but later on, they also took up the sport. So these are some benefits of running and exercise. It reduces, as we all know this, reduces hypertension, arrhythmia, and coronary disease risk. It also manages your stress by metabolizing cortisol. And a very interesting thing I found is it boosts BDNF, which is brain-derived neurotrophic factor, which improves memory, concentration, and problem solving. Also, marathon training needs lot of discipline, which instills the same systematic preparation and composure needed in anesthetic emergencies. Now, this is something about my singing. I do perform some local shows in Pune and Mumbai whenever I get chance. The benefits, some benefits of singing, it creates expression, it unlocks emotions and thoughts that clinical precision cannot. Basically, singing and running both complement each other. When I started running, my singing got better. That's what I felt. It also causes emotional regulation, it enriches you, it causes cognitive enrichment, and it connects to patients, colleagues, and communities. It also has some healing power, which is for the singer's body, it improves respiratory muscle strength and lung capacity. It stimulates the vagus nerve. It reduces heart rate and anxiety. It's pure form of dynamic meditation. That's what I have experienced. You cannot think anything else when you're singing a song. It enhances posture and core engagement over time. And for clinician's mind, it builds pattern recognition, which is an asset in anesthetic monitoring. It also trains focused attention, which is very critical during long procedures. Emotional processing prevents compassion fatigue. And it enhances communication skills with patients and teams. I literally start singing before inducing a scared patient. Sometimes I have found it helpful. So this is an important part of it. How to find time for your passion. So you have to schedule it like your OT list. You have to block time for running. I'm not saying only running or singing, whatever you like. You have to block time for that particular activity in your calendar. It should be non-negotiable. Then you can take advantage of early mornings. You have to, 5 to 6 is a great time where we can, before our list starts, before our rounds, before the world needs you, you can grab hold of that time. You can combine recovery with passion, like all your rest days. We are not working every day. We have some rest days. You can do whatever you like on those rest days. And you have to, if you involve your family in that, you will even create more time. And then it's fine. Some days you don't have full time. You don't have really 1 hour, but micro commitments. Just take out some 20 minutes of time, 15 minutes of time, whatever you like after you go home. And that's it. That will just build over the period. So ultimately, balance is the key. It causes physical, mental, emotional balance, which is a fit body is a safer doctor. It gives you clarity mentally, and passion protects burnout. Doctors who pursue what they love outside medicine report higher job satisfaction, lower depression rates, and longer careers. A well-lived life is the foundation of well-practiced medicine. So friends, lace up, sing out, show up. Run regularly, sing boldly, pursue passions. Thank you so much. We have given you one form which you can fill, and you don't have to give it to us. Just go home and stick it somewhere you can see and remind yourself and try to do at least one thing which you always wanted to do. Thank you so much, dear friends.
My God, what an eye-opener session. अभी तक एनेस्थीसिया फिजियोलॉजी, अंडर एनेस्थीसिया एंड नॉर्मल फिजियोलॉजी पढ़ा था, आज सिंगर्स फिजियोलॉजी भी देख लिया. So I would like to request Dr. Archana Matre to felicitate Dr. Pranali Patil. By the way, they both are very good friends. Yeah. 25 years of. Wow, what a reunion. So after this, I would like to request Dr. Rochna Bakshi ma'am to introduce our next speaker.
So our next speaker it gives me immense pleasure to introduce our next speaker because she's a perfect combination of beauty with brains, okay. So Dr. Leena Pawar is a senior consultant, pediatric cardiac anesthetist at Apollo Group of Hospitals. To her credit, she also has a lot of beauty pageant winning titles. So she's been top 8, she's come in the top 8 at Mrs. Maharashtra 2024. She's been Mrs. Navi Mumbai 2025 winner, Mrs. VG India 2025 Finesse category winner, and she's also preparing for the upcoming Mrs. Glamon 2027. So Leena, welcome you to the dais.
Thank you, ma'am. Thank you so much. Okay, so I'll just take you in very short, the two worlds of mine, what I say. So what I do, so obviously during day, we give anesthesia. I usually do cardiac anesthesia, pediatric, neonate, and adult. But, okay. So during day, I obviously practice cardiac anesthesia. But at night, you'll probably see me in high heels or maybe gym wear most of the times. So, excuse me, can you play this for me? Thank you. So this is just a winner's felicitation which was there in December 25. So what made me go through this? Why did I go to pageantry? So I always wanted to create awareness about anesthesia because I'm sure you all must have experienced. Anesthesia is considered as a secondary branch. Only the surgeons are projected everywhere. Do really people know about what is anesthesia? So then how to have a global platform where you can actually present yourself, you can present your branch, you can talk about anesthesia very freely. Not in 1:1, it's not possible all the time. So you have to have a platform where you actually can put your views, create awareness about everything. And cardiac anesthesia is something people are actually not aware about. So I think that was one of the main motive for me to enter into the pageantry. And moreover, recently, because I'm so active on Insta FB, there's so many memes which come up. Is an anesthesia really just confined to have a coffee and maybe sit once the tube is in? Is it so? Do you all agree to this? Doesn't your blood boil when you say these stupid memes? Yeah, it actually boils because nobody can actually judge what anesthesia is. One slightest mistake and the patient is gone. Do people really understand this? No. Then how are we going to make awareness about this? So I think these are the certain points where actually I took up the pageantry so that I have a global platform to present our branch. And then of course the best of the best stress relief, at least this is what I have found. And when you look good and you feel good, the confidence doubles up. See, otherwise when you're on medicine, you're confident, you talk, you meet unknown people, you land up talking to relatives and all that. But somehow actually this adds to your personality, that is what I feel. And then glamour. Who is not attracted towards glamour? I think we all are. Because everybody thinks that doctors are usually cannot carry themselves, they cannot look good, they're not into makeups and, get-ups and all that. So I think I should just try that. And, this is what motivated me to take up pageants. So this is my workout video. Oh. Oh, fine, it's just a small video. So I am into regular fitness also. I do regular workouts. It's about 240 lb of leg press. So fitness, again, it's an integral part. Whether you practice anesthesia, you take up any of your hobby, may it be running, trekking, jogging, anything, fitness becomes an integral part. So our fitness is always has been there and should be there as a part of our life. We eat, we drink, we sleep every day. So why not be fit as well? Exercise also should be a part of our routine. That is what I feel. And I have been exercising regularly for last, say, 12 to 13 years. So I'm into weight training mainly. And of course, fitness is like a bridge between what you do is routine and what is your passion. So that's why I think fitness is the part of our life, should be. And what does fitness actually gives you? It gives you a lot of discipline. Discipline in the terms of waking up early, preparing your own meals, concentrating on what you eat, avoiding what you should not eat, so all that. So yeah, so fitness is very important. And what has all this, given me? I mean, when you look back, so it's, there are so many things which will come up. It's no anesthesia, yeah, it is there. But when you, when you have your own passion, you create something good about it, you feel good. So what has this helped me? So actually, I think I have developed a lot of skills when I entered pageantry, when I started getting fit. People come and compliment, they ask me about my fitness routine, my diet and nutrition. So the skills that I have achieved when I entered all this is being calm and poised. See, anesthesia otherwise is very stressful. Slight drop in pressure in a neonate, what can the disaster be? So actually, what we should be doing is to remain calm, pose, and monitor and manage that low BP, and not just get panic, get tachycardic, and drop our maybe go hypertensive and tachycardic your own. No, that is not done. Then again, attention and discipline, as I said. Communication skills, yeah. I mean, because you are on the stage, there are hundreds of people, unknown faces, the judges are throwing you questions, and there's a lot of challenges that you face when you're on the stage. You are not aware of the questions that are asked, and the questions are so very different. So all these communication skills and to put your thoughts in a very short while, I mean, it has taught me a lot. And of course, empathy and advocacy. You become very empathetic. That is what I have realized. So the message I want to give you all is laryngoscope and stilettos actually can coexist. So likewise, whatever your profession is, with that, your passion should be continued no matter what. Do the work that heals others, and also do the work that heals you. So that is very important, because I think that is that is something which will, you'll enjoy doing it on the routine practice. Anesthesia every day, you might be getting tired, bored, and all that. But when you pursue your passion, you are into that, you are active elsewise also. I think your life will be very active and very interesting. That is what I feel. So here I am done with my presentation. Thank you. And so you can ask me questions related to anesthesia or to how to walk in a 4-inch heels and pose. So both are skills, yes.
Amazing, amazing presentation. And Dr. Leena is, heartbeat of many. So I would like to request Dr. Jessie, ma'am, to felicitate Dr. Leena. A little bit ahead. Dr. Leena, a little bit ahead. And few things Dr. Leena have not shown in the slides is she's a very good dancer, by the way, which I know personally. She's a very, very good dancer. Amazing, amazing. Thank you so much, ma'am. We are blessed we have you in our department. So I would like to request Dr. Jessie, ma'am, to introduce our next speaker. And believe me, हमें उन्हें मनाली से पकड़ के लाना पड़ा है, because he was on track.
Hello. We come to our final last presentation. So there is lunch after that. Dr. Mokashi, he's
Dr. Suhas Mokashi.
Suhas Mokashi. He's a senior consultant, cardiac anesthesiologist right now with Apollo. He's an avid trekker and a photographer and lots more. Let's hear it from him itself.
So we are ready, we can head for a trek after the CME. We have a Parsik Hill next to us. Huh? Okay, so I won't take much of your time. I know all of you are hungry. Even I'm hungry too. Okay, so now looking at the attire, you know that the altitude what we were talking about, it's not about anesthesia, it's the altitude which actually we climb. Okay, my colleague Dr. Pranali has already spoken about burnout in anesthesia, so I won't touch the topic again. So definitely when I started these hobbies, I did not start for the health benefits or with having any goal in mind. So since childhood, I used to I always loved to walk, and then we used to climb small hillocks, small mountains, and then slowly it converted into a serious hobby. So during MBBS days, we used to do a lot of Sahyadri treks, and that lush greenery, the water means during monsoon, as well as during winter season. The views used to be amazing. Then just 20 years back, we did Chandratal trek. And in Chandratal, for the first time, actually, I could see those snow-capped mountains with naked eyes. With whatever pictures we see, which we keep as our screensavers for our laptops or for our desktops. So to see those same mountains with naked eyes is amazing. It's a different experience altogether. And that's how I started doing Himalayan treks. In 2006, we did Chandratal trek. After that, I wasn't regular. In 2012, we did Stoke Kangri. So it's about 6153 meters. It's approximately 20,500 feet. We could summit. Then in 2018, we did Gokyori. So I'll just show you the pictures. So the quote which says that the best view comes after the hardest climb, it's so true. And how, I agree with Edmund Hillary, who says that it's not the mountain we conquer, but ourselves. Edmund Hillary, those who don't know, Edmund Hillary is the first one who climbed Mount Everest. Okay, so this beautiful picture is from Nepal. That's Gokyo Lake. And the white mountain which you see on the backdrop is Choyu. That is the 6th tallest mountain in the world. And the hotel which you see with the red roof, actually there we have stayed there. I have stayed there. And the black mountain which you see on the left side, that's the Gokyori. So we had that's a summit point, and we had submitted early morning actually. And when we reached on the top, this was the picture at the sunrise. The left one is Mount Everest, and the right one is Lhotse. That's the 4th highest mountain in the world. And that's sun rising, that you can see the golden border. This is another trek which we did this is the highest altitude I have achieved so far. It's Kangyatse 2. We did it in 2021. Sorry, it's 6250 meters. It's approximately 22,500 feet. Okay, so here you see the two friends standing. So I was there behind, you see the crowd. So we were rappelling that much portion. That slope was somewhere around, you see on the right, that Kangyatse peak, the tip. So that slope was around 60 to 70 degrees, and we did rappelling for almost 700 to 800 feet. And this is the summit picture. And this is Stoke Kangri, which I was talking about. And this is at the summit. Okay, the second hobby is photography. All of us love to click pictures, but only some of the pictures, when we see them, we say, oh wow, these pictures are really good. So even I love taking pictures, and I did some basic course in DSLR photography in 2006. And really, definitely, with photography, we can relive those moments. We can see the memories again and again. So these are some of the clicks I've taken. This is a beautiful evening in Pench Forest. This is Dr. Prakash Amte playing with his pets. Means I have clicked this picture. This majestic beauty I found in Pench. And this is just a random picture which I came across. Okay, means I was on my honeymoon in Singapore. And my wife has clicked this picture. This is a live snake, it's not dead. And I felt that handling this snake is relatively easier. Okay, then very off late, since last 6-7 years, I started running marathons. Actually, I don't practice marathons, because I find it quite boring to run alone. And in marathons, I feel that there are so many people running together, so many people are there to cheer up. So the endurance is built over the period of time because of the treks and the walks. So I don't run continuously, but I run, walk. And I feel that completing the marathon is important for me and not the time. So just 4 months back, I finished Tata Ultra Marathon, which is 50 kilometers, and it's conducted in Lonavala. So these are some of the pictures of the marathon. The last but not least is the traveling. So you have to pursue these hobbies, then you have to travel a lot. And I'm sure when we travel, we visit different cultures, we meet different people. At the same time, if you go to different places, just try their different cuisine, the local cuisine especially. This is a beautiful Tirthan Valley. I just visited 2 weeks back. That's the Tirthan River. And it's an offbeat location in Himachal Pradesh. Okay, so I say that you must visit this place at least once in your lifetime. Because in Himachal Pradesh, everybody goes to Shimla, Manali, but this is a different location. It's quite peaceful, less crowded. So this is a world map, and the countries which are painted, actually I have been to those countries. Hopefully, I should be able to paint all the rest of the map as much as possible till I breathe last. So these are the common lessons what I got from my hobbies. From mountaineering, photography, marathons, discipline, but I yet to get discipline, and traveling. So definitely it has your hobbies have a good impact on your professional life, because you know our branch is quite stressful. And when you go out, you disconnect yourself from the world, from our anesthesia part. And especially instead of taking a long vacation, I prefer I suggest that you should take small breaks, like 2 to 3 days. Okay, so that take-home message is it's balanced life definitely creates a better professional, and success is not only measured by the achievements in the operation theater, but also by the experiences that shape us outside it. Okay, thank you. And this is not Switzerland, it's Himachal Pradesh. It's an offbeat location, that is Bahu village in Himachal. Okay, must visit. Thank you.
थैंक यू सो मच डॉक्टर सुहास, बट एक छोटी सी रिक्वेस्ट है, घूमते घूमते अपोलो ओटी नहीं भूल जाइएगा. So I would like to request Dr. Rochna Bakshi ma'am to felicitate Dr. Suhas Mukashi. अरे वो सामान Now I would request Dr. Thomas, sir, our head of department cardiothoracic surgery, DY Patil Hospital, to felicitate our chairpersons. Sir, please. Yeah. Dr. Jessie Venel, ma'am. Aye, sir, please. नहीं मैडम का I would also request Dr. Thomas to felicitate Dr. Archana Mhatre, ma'am. I would request Dr. Alvina D'Souza, ma'am, to please felicitate our chairpersons. Dr. Rochna Bakshi, ma'am. और थोड़ा सा पुढे मैम थैंक यू Dr. D'Souza to Dr. Mona Jadhav, ma'am. Our enthusiast singer, beauty pageant, trackers want to click a picture with all of you. So I would request all the chairpersons, ma'am, you also please be here. Yeah, Dr. Pranali, Dr. Suhas, they want, yeah. Leena, yeah, but she changed, I think. So a big picture, please. Leena, I think changed. So lunch is going on. And after 15 minutes, we will assemble once again here for the poker session. Thank you so much, ma'am. Thank you so much. Thank you. Very light. Thank you so much. Thank you so much. Thank you. So, welcome again. I hope you enjoy your lunch. I would like to invite Dr. Kanchan Singh, Senior Consultant, Department of Anesthesia, Apollo Hospitals, Navi, Mumbai, to proceed for the next session, which is POCUS. Dr. Kanchan Singh.
Hi everyone. May I please request all the faculty to return to the conference room if possible. Let's start. We are running behind time. I hope you all enjoyed lunch and reconnecting with your colleagues. So moving on, the next session will be on point of care ultrasound, a tool that has transformed perioperative assessment and decision making. So just to take a poll, how many of you are using POCUS in your routine anesthesia practice? Please raise your hands. There are many having lunch, but who all are using a point of care ultrasound? All right. So, dear all, please join me in welcoming our first chairperson, Dr. Olvina D'Souza. She is a highly respected anesthesiologist and professor at MGM Hospital, Kamuthi, and she is the current ISA president, Navi, Mumbai. We are honored to have you, ma'am. Next, I would like to invite our own Dr. Vikram Vaghalkar. He is a senior anesthesiologist at Apollo Hospital. He is an extremely skilled anesthesiologist. May I also request my dearest friend, Dr. Shwetali Vadke, on stage for chairing the session. She is a very proficient, calm, and compassionate anesthesiologist. Finally, it's my pleasure to invite our Dr. Ajit Pillai, sir, who is a senior consultant at Apollo Hospital. He is extremely experienced and talented. Thank you, sir. So this session will focus on point-of-care ultrasound. To commence the scientific proceedings, may I request Dr. Ajit Pillai, sir, to introduce our next speaker, Dr. Viral Parekh, who will be speaking on airway POCUS. Thank you.
Good afternoon, everybody. It gives me great pleasure to invite you on a post-lens session on POCUS. The next speaker actually requires no introduction. He's very well-known, dynamic, young anesthetist. He's a consultant at PD Hinduja Hospital, Khar. Very good friend of mine. He's on the NISORA Educational Board member. He's a NISORA reviewer for the NISORA Anesthesiology Manual and a reviewer for the NISORA Anesthesia Updates. He has won the ISA National Young Talent Award in 2025. He has multiple publications, and you'll find him literally on every Sunday conducting some workshop or some form of some lecture.
Thank you, sir.
Somewhere. Introducing the dynamic, of course, Viral Parekh.
Sure. Thank you so much, sir, for such a kind introduction. So before I start my talk, I would like to thank Dr. Saurabh sir, Dr. Ajit sir, Dr. Amish sir, the IECTA, ISA Navi Mumbai, for inviting me and giving me this opportunity. It is my first talk amongst the IECTA group of cardiac anesthesiologists. And after the amazing food in the lunch session, I know all of you might be feeling sleepy, but the talk is about the airway POCUS, and it is predict, prepare, and perform. And for all anesthesiologists, it is one of the most important aspects. So before I start my talk, I have no conflict of interest. Few of my pictures are from the Complete Anatomy app, and a few patient pictures, the appropriate consent has been taken. So as an anesthesiologist, the primary concern and our target is to secure an airway in each and every group of patients for maintaining the patient's perioperative care and as well as to prevent any untoward incidents. So before I go to airway ultrasound, I'll just show, this is actually, I could not take this patient's picture pre-operatively. This is just post-induction. He was a 24-year-old male with a BMI of 53.3 kilogram per meter square, and he was posted for laparoscopic sleeve gastrectomy. So when you see such a patient with such a difficult airway, what are the questions which will come in your mind? That whether we'll be able to mask ventilate the patient, whether I'll be able to do a laryngoscopy, whether my tube will go appropriately, and if necessary, will I be able to palpate the cricothyroid membrane and perform an emergency cricothyrotomy. So the traditional evaluation methods, what we are doing daily are the Mallampati score, the calculation of multiple heights like the thyromental height, the upper lip bite test, and various radiological evaluations for the airway. But all of these are not specific, they take time, and it is not immediate. So if you want to do a scan or if you want to do an X-ray, it takes time, right? So when the patient is on table, you need the evaluation immediately, and that's where the ultrasound comes in picture, because it is obviously all of us know the advantages of the ultrasound. So point of care ultrasound, so what are the advantages is that it has a specific question. So whether I'll be able to ventilate my patient or not, or whether the laryngoscopy will be difficult or not. It's a time sensitive. Whatever question, it has to be answered immediately by performing a limited scan. And obviously, if it's not specific, then we can refine the differential diagnosis and it helps us to guide the treatment. And for all the POCUS evaluation, there is a specific IM approach which has been said by Dr. Barner. So the acronym stands for I is for indication, A is acquisition, I is interpretation, and medical decision making. So these are the two very good articles which I have come across for airway POCUS, and I would recommend all of you to go through it. Most of my talk is on the basis of the calculations and what all parameters have been given in these two studies. So let us start how it helps us to identify. So point of care airway, it helps us to assess airway prior to intubation or procedural sedation. It helps to identify unanticipated difficult airway. It helps to confirm the placement of the endotracheal tube in the trachea, or it helps us to diagnose the esophageal intubation or endobronchial intubation, and for the identification of cricothyroid membrane. And this is mainly an upper airway evaluation in which we examine the airway from the suprasternal notch to the mentum. We can do the evaluation in the transverse as well as longitudinal scan. We can start from the mentum and go down, or vice versa. And we can obviously perform a sagittal and a parasagittal scan. So now this is the anatomy of the airway, and the hyoid bone serves as a landmark. So any evaluation which is above the hyoid is a suprahyoid evaluation, and below is the infrahyoid evaluation. So all of us know that the suprahyoid structures, they are more deeper, and thereby we need a curvilinear probe which definitely helps us to see the structures which are at deeper target. And the infrahyoid structures, they are more superficial, and thereby we need to use a linear probe in most of the patients. So what are the structures we'll be identifying is the hyoid bone, the tongue, esophagus, the two membranes, the thyrohyoid membrane and the cricothyroid membrane, and the four cartilages which are the epiglottis, thyroid cartilage, cricoid, and the tracheal rings. So the ergonomics for any procedure with the help of ultrasound, you need to be very much perfect with the ergonomics so that you can scan effectively. So you can usually for the upper airway point of care, you need to stand on the right side of the patient. The patient will be having a sniffing position, and the ultrasound machine will also be on the right side of the patient. So you can do the changes on the machine with your left hand. And suppose if this is not possible, you can be at the head end and keep the machine on the left hand, on the left side of the patient. So these are the 5 areas where we will be evaluating, and I'll be going it through one by one. So before we go to different target areas, how does the different structures look on the ultrasound? So the cartilages usually appears hypoechoic, the membranes are hyperechoic, and the bone, it appears as a hyperechoic with a acoustic dropout. And for all the different suprahyoid, infrahyoid evaluation, we need to know what is a transducer we will be using, the structures what we are going to see, and the clinical implications. So starting with the first, which is a suprahyoid view, it's a longitudinal view. We'll be using a curvilinear probe with the orientation marker cranially, and the structures which will be seen are the tongue, the hyoid bone, the mentum, the mylohyoid, and the geniohyoid. So this is the classical ultrasound appearance what we see when we look at the suprahyoid scan. And there are 2 distances which we need to calculate. The hyomental distance, which is the distance between the mentum. So the left side of the screen is cranial, so this is the mentum and this is the hyoid bone. And the second is the tongue thickness. So I'll come to each of them one by one. So now in this patient, I'm standing on the right side of the patient and my orientation marker is cranially. So this is the cranial end, this is the caudal, and this is the tongue, this is the mentum, and this is the hyoid bone. So the tongue usually appears as a fan-shaped muscle with a fan shape with intrinsic muscles and a striated appearance. And there is a hyperechoic line which separates the dorsal surface of the tongue from the air mucosal interface. So this gap between the palate and the tongue is also of importance, because if usually there is some amount of space between the dorsal aspect of the tongue and palate. But if it is not there, there is possibility that the patient might have higher chances of tongue fall, and there could be more chances of difficult ventilation. So this is the video. So I'm just scanning. And as I told about the distances, the hyomental distance is to be measured between the hyoid bone and the mentum, and the tongue thickness is to be measured from the skin to the posterior aspect of the tongue. So as you can see on the right side of the image, it is around 5.88 centimeter in this patient. So how is it clinically significant? So if any patient who has a hyomental distance in neutral position less than 5.29 centimeter, or if the hyomental distance ratio, so you take the measurements in extended position and in neutral position, and you do the ratio if it is less than 1.08, and the hyomental distance ratio between the ramped position and the neutral position if it is less than 1.12, and if the tongue thickness is more than 6.1 centimeter, then there are high chances that the patient might have a difficult airway. Coming to the next view, which is the thyrohyoid view. It's a transverse view through the thyrohyoid membrane, and you will be using a linear probe in most of the patients. What are you going to see? The hyoid bone, the epiglottis, the pre-epiglottic space, thyrohyoid membrane, and the strap muscles. So as you can see, the probe is on the hyoid bone, and we'll be starting to move caudally. So how does the hyoid bone appears? So visualization of the hyoid bone, as all of us know, the bone will usually appear as a hyperechoic line casting a black shadow beneath. So as you can see, the ultrasound beam is hitting the hyoid bone, and this is a classical sonographic image how you visualize the hyoid bone. It's an inverted U shape. Again, the distance from skin to hyoid bone, if it is more than 1.4 plus or minus 0.3, there are high chances that the patient might have a difficult airway. So this is the patient, and this is a volunteer in which with the linear probe I am just checking the distance from skin to hyoid bone, and it was around 1.08 centimeters. So we are much safe. Now as we start to move the probe more caudally, we'll be coming at the level of the thyrohyoid membrane, and obviously we are going to visualize the epiglottis and the pre-epiglottic space. So how it will appear on the ultrasound? So this is a classical picture what you see. So these are the two strap muscles. This is the epiglottis. So as I mentioned, since it's a cartilage, it will be appearing a hypoechoic, and the PS is the pre-epiglottic space which is anterior to it. And this is a classical neonatal face sign which, so this appearance is like the strap muscles appears, the eyes resemble the strap muscles, the nose is a pre-epiglottic space, and the lips appears as the epiglottis appears like a lip. So if the distance from skin to epiglottis is more than 2.54, it resembles that a patient might have a difficult airway. So this is the patient which I showed picture previously. In that patient, the distance from skin to epiglottis, it was 2.24. So we were not crossing the 2.54 mark. The third view is the thyrohyoid membrane. Again, it's a longitudinal parasagittal view with the orientation marker cranially. So now this view is important. So if you want to give airway blocks, the superior laryngeal nerve block, so the left side is the hyoid bone and this is the thyroid cartilage. If you pierce the thyrohyoid membrane and deposit the drug, it will help to successfully give the superior laryngeal nerve block for awake fiber optic intubation. And this is the same picture. Again, the thyrohyoid membrane we can visualize in the transverse scan as well as in the longitudinal. Coming to the thyroid view, we'll be putting the linear probe over the thyroid cartilage and we'll be mainly visualizing the vocal cords. So this is important because we need to check for the vocal cord movements. Most of us are very much interested post-thyroid surgery that the patient has any vocal cord palsy or not. So if you just keep the ultrasound probe and look for the movement of the vocal cords, as you can see, you will be able to see the vocal cords moving equally on both sides. And there are multiple studies which have confirmed that with the help of ultrasound, it can identify the vocal cord palsy. And we have seen this, I'll show you a picture. So there are further studies which mention that the appearance of the false vocal cord and the true vocal cord. So the true vocal cord usually appears hypoechoic with a hyperechoic rim, and the false vocal cords are mostly hypoechoic. In few patients, the cartilages might be calcified and you might not be able to see anything anterior. So multiple studies suggest that. So this is a picture in which the patient was operated for total thyroidectomy and he had a hoarseness of voice post-op, and as you can see, the right side of the vocal cord is not moving. So that confirms the finding. Coming to the cricothyroid view, for the identification of the cricothyroid membrane, mainly for emergency cricothyrotomy, there are two techniques, the transverse scan and the parasagittal. So it's a TACA protocol in the transverse scan, and in the parasagittal we'll visualize for the string of pearls. So how does it appear? The TACA protocol is the acronym for the T stands for thyroid, A is airline, C is cricoid, and A again is airline. So as you move the probe from cranial to caudal, you are supposed to identify the thyroid cartilage, as you can see on the right side here. So this is the thyroid cartilage which appears as an inverted V shape. Now as I move my probe more caudally, this is the hyperechoic line, the air mucosal interface. This is the cricoid cartilage, which is an inverted U shape with a signet ring appearance. And again, as I move more cranially, this is the air mucosal interface. So this is the point for the cricothyroid membrane. And string of pearls, again, it's a longitudinal scan with a linear probe. As we start moving from cranial to caudal or from caudal to cranial, we see the tracheal rings appearing as the pearls, and this is the cricoid cartilage. It is more superficial, more wider, and thereby it helps us to distinguish between the tracheal rings and the cricoid cartilage. And the space above the cricoid cartilage between the thyroid and the cricoid is the cricothyroid membrane. So this is the classical string of pearls appearance. And this is how you identify the cricothyroid membrane. Multiple studies do suggest that the identification of cricothyroid membrane is more successful with the help of ultrasound. And as I mentioned, the cricoid cartilage is an inverted U-shaped cartilage. So it helps us to identify the endotracheal tube size also in pediatric patients because the cricoid cartilage is the narrowest part. Now coming to the last view, which is the suprasternal view. So it helps us to identify the trachea, esophagus, identify the Riles tube insertion, DLT size, and endotracheal or the esophageal intubation, and for identification for the site for percutaneous dilatational tracheostomy. So here you keep the linear probe in the suprasternal notch and you start moving more cranially. So what you will see here, this is a trachea in the center, and as you focus on the right side of the trachea is the esophagus. So normally this is the left side of the patient. So as I'm telling the patient to swallow, it's the esophagus, there is a movement which you can appreciate. So if the endotracheal tube is in the trachea, what you will see classically is the bullet sign. As you can see here, the tube is passing into the trachea. And if the tube goes into the esophagus, as you can see, the collapsed structure which was there on the left side of the trachea, it again shows similar pictures like a trachea, and it is also called as a double tract sign. So here, as you can see, the endotracheal tube passing into the esophagus on the left side. There is something called as a snowstorm sign, which is a dynamic real-time visualization of brief flutter or shimmering movement seen when the ETT passes through the trachea. And here in this picture, I was passing the Riles tube and we had kept the probe on the patient's neck after intubating the patient. And as you can see, there will be some movement which is appreciated on the left side of the trachea. So this is also similar picture. Now, one thing which I wanted to show here was the, as I mentioned, this was the first picture which I showed about the difficult airway, the bariatric patient. So in those patients, we need to pass the gastric calibration tube. So in this patient, we were facing difficulty to pass the GCT. Obviously, it's a wider tube. So what we were presuming, usually the esophagus lies on the left side of the trachea, but in that patient, so this is the left side, but we were not able to negotiate the GCT. So we just did a gentle laryngoscopy and then twisted the tube. And as I move more forward in the video, as you can see, now the GCT is passing through the esophagus, which you can see on the left side of the trachea here. So definitely in certain group of patients, there could be some anomalies. Again, it helps us to identify the double lumen tube size estimation. Multiple studies have suggested that if you do measure the transverse diameter at the level of cricoid cartilage, and then there are multiple charts which helps us to identify which size of tube will pass through the DLT will pass through the patient. And also it helps us to guide the specific level at which we need to mark for the percutaneous dilatational tracheostomy. And also it helps us to identify the appropriate conformation of the laryngeal mask airway. So there is something which is called as a snakehead sign. After you put in the LMA and you just keep the ultrasound probe on the neck, this will be the classic appearance what you will see. So last but not the least, the DARES protocol which has come up. It's the difficult airway evaluation with sonography. So the step one is you go to the thyroid view. If the distance from skin to epiglottis is more than 2.54, there is a probability of difficult airway. If not, then you go to the suprahyoid view. In neutral position, you measure the hyomental distance and the tongue thickness. If the thickness is more than 6.1 and if the hyomental distance is less than 5.29, there is a probability of difficult airway. If not, then again you calculate the ratio in between the neutral and the extended or the ramp and the extended, and depending upon the values, you can predict whether the patient has a normal airway or difficult airway. So multiple studies confirm these findings, and my take-home message is always assess patients with difficult airway with ultrasound. identify and mark cricothyroid membrane in difficult patients, and obviously use for confirmation of ET tube placement. Definitely this helps mainly in the emergency, in the casualty or in the ICU when sometimes your the video laryngoscope is not working and all. So obviously the patient safety is a priority. Thank you so much.
Thank you, Dr. Viral. I think we'll take questions at the end after the three speakers, if it's okay. And a wonderful presentation as always. Thank you very much.
Thank you, Dr. Viral. May I now request Dr. Ajit Pillai to felicitate our speaker, Dr. Viral Parikh. May I request Dr. Alvina ma'am to please introduce our next speaker, Dr. Jayashree Venkateshan.
It's my pleasure to introduce Dr. Jayashree Venkateshan. She is a consultant anesthesiologist, Koti Siranandani Hospital, Vashi. After her MD and DNB, she has completed EDRA with European Diploma in Regional Anesthesia. She is an expert in the management of acute pain management and ultrasound-guided regional anesthesia. Over to you, Dr.
Good afternoon. Thank you very much for the kind introduction, ma'am. I would also like to thank Dr. Saurabh and his organizing team for giving me this wonderful opportunity to speak in front of the eminent and most prominent people in our fraternity. So let's go to my topic. Lung focus, is it the new gold standard at the bedside? Yeah, well, I'm not ending my slide. I just have to extend my heartfelt gratitude to Dr. Amit Dixit and Dr. Harshal Wagh for their valuable inputs and guidance for this talk. Also, I would like to say that the videos are of the focused team led by Dr. Amit Dixit and Dr. Harshal Wagh. So now I will be starting my talk, so I would like your focus, but then I know that most of you will be requiring coffee for this. So again, lung ultrasound imaging was not very popular till now or till the recent years. Why? Because of the obvious reason that the lung has air, and air is the enemy of the ultrasound beam. Why so? Because air has very low acoustic impedance, and from air till any surface you touch, the impedance is going to increase. So most of the rays will not penetrate. There will be zero image penetration. Most of the rays will be reflected back, and more than reflection, there will be scattering. And that's why you will literally not get any image below the air. So this is just an example wherein you will be having a duodenum, and this is what you see. It is something called as dirty shadow. So this is what we were seeing in any of the lung ultrasound. So that's why it was not popular. We were not using it in clinical practice. But however, we being humans and we are very resilient, we try to see positive even in the worst of the situations. So that's why we started concentrating on what was actually seen. So what we actually see is the artifacts, something called as reverberation artifact, and all of those were repetitively seen in the lung ultrasound. So those we made it as the normal lung ultrasound part, and then pathologically there was a predictable sonography which we used to get in most of the pathologic conditions of the lung. So we made that as a norm, and then that's how we started scanning our lung and putting it into applications like screening, diagnostic, and monitoring. I'll be speaking about this, and you will come to know in my next slides. And the best appealing features of ultrasound will be there is no radiation. We all know this. It gives a real-time dynamic imaging. It is repeatable, bedside, portability, low cost once all the PCP NDT is done. And again, bedside, we can do it multiple times. So what is our aim as an anesthesiologist? What is the basic lung USG which we should be knowing? Mainly, we'll be requiring to confirm the air entry on one lung and ventilation as well, detect pneumothorax, pulmonary edema, consolidation, atelectasis. Also, we can assess diaphragmatic strength assessment as well. So a focused lung scan can change our decisions immediately within seconds, which is of prime importance to us because that's all the time we have. And instead of giving wide variety and wide range of medications like, ye ho sakta hai, and just we give everything to the patients, we can have a focus diagnosis which will help us medico-legally, and then we can proceed or delay or recruit or even escalate imaging. So how do we go about linear? We have this probe selection. We have linear, curvilinear, and phased array that I'll be explaining during the workshop. But initially, we start with the linear, and for the deeper structures, we go with the phased array. Initially, they started off with the bedside lung ultrasound and emergency. That is something called as the blue protocol. So just to explain in brief, it will be like you're using both your palms on the right side of the chest, wherein this is shown over here. The ring finger that of the upper palm will show you the upper blue lung point. The lower middle finger of the lower palm will show you the lower blue point, and your little finger will be the phrenic line, that is coinciding with the diaphragm. So mainly blue protocol was initiated to find out these 6 clinical conditions, and thereon we expanded our horizon. A special mention about the posterolateral alveolar pleural point. This is the point from the lower blue point up to the point where we reach the posterior axillary line. So this is the posterior most point in the lung scan, wherein if it becomes positive, it shows that there is pleural effusion, alveolar consolidation, or atelectasis. So lung zone, again, for a very fast scan, it is usually divided into 8 zones. Again, this is arbitrary. It does not coincide with the lung zones actually. Upper, lower, anterior line, posterolateral, upper and lower. Again, if you want to go in detail, you'll be having anterior, upper, lower, lateral, and then posterior. And the same on the other side of the lung. So now, instead of looking into what we cannot see, we started seeing what is actually there. So these are the artifacts which we are actually scanning and getting our knowledge about the lungs. So first is the pleural line. What is a pleural line? When you start scanning anteriorly in the longitudinal section with a curvilinear probe, the first thing you see is the rib. Again, it's a hyperechoic structure, bony. You cannot see anything below this. After that, there is a pleural line. It is a homogeneous hyperechoic structure that represents the pleura. And again, you'll see the rib. So this comes because of the complete reflection of the pleura, and beneath that is your lung, normal aerated lung. The next ones are the A-lines. I think we have heard about this so much. These are the actually reverberation artifacts of the pleural line, which you can see equidistant horizontal lines going up to the end of the screen, but then they will be decreasing in intensity as we go down. Again, these are all the normal signs which we actually see. This is the bat sign. Again, the same thing. It looks as like the bat when you start scanning the rib, pleura, and the second ribbon line. The only condition where this bat sign is not available is the subcutaneous emphysema. When you see air over here, you cannot scan anything below it. In all the other pathological conditions, bat sign will be there. Curtain sign, this is easier to demonstrate rather than to speak about it. It is again a characteristic when you look down beneath the lung in the costophrenic recess. So you will be able to see the dynamic movement of the lung. So the lung is moving down with inspiration and moves up with expiration. And it shows that it is actually covering the abdomen. So it is obscuring the abdominal part. So that is why it is called as a curtain sign. One more important sign is the lung sliding or the gliding sign, wherein you will be able to see that the pleural line moves. This is the dynamic movement of the pleura against the parietal pleura. So you can see over here, it's a homogeneous, sharp, shimmering kind of a motion. This is your lung gliding or sliding sign. And if you apply a power Doppler to this, there will be color beneath this. So it shows that the lung is actually, the pleura is actually moving. The same thing, if you apply an M mode to this, this part of the pleural line, the upper part, where is the static thoracic, that is, it doesn't move. So that is why you will get the horizontal lines. And the lower part, which is the lung, it will give you a sandy or a granular appearance, just like the seashore. So there are certain conditions where lung sliding is absent. They are enumerated over here. The most common ones, as we all know, pneumothorax, pleural effusion, because there is fluid or air in between the pleura, and hence you will not be able to see anything below it. Pneumonia, which is complicated with adhesions of the pleura, pneumonectomy, and one lung intubation. So coming to the pathological conditions, after A line, the next in line is the B lines, but mind you, this is a pathological finding which you have in your ultrasound. These are hyperechoic laser-like, but these are the vertical lines that extend from the pleura till the end of your screen, and A lines will not be present in this kind of a situation. And if you find more than 2, 3 B lines together, it will be considered as a positive B line. This actually indicates the severity of the disease. One second. Yeah, so over here we can see that they are moving and they are in pockets or multiple B lines can be seen. So what these actually indicate are there is interstitial edema, then impending into pulmonary edema. This is actually equivalent to the crackles which you hear on auscultation. Again, there is a chart wherein you will be able to grade the amount of B lines and as per the severity of the disease. Just a mention about the Z lines, these again look like the B lines. They are vertical, but mind you that there will be A lines. These are not pathological, or these actually don't have any clinical value and shouldn't be mistaken for B lines. Coming to the stratosphere or the barcode sign, so when you apply M mode to the absent lung sliding or this pleural line, you'll be seeing that even the static thoracic wall doesn't move, even the part below the pleural line doesn't move. So that is why you'll be having just horizontal lines, just like the barcode. Next this is an important point for this pneumothorax. So it is the actually transition point between the normal lung and the pneumothorax, or the edge of the pneumothorax. This is how you can see over here. And on ultrasound, okay, I don't think so this is playing. So over here, you'll be seeing that one part of the lung is moving, sliding, where lung sliding is present, and the other part, it is not moving. So that is the pathognomonic sign of pneumothorax. One more thing about the lung pulse. These are the cardiac pulsations. These are rhythmic pulsations which you will be able to see, which are transmitted to the pleura. This happens when the air is not present, or in cases of atelectasis, or if there is one lung ventilation. So you will be able to see that these are the vertical lines that are present and pulsations will be seen. Again, these are indications that there are atelectasis present in this patient. For pneumothorax, how do we go about scanning? These are the prime areas of scanning for a quick scan. And mind you that these are the ultrasound findings which you will be having. Those are the absent lung sliding, absent B lines. Only A line will be present. And if you see lung point, it is definite that pneumothorax has occurred. Coming to the next pathology, pleural effusion. So whenever there is pleural effusion, you will be seeing that between the two ribs, these are the two ribs, okay, hyperechoic. These are the lines which you will be able to see. Upper line is the pleural line and the lower one is the diaphragm. This actually forms a quadrilateral kind of a sign, so it is called as a cord sign. And if you put an M mode to this, you will be seeing that there is this sinusoid pattern. This is mainly because of the movement of the lungs. Because of the inspiration and expiration, the lungs move in and out. So that is what is reflected in the M mode. Again, pleural effusion will not be just transudate, it might be exudate, it may be having some fibrosis, some particles in it as well. So there may be floating hyperechoic structures that are called as the plankton. It is mainly seen in the malignant effusions and empyema. And this is again a sign called as jellyfish sign, wherein you can see that this is the atelectatic lung, okay, and then it is moving in the pleural effusion. So it is something called as a jellyfish sign. It shows that the effusion is a very large one. Lung consolidation. So once the lung consolidates, it looks similar to that of a liver. So this is what we are seeing. This is actually lung, but it looks similar to the liver. So it is called as a hepatization because the hypoechoic lung has changed into something hyperechoic structure. And you may have irregular or regular boundaries. The pleural line may be regular or irregular as well, and hence you will be seeing absent or reduced lung sliding. So pneumonia and atelectasis, how do we diagnose? So there are presence of air bronchograms. Air bronchograms are the ones wherein in consolidated lungs, there are certain alveoli that are still open or patent, so the air moves in and out, and hence you will be able to see them. If it is a dynamic means moving. The air bronchogram is moving within the lungs, consolidated part, so it indicates more of pneumonia, just in this case. If I'm not able to show, I'll be able to show you during our workshops. So just to say, this is the consolidated lung. Over here, the bright hyperechoic shadows, these are of the air that is entrapped in them. So in the dynamic one, these part will be moving. And in the static part, again, these are the parts where air is present in the consolidated lung, and they are definitely static when the lung moves. So static shows that there is atelectasis, and dynamic shows there is pneumonia in the lungs. This is just a basic bedside diagnosis. It will definitely need more imaging, but this is for us to immediately diagnose whatever is there or no. ARDS, again, it's a very complicated one to manage. So what all we see on an immediate basis is we'll see multiple B lines, but they are non-homogeneous, they are irregular. And again, there will be some areas that will be spared, which is not the same with the pulmonary edema. All of the lung will be there filled with fluid, but over here you'll be having certain normal areas. Again, it is non-gravity dependent, and there will be subpleural consolidations, which we don't see in the pulmonary edema picture. And for ARDS, it acts better as a monitoring tool, wherein we'll be able to understand ARDS, whether it is progressing or we are treating the ARDS. So that's how we can use it as an important tool in the critical care settings. So this is just a summary of all the ultrasound signs which we have till now read about. Okay, just to speak a little about the quickly how we can assess as per the blue protocol is, if you have a lung sliding and you see a B line, it is pulmonary edema. If you do not see a B line, you see an A profile, and you see a thrombosed vein, that is again pulmonary thromboembolism. But if the veins are free and you see the PLAPS point at that point of time, the PLAPS is positive, it is pneumonia, because again it's a deeper structure. And if no PLAPS, you go for the diagnosis of COPD and asthma. And if any of the profile is present and you feel that it is abnormal, it is again pneumonia. If the lung sliding is abolished and B profile is seen, it is pneumonia. And if A profile is seen, it is pneumothorax. Plus, if you have the lung point. And if you do not have the lung point, you definitely need further imaging. Also, this helps to assess the diaphragm. For us, it may be useful while we are reversing the patient, or we are not sure about the neuromuscular blockade, or also while we have given interscalene blocks, we can assess the diaphragm and see whether the patient is breathing adequately or not, or in certain cases of doubt. Usually we use the phased array probe. In thin lean patients, we can go with the curvilinear probe as well. So the area of examination is between the anterior axillary line and the midclavicular line. So you put an M mode, the diaphragm is almost approximately up to 14 to 16 centimeters in distance. And if you put an M mode to this, you'll be able to see that there is inspiration and expiration movement. And then we measure this with the help of the caliper. And then this is the diaphragmatic excursion values. So during quiet breathing, the difference of up to 1.5 to 2.5 square centimeter is the normal one. Even in deep inspiration, 5 to 9 square centimeter is found. And if it is less than 1 centimeter, we label it as inadequate diaphragmatic function. And these are indicative of the failure to wean. So it is more useful in the critical care setting, wherein you want to get the patient out of your ventilator and you continuously assess these parameters. Again, in neonates and in pediatric patients, lung ultrasound is of immense importance. It also helps to understand the surfactant requirement of the premature newborns. There are multiple studies related to that. I'm not going in much detail. One thing of transient tachypnea of newborn is this, wherein we'll be seeing the double lung sign. Double lung sign actually means that there is an upper normal lung, this part, and this is the abnormal lung, wherein you can see all the B lines over here. So this is called as a double lung point. It has multiple uses in neonates, wherein we put the patients on ventilator, then weaning, providing surfactant, or diagnosis as well in the premature and neonates. So how do we apply lung ultrasound? I think I have covered almost, but just to enumerate them, in the preoperative period, we'll be looking out for occult effusion, pulmonary edema, consolidation, pneumothorax, and in certain cases where the history is unequivocal or incomplete, and we have to be sure of our diagnosis in the PAC duration. How intraoperative applications, again in thoracic anesthesia, we'll be able to confirm the one lung, and if again we find desaturation or if there are any problems going on intraoperatively, we'll be able to monitor them, identify any atelectasis or recruitment maneuvers that can be done during thoracic anesthesia. And most important for us is the unexpected events. When there is sudden desaturation, when there is sudden rise in the peak pressures, we can easily scan the lungs and find out what exactly is wrong, pneumothorax or new consolidation which we have missed, all of this. So it is essential that we start adding focus and doing it on a regular basis in our practice, especially for the long cases. Post-operative complications, I'm sure that each one of us has experienced desaturation, and if it doesn't, it is not treated within some time, so we have to do the focus, find out what exactly is wrong. Again, look for these pathology, and as per that, we can give treatment or hike our imaging techniques. And also, if there is pneumothorax or pleural effusion, thoracocentesis and chest drains can be put under real-time imaging, and then we'll be rest assured that we have done the right thing. The best benefit is it is bedside. You can do it immediately. You don't have to shift the patient, causing more problem otherwise. Pitfalls, yes, obese patients, scars, these are all going to be difficult. Again, it's an operative dependent one. The more we do it, the better we can become at it. So that is the idea about the lung ultrasound. So my take-home message is, yes, lung focus is definitely the gold standard. It should be used, more and more used by each one of us. As I've said, it is rapid, bedside, portable, easy, and it also keeps us medico-legally safe when you actually show it or write it down in your paper. And all of you know that this is the diagnosis of the patient, instead of just arbitrarily thinking कि हाँ bronchospasm हुआ है, consolidation हो सकता है, aspiration हो सकता है. We have a proof to say that what has exactly happened in these patients. So it is literally the visual stethoscope for all of us. So yes, it does belong over here. So before I say my final thank you, I would request you to be a part of this Navicon, which we are holding on 21st June in Navi, Mumbai. It's going to be the first of its kind in Navi, Mumbai, and I wish that all of us residing and being a part and working over here should be a part of it. And we have excellent speakers from the entire Mumbai coming up. We have excellent masterclass sessions, and it is going to be an academic feast, academic extravaganza. Plus, we'll be having a good time in the evening, unwinding ourselves from our busy schedule. So, thank you for your time. Thank you.
Excellent presentation, Dr. Jayashree. Very good explanation with beautiful videos and pictures. Thank you very much.
Thank you, Dr. Jayashree, for a wonderful presentation. I request Dr. Alvina ma'am to please felicitate Dr. Jayashree. So having explored the upper airway, thorax, we now move on to the abdomen. May I request Dr. Shwetali to introduce our next speaker,
Hello.
Dr. Senthil Kumar.
Would like to invite Dr. Senthil Kumar. He is a consultant anesthesiologist from Kokilaben Dhirubhai Ambani Hospital, Mumbai. He's an active member, governing council member of SAMS, past ISA Mumbai Executive Council member, with niche areas being regional anesthesia, POCUS, and robotic surgeries. He'll be speaking on gastric POCUS.
Thank you, chairpersons, for the kind introduction. I know it's a postprandial time. Everybody would be sleeping, but please be awake. I will be showing your stomach right now. So gastric ultrasound and POCUS. See, POCUS is something which is you do with something called as pattern recognition. So POCUS is pattern recognition. As you would have seen, Viral would have shown you a string of pearls. So it's a pattern in black and white. So seashore sign, bat sign. So POCUS is all about pattern recognition in black and white, which you will have to get accustomed and familiar to. And POCUS, we have something called as a POCUS question. So we don't replace radiologist on using ultrasound. We are not going to give something, a detailed report of what the patient is having or what we are looking for. So POCUS is POCUS question. So whether the patient is having pneumothorax or not, whether the patient is having regional motion wall abnormality or not, whether the patient is full stomach or not. So based on that, you decide. Suppose a patient is having hypotension, so you need to know what is the reason for hypotension, whether the patient is having less fluid or hypo because of less fluid. So you see for IVC. If the patient is you are suspecting a regional motion wall abnormality, perioperative myocardial infarction or ischemia. So you look for the echo and see if there is any regional motion wall abnormality. So you always should have a POCUS question before you do the ultrasound on the patient. So why gastric ultrasound? Because it is reliable, non-invasive, quicker, and it is an effective tool. Objectively, within few minutes, you can pick up whether the patient is having an empty gastric antrum or patient is having any clear fluid or the patient is having a solid. Because in patients with delayed gastric emptying time, even after the patient is having adequate NBM hours, the patient can still have fluids inside the stomach, which can cause aspiration. So it's necessary that you assess the gastric contents or the residual gastric contents and the aspiration risk at the bedside in a quicker way. And airway POCUS is incomplete if you don't do a gastric POCUS. So gastric POCUS is a part of the airway POCUS because patient is having aspiration risk, solid contents or liquid contents with a difficult airway. Then how will you manage the patient? Whether you have to do an awake fiber optic intubation or whether you're going to do a video laryngoscope, rapid sequence induction, and all those things. So airway POCUS is incomplete without a gastric POCUS. So the stomach is from the lower esophageal end to the upper duodenum. So what is the area of interest when you do a gastric ultrasound is the pylorus. Sorry, not the pylorus, antrum, pyloric antrum. So why antrum? Because of the consistent location in the epigastric region, and you can have all the sonographic windows. The fluid you can see, solid you can see, and an empty gastric antrum just with a little air you can see. And it is superficial, so just below your rectus abdominis muscle, between your liver and the pancreas, you can spot the gastric antrum. And something called as gut signature. And what is gut signature? So you have a distinct 5 layers in the gastric antrum, which is thicker than your bowel. So antrum is thicker with these 5 layers distinctly seen in your ultrasound. So you can have serosa, which is thin and hyperechoic, and then comes the muscularis propria, which is hypoechoic. So there is alternative hyperechoic and hypoechoic structure that you can see. So submucosa, which is hyperechoic, and again muscularis mucosa hypoechoic, and the lumen, where there is a air mucosal interface. So all air mucosal interfaces appear hyperechoic, which is white. So that's the rectus muscle, this is the lumen, and this is the gastric antrum, where you can see the 5 layers. So at least you'll have to spot the gastric antrum lumen along with the muscularis propria, which is hypoechoic. So as already spoken by Dr. Viral, the I-AIM framework for point of care gastric ultrasound. So the I-AIM framework is for every POCUS that we do, which is a logical stepwise approach for doing a POCUS examination. So for point of care gastric ultrasound also we have I-AIM framework, which is what is the indication, how will you acquire the images. Now based on the images that you have acquired, what is your interpretation? And based on that interpretation, how your medical decision is going to be, how you are going to treat the patient accordingly. So that is I-AIM framework for gastric ultrasound. So now, is it easy for all of us to do the gastric ultrasound or any POCUS examination? Yes, because 33 scans which can help you to diagnose with 90% accuracy. So coming to the indications, so the primary use is to assess the aspiration risk when you don't know the NPO status. So we all know when there is an emergency situation, urgency situation where you don't know the fasting status of the patient, and patients who cannot communicate with you, or patient who's having an altered sensorium, patient who neurodevelopmental disorder, so children, you cannot communicate with them, so there you can do a gastric ultrasound. And patients with delayed gastric emptying, so the most common being diabetes and other critical illnesses. So delayed gastric emptying you can assess objectively. Now, when there is a normal anatomy of the gastric antrum, you can qualitatively and quantitatively assess your gastric antrum. But when there is an abnormality, suppose patient is having an hiatus hernia, patient is operated with sleeve gastrectomy, then you will not be able to accurately measure and do. So recently we have GLP-1 agonists. We all know that it is increasing in the treatment of diabetic patients for weight loss and for cardiovascular complications, so which causes gastric emptying time, which the delayed gastric emptying time. So it is important that you do a GOD protocol, which is gastric ultrasound for aspiration risk determination in these patients. So this is a good article where you can go through the status guidelines for patients who are on glucagon-like peptide receptor agonists. So are there any contraindications for gastric ultrasound? Yes, if the patient, you cannot give patient the position, supine or right lateral decupitous position, which we usually give to measure the gastric antrum. Or if the patient is in acute pain, traumatic patients, when the epigastric region is with trauma, then dressings, then you will not be able to do a gastric ultrasound. So that is one of the contraindications. So are there any limitations of gastric ultrasound? Yes, patient who is undergone gastric resection or bypass, gastric band in situ, fundoplication and large hiatus hernia. So you will not be able to appropriately do a gastric ultrasound and objectify the management. So next is acquisition. So how to do? So what is the position of the patient? So you first do the examination in supine and then the right lateral decupitous position. So now the right lateral decupitous position, patient will, the gastric contents because of the gravity will come down so that you can measure the clear fluid in it. Suppose the patient is having solid contents in supine position, we know that patient is having high risk aspiration. When there is a clear fluid, then you will have to measure. You know that a little bit of a clear fluid will be present in all fasted patients. So you will have to put the patient into right lateral decupitous position, and if it is a significant fluid that is available in this position when you quantify the patients, then we know that this patient is for high risk. So what position for the USG machine, which is the ergonomics? So the patient is on the right side, the ultrasound is in the right, to the right of the patient, use it, and then with the left hand you maneuver the ultrasound, and the right hand you hold the probe and acquire the image. So which probe? So because the abdomen is at a depth, so we use a curved array low frequency probe to acquire the image in children who are greater than 30 kgs and adults. So can we use a linear frequency probe? Yes, you can use a linear frequency probe in children less than 30 years and a thin built individual. But with low frequency probe, the vision is more. So the number of structures that it can accommodate and in the sonoanatomy is more. So it is better to use a low frequency probe. So what is the knobology? So before doing any scan, you will have to do a preset. So here we have the abdomen as the preset, so that the ultrasound machine by itself will give you the depth. So you would use color Doppler to identify aorta and other blood vessels. You adjust the depth and gain and focal zone. So this is the picture showing abdomen preset, and you will get abdomen here, and this is your orientation marker. So question is, what do we see? So which is the scanning plane for the patient? The scanning plane is either a sagittal scan or a parasagittal scan, keeping your probe in the epigastric region, subxiphoid region. So when you put the probe, this is the structures that you're going to visualize. So you have the liver. So your gastric antrum is in between the left lobe of the liver and the pancreas behind it. You should have aorta in the window, not the IVC, and you have the spine behind the aorta and superior mesenteric artery which is taking off from the aorta. So when you see the gastric antrum, you will see superior mesenteric artery and aorta, so and the liver. So this is your rectus muscle, this is your hyperechoic liver, and this is your gastric antrum, you can see, and this is an empty gastric antrum with the muscularis propria, which is hypoechoic. See, it's called the bull's sign or the target eye sign. And you see a hypoechoic structure here. This is your aorta, this is your spine. And the spine casts an after shadow. So this is the after shadow that you see. So superior mesenteric artery and pancreas. So the gastric antrum lies below your rectus muscle between the left lobe of the liver and the pancreas. And pancreas is hyperechoic. And you should have aorta as the window to measure your This is a video that I have taken yesterday only in an elderly patient. So it's a poor sonogram anatomy view that you can see. But still you can see the gastric antrum which is empty. She is a fasted patient. This is your liver and this is your aorta. And this is probably your pancreas. And this is your spine over here. So that's the aorta. And this is probably your superior mesenteric artery. So when will you measure, because the gastric antrum and your bowel is going to have peristalsis, so it's continuously going to move. So when you have to measure the patient antrum. So the antrum, you should observe the antrum at least for 10 to 15 seconds to obtain a representative observation. So in between the peristaltic movement, you take 3 readings and the average for the cross section of your gastric antrum to measure the volume. So now you're going to interpret. There are 2 things, qualitative and quantitative assessment. So qualitative, which is the antral grading system that we have. So as I said, this is the empty antrum, is the bull's eye sign or the target eye sign. So when the antrum is empty, so the anterior and the posterior wall of the antrum is going to be flattened and it will be a ovoid structure over here with a little air inside it. And you can see the muscularis propria around it, which is hypoechoic. So that is causing your bullseye or the target sign. Then coming to the clear fluids, one clear fluid is going to be anechoic or hypoechoic, as you see here. This is the gastric antrum, pancreas behind and aorta. And this is the diaphragm with the liver and the rectus muscle and the skin. So the fluid can be anechoic or hypoechoic. And when you drink the water, then you inhale air also. So they can have a starry night appearance, which is called, this is the starry night appearance where the gas bubbles is seen mixed with the fluid. Or you take a fizzy drink, so this would be the appearance. What is frosted glass appearance? So this is the solid that is present immediately after your food intake, where the gastric antrum is completely distended. I think most of our antrums will be like this only right now. So when you take the food, you're mixing the food with fluids, you have secretions, then you have air also, you inhale air also. So air is a poor conductor of your ultrasound, as Dr. Jayashree had just mentioned you. So it will not conduct the ultrasound, so it's going to cast an after shadow. So because of the dense air that is present here and a distended abdomen, only the anterior wall of your antrum is seen. And it has cast a shadow. So this is the after shadow. So this is the frosted glass appearance. And this is the antrum that you will see after 2 hours of your solid intake. So it is going to be heterogeneous in echogenicity like this, mixed echogenicity with air and fluid and solid. So what is the qualitative grading? So we grade it as 0 antrum, grade 0, the antrum which is empty in both supine and right lateral decubitus position, which is minimal or no fluid, so which is low risk for aspiration. Now grade 1 is fluid is visible only in the right lateral decubitus position, but that there is no fluid that is seen in the supine position, then the most probably the volume is less than 1.5 ml per kg, which is also low risk for aspiration. So grade 2 is both in supine and right lateral decubitus position, which is going to be solid, and fluids which is more than 1.5 ml per kg. So which is high risk for your gastric aspiration. So this is what I mentioned now. So empty stomach, no content visible in any patient position, which is grade 0 antrum just now. Then clear fluid in the right lateral decubitus position, which is grade 1 antrum. And you do a cross-sectional area, which is less than 10 centimeter square in the right lateral decubitus position. Then clear fluid, which has a gastric volume less than 1.5 ml per kg. Opposite to this would be a full stomach. So how are you going to measure the volume? So when the gastric emptum contains clear fluid is when we are going to measure the gastric antrum. So this is how you mention, you take a craniocaudal and anteroposterior diameter. This is one method, or you, using the caliper, you can trace the serosa, the entire serosa you trace, and then put it in the formula. So with respect to your anteroposterior diameter and the craniocaudal diameter, you put the cross-sectional area based on this formula. Then you look for the volume. So trace cross-sectional area from serosa to serosa in right lateral decubitus position is warranted. So the volume measurement is based on this formula. So, and you measure always the gastric antrum in right lateral decubitus position. So this is a chart based on the studies from volunteers. They have already made it based on the age and the cross-sectional area, so that you can directly have the absolute volume in the gastric antrum. Now the shaded areas is for low risk, which is less than 1.5 ml per kg. So in pregnant patients, can we do? It is going to be very difficult because of the uterus and the moving fetus, and the gastric antrum would be pushed cephalad and more anterior. So it is little difficult to measure, and also because the steep angle between the abdomen and the xiphoid. So you will not be able to place the probe. So medical management, you know whether it is low risk or high risk. So if it is low risk and high risk, whether you ought to go ahead with the procedure, whether it is an urgent procedure, it is a elective procedure, whether you have to postpone or not, whether you are going to do a rapid sequence induction, delay or cancel, and also to convince your surgeon objectively that this patient is high risk for aspiration. So full stomach by gastric ultrasound, and you find a difficult intubation by POCUS, you do a fiber optic intubation. No difficult intubation by POCUS, you do a rapid sequence induction by direct laryngoscopy or a video laryngoscopy. Thank you.
Thank you, Dr. Senthil, for an excellent presentation. May I request Dr. Shwetali to now felicitate Dr. Senthil Kumar. We move on to the last talk of this session. May I request Dr. Vijay Shetty on stage. He is a highly respected anesthesiologist. He is very senior, proficient and experienced. Thank you, sir.
Thank you very much. That could probably be said for everybody who spoke before me. I think hopefully you young people have been paying attention to the focus sessions, and you'll get a great your money's worth for the session. I would also want to remind that this is what our constant endeavor was, that we make the echo probe or the USG probe as a stethoscope, and this is probably right extension, and believe it or not, you guys are very primely positioned to make the best of it. So my talk was supposed to be for neuromonitoring in cardiac surgery, but I got to know, because I was late, I thought I'll be addressing most non-cardiac people. So a typical neuromonitoring in cardiac surgery would involve definitely cerebral oximetry, but I'm not going to speak about that because that has got functionalities more in cardiac surgery. What I'm going to speak about is ECG-based depth of anesthesia monitoring. Thank you very much, respected faculty. I'm respected chairpersons for, I not acknowledge you, but thank you very much for this. So how many of you using depth of anesthesia monitoring in your OTs? Depth of monitoring anesthesia is something like a BIS. Anything else? End-tidal agent? All of you are anesthetists? Pehle haath uthaiye, anesthetists? Yes. So you are using some depth of anesthesia monitoring, or you can say I am the depth of anesthesia monitor. I know when the patient is asleep or I'm awake. So somebody is there always in the OT who is having knowledge about the depth of anesthesia. So I'll just tell you about how a process ECG work. And this is another thing that you should be very much clear in your head as to how it works and how it functions, because there are a lot of pitfalls in this, and unless you know that, you would probably be doing a wrong or you might be doing an error in your work. Again, what I like to say, having a superior machine or a superior technology does not make you superior. It's only if there a person who's behind the technology is able to understand what is going right and wrong, understand the pitfalls, having the clinical context, and then putting it into. So why do we monitor depth of anesthesia? Because we never know, seldom know if the patient is properly anesthetized. If the patient is too deep, then what happens? You wasted extra anesthesia on him. That is not the problem at all. Actually, that it also means that the patient can have postoperative cognitive dysfunction. He has a prolonged time for recovery, and obviously your surgeon and your team will be dissatisfied. If your patient is too light, which is the first reason why the BIS was used or the bispectral index was used, because you would not want the patient to have awareness under anesthesia. Certainly not. So one of the first things that happens is that you want to detect that the patient is not aware. So if the patient is too light, you will have a very unsatisfied patient. You will have a lot of neurocognitive problems because of that awareness that the patient gives. And overall, you have a very dissatisfied patient. So what the BIS technology does, you can see all these ECG waveforms which are there here. Right from the very slow, what you can easily make out even from the distance is the frequency. How many waveforms are passing through a point in 1 second. So this is a very high frequency waveform but very low amplitude. This is whereas the theta here down below are very high amplitude waveforms but very slow frequency. So this much is available. So I would request you, going back to your OTs, when you see the EEG, which you have a basic EEG playing, even when you're using the BIS monitoring, just have a look at how the amplitude looks, how the frequency looks. That gives you an idea as to whether the number that is reflected. So what this is, there is a proprietary algorithm in something like the Metronics. Everybody's got his own algorithm which nobody understands. So basically they fuse together the EEGs and then give a number, like a heart rate, they give a number. This is the number. And then we are expected to keep the BIS between 40 to 60, in which state we expect that the probability of the patient being awake or aware is extremely low. If a patient's BIS is above 60, does it mean he is awake? No, it means that the probability of him being aware is probably there, or he is more nearer towards awakening than towards deep anesthesia. Okay, so that's just a play of words, but it tells you where you stand. This is a busy slide, but just to tell you that the BIS, actually, there are something like entropies, etc., which are set lines which are used, or even the BIS, but the BIS is one of the most studied subject, thousands and thousands of papers on that is there, and that's one of the technology that we follow very routinely. Entropy is also available but entropy has got certain advantages in when cautery is used, etc., which the BIS does not have. So you might find yourself in a situation like this. If you're using the BIS, your patient has got hypertension, tachycardia, and then you think it is light, and you might have a BIS which is very high, a BIS which is very low, or BIS which is normal. So at that time you have to stand or take a call as to what you're going to do. Do you think whether the BIS value is high, BIS value is actually correctly displayed, and then whether there is an option of you giving an extra anesthetic, or whether you have to give a beta blocker or something that to get to pressure down. So these kind of decisions can be made because you have an extra monitor which is going to help you decide whether the patient is light or whether the patient is deep. So what is the worst case situation that you can have? You can have a patient who is hypotensive and has got a very low BIS, right? So if the patient is hypertensive and the BIS is high, very clearly he is light anesthesia, so you need to give him some anesthetics. So there are a lot of benefits that has been, studies have shown that the bispectral index is accelerates recovery. There is no rocket science in that, eye-opening orientation. So we're not looking at saving these few minutes of recovery or early shift out of the recovery room. We are looking at actually whether accidentally we have caused much more deepening of anesthesia, which would have deleterious outcomes, which we will not know. For example, I like to give the example of a 75-year-old person who comes for oncosurgery, excellent surgery, excellent anesthetist, and then when the patient has extremely deep anesthesia for whatever reason, and he has a postoperative cognitive dysfunction, delirium, he has another fall. Now a person who you conducted a surgery very well, the surgeon has done a minimal access or a robotic surgery, now goes home, and now the person is no longer dependent. Now he is no longer independent. From then on, because of surgery or the anesthesia, he has now become a dependent person or a less confident person. So our role, especially in the elderly patients, is to make sure that they recover without any as less neurological harm as possible. Okay? So this we accord to our children. The same thing has to be accorded to our elderly population as well. Similarly, in neuroaxial anesthesia also, where we give sedation or we might give some small propofol just to keep the BIS around 60 to 80. Even these kind of scenarios also, the BIS is extremely useful to see exactly titrate how much you want to be giving. And very interesting, this is always I wondered how is the BIS titrated with the inhalation agent, because most of us use the balance anesthesia, we use inhalation agents. We do not know if we use the inhalation agent, we use the end tidal gas, whether the BIS is actually reflecting something. So I will just, as you can see here, for example, at 1 Mach, which is supposed to be equipotent, the BIS value of halothane was around 60, the isoflurane was 45, and the desflurane was 38. If it was equipotent, we would expect that the BIS value would be same, approximately same in all the agents. That is not the case. So even this is again a recovery pattern. As you can just see, there are two groups of patients. In one group of patients, the BIS acts exactly like how it would act in a inhalation, in a totally intravenous. Like as you become deeper, you can see most of the patients, irrespective of, in the blue one, irrespective of what effect site concentration was there, 0.4, 0.6, 0.8, this is the effect site, inhalation concentration, but they're all waking up at a BIS of 80. So this is one group of patients. And other group of patients, they will wake up at different groups. So we do not know your patient falls into which group. These are the two types of patients who are there existing in the population, and their representation of the BIS may not exactly tune in with what you're expecting the inhalation agents to be. So end-tidal relationship exists with the BIS, but it cannot be used as to fine-tune, but you can have a gross control. Like if a patient, you're getting inhalation anesthesia and you suddenly find the BIS is going up to 80, your patient is actually most likely becoming light as long as you look at the other caveats. So the challenges for BIS that it can never be used in isolation. That means you cannot use just a number and think that everything is okay. You just manage a number and you can prevent deep anesthesia or avoid light anesthesia. There is a relationship which exists with the inhalation agents, like I already said. It has got a great role in sedation practices in ICU as well as in out of OT, which is one of the least used areas in our population, I guess. But as you do more and more high-risk patients and more aggressively you pursue minimal access things in the out of OT, your dependency on these technologies will be very, very high. The recommendations would encompass suitable. There are Indian recommendations now, which I was also fortunate to be part of, which tell you about the problems that can exist with various patient groups and where exactly it can be used. Regular training and of course intraoperative BIS monitoring should certainly be available for. This is some of the guidelines that are there. Like if you're using TIVA and you're using a muscle relaxant, it is very, very important that you're using, because your patient will not be able to move and tell that he is light or she is light. So you will have to use the BIS in these kind of scenarios. So there are a lot of good statements there. You can please go through this. What is wrong in this picture? Somebody can tell me? So if you use the BIS, you need to tell me the answer here. What is wrong means what you do not like in this picture. Anybody can say? Yeah, come on. Sahi hai, huh? Max 0 acha hai na, you're using TIVA, so there is no inhalation agent. That's a good thing apparently. Anybody? Saurabh chocolate dega aapko, chalo. So one of the things that many people monitoring BIS don't see is suppression ratio and suppression time. So suppression time is not available in the older BIS machine, but you have a suppression ratio. What the suppression ratio tells you, in the last 64 seconds, what is the percentage of that minute that the patient had an isoelectric or a very depressed EEG. So in this case, you can see it is 37. 1/3 of the last minute, patient had a very deep anesthesia. This doesn't come out on its own, you have to see for it. So if you have a SR on the monitor, from tomorrow onwards, whenever you use the monitor, make sure that you put the suppression ratio, which tells you that the patient is coming into deep. So he has got a BIS which is around 30, is already deep, right? But he also has a suppression. You have to act here. You have to get the patient out of the light anesthesia zone. That is what I am trying to tell. So we are also now going to more advanced I just go through very quickly through this. What you saw, the various waveforms, in any particular minute or any particular second, what is the density of each waveform is what this digital spectral array tells. So now, if you would buy a new BIS machine, you would get this trace. It's a beautiful trace for various reasons. It is called the density spectral array. What it tells for the frequency of for the waveforms of 0 to 4 or lower theta waveforms, if it is that is the predominant waveform, in any time you can find theta, beta, everything together. But what is the density of the wave? You can just say what is the weightage of that particular frequency. If it is very high, it is properly, you will find it in red color. So when you see the red color, that means that frequency is the most obviously high, most obviously represented in that time. So example, if a patient was like hopefully I'm putting EEG on you now and you're listening to what I'm saying and not sleeping, you would find that the frequency would be beta. So there will be red color, if at all, there will be no red color here. There is no theta happening here. So you would find most of the color, the heavy colors here. Whereas when anesthesia, when the frequency goes down, you find more of those, less of the beta waves, more of alpha and theta waves and gamma waves, that you'll find that the lower part of the spectrum will become heavily loaded. Okay, and then something called the spectral edge frequency, which tells 90% of the frequencies are less than this, and this is the middle edge frequency. I think if you're keen, you can go and read it. Well, why this is coming around? Because this is a representative article for this. If you're using BIS, just like to monitor your anesthesia, the corollary is it is like using the ECG trace and just getting a heart rate. You're not seeing the STs, you're not seeing the PQRST, you're not seeing anything. You're seeing the heart rate and saying, patient is okay, patient is okay. Similarly, if you're just using the BIS and getting a value and using it, you are the same way, okay? You're not using the other part. So whereas this DSA will also tells you that that your patient, when he has a 40 BIS or 35 BIS, it's actually low because the representation of the graph will help you to do this. So this is what I'm trying to tell you. The delta, theta, alpha is around 8 to 12, so it will be more, red will be here. So typically when anesthesia, when you do this in a properly anesthetized patients, you will find two bands. One is in the delta band down and one is in the alpha band. Sevoflurane and propofol, when you give this anesthesia, I'll show you in this next slides. Whereas if a patient becomes light, he will have more of these beta. So these red colors will not be appearing here. Okay, so let's see if I am able to show. This is just to show you, this patient is getting sevoflurane. You can see this lower band red and around 10 band red. So did you know this part? That actually we do not know how anesthesia works. But somebody who's worked for 20, 30 years, now we are able to see actually that anesthesia is working. And that is, I think, one of the biggest things that this DSA does for me. You give ketamine, obviously the EEG changes and there's a lot of hyperactivity to the EEG. So everything disappears. See, this is, you give ketamine here, the whole pattern, that beautiful pattern that has disappeared. So this is the spectrogram for age. I'll just go to other diagram and show you. This is a 30-year-old patient. See how this brain is? You're getting those two bands of red in a propofol anesthesia or a sevoflurane anesthesia. But see what happens to an 81-year-old patient. There is no red band here. This is telling you about the aging of the brain. So I'm in my age, like if you see this, I'm hoping that if somebody gives me anesthesia, I can see this, because this is represent almost like how a young brain is. And some other 56-year-old old brain, he's having a brain which looks like an 81-year-old. So every patient who comes to your OT is actually physiologically, or he might be much older, or he might be much fitter and younger than. So you can see this patient, they have 25 years between them, but they have almost the same signal. So it would be safe to say this patient has the same risks of a poorer neuro outcome than the 81-year-old, is what I'm trying to tell you. Why this helps you? Because if you already know the patient is at risk, then you can do all these things to avoid. Like you have things of identifying the risk. You have a preoperative prevention, intraoperative what drugs you can use, and so on and so forth. That is in fact a safe safe brain initiative, which the world over it has been initiated. And one of the things is about looking at the EEG and seeing. So this is something that younger people will have to do in the coming days. So let's see burst suppression. So what happens? So you can see this burst suppression. This is the newer machine. You can see SR is a suppression ratio. But what the older machine don't have a suppression time. Like if I go to the OT now, I will see the suppression time of 0.54, which means that in cumulatively, from the time that the patient has been induced, 0.54 seconds, the patient had a deep anesthesia. Okay, now you can see it is still going on. In today's machine, in the older machines, if I go after 1 hour, that you have to go to 5 minutes, that value won't be there, because your suppression ratio talks about only the last 1 minute. The suppression time tells you about. So this is what a suppression looks like. Okay, you can see this. We just give a little bit of more anesthesia, or somebody's given just a little bit more profit. You can see this. The whole thing has become straight and flat now, and you can see if this timing, this remains straight, this just remains constant, whereas this suppression time or the suppression ratio talks about the last 1 minute, suppression time talks about the cumulative. This is after 2 hours. There is no further addition to the suppression time. That means after that the anesthetist has been careful not to give deep anesthesia. But this information is available only if you have the modern machines. And again you can appreciate the 2 red splits and the yellow in between, the alpha and the gamma waves. So this is one important thing again. If you're using the BIS, you have to always be careful about the contamination of the EMG. You can see these 2 parts where the EMG was high. So these high BIS values are also because the patient was light or he had frontal movements, and that has caused contamination of the signals. That for this high BIS values, when you see high BIS value, you always make sure that the EMG value is within 30, 25 on the lower side and not high, because most definitely the EMG is going to influence the things. So when you get a low BIS, you can always confirm that your SEF and the medial frequency and the spectral edge frequency. That means 8 is 90% of your frequencies of the EEG are below 8 Hertz. That is how deep this anesthesia is, and that is why you can confirm that this 30 is actually very low and you need to go up on that. You can see that the suppression time and suppression ratio are the same. They are not been disturbed. But this gives you a chance of lightening the anesthesia or getting your BIS back up, and that is I believe, a superpower. So one last thing I just said about a lap myomectomy in which they had given vasopressin. I think many people would have seen it. You can see this gross bradycardia happening here. Just out of interest, I'm just trying to show you what various you can see the BIS and the suppression time. This is a TIVA case, again under propofol, remifentanil. The gross bradycardia happened, and you can see that the BIS is maintained, number 1, and also its suppression time and suppression ratio remains 0. So what we are usually worried about is when this transient bradycardia happens and very severe bradycardia happens, you're not able to measure the BP, etc. You're worried about what is happening to the patient, but your patient's brain is intact, and that is what I'm trying to show you here. So the monitor does not think the anesthetist does. That is what I like to say. Know the principles, monitor early. For example, if you put the monitor early on an elderly patient and it shows that the patient's BIS is already very low, especially elderly patients, that patient definitely, before the induction even, that patient definitely has a much higher chance of having neurocognitive issues. So this is what I would like to end with. I think already Jayashree has told about the MASCON and the NaviCon she's told about. And how many students are there here? And we are all students of anesthesia, I understand, but so I would invite all of you for the NaviCon and the Mumbai Anesthesia Society MASCON as well, and I would request you to present the papers. There is one more PPT, if I can just take 1 minute. Any questions, or anybody wants to ask anything, you can ask it later on, but I'll just try and tell you about our meeting. This poster is quite viral, I'm told, and you've seen this 24th and 25th of October. So I would like to see everybody of you coming to the MASCON in Aurika, which is every 2 years we have this, and this meeting has consequently evolved that the people who attended the MASCON now are arranging it. For example, these 3 people sitting in the front, they are usual MASCON Janta, but now they are the ones who are going to be organizing the future meetings. This is the Aurika by Lemon Tree, excellent place, and if you've not been there, this is your chance. We got superb national faculty. You see Shiv Shanmugam, Sunil Pandya, Anju Grewal, Raj, Murali sir, ex-editors, IJ presidents, etc. will be coming. Also, we have Dr. Bala Venkat, Dr. Ramesh, Bhavani Shankar. these are people that you have to pay lakhs of rupees to go abroad and listen, or you have to travel to some other country. Now they're coming to your city, so I urge all of you to please come and do it, and attend, and please make the most of those 2 days. And for the students especially, this is one point I don't want to be missed. This is in memory of my great friend, dear friend, Dr. Samir Pradhan. He used to work at Hirandani Hospital, and he unfortunately passed away battling cancer. And in his memory, we have this Best Research Award. So this carries an award, a gold medallion and an award of rupees 51,000. And over the years, we find that young people come up and present. The presenter has to be post doing his studies, or he has to be 3 years post qualification. So please make sure that you send a lot of even your thesis that you've done. You could probably come and present that. There are a number of other categories of original research, case reports, and for the senior as well as junior anesthetists. And also, one more thing, that even if you're not academically inclined, there is a director's award for making videos about some jugaad, some hack. There's one option. Or second, you could just do about 1 day in anesthesia. How is it humorous? Bring out the laughs, and there are good prizes for this as well. Number of other things to participate and engage. So I'm sure that all of you are looking forward to the MASCON, and I look forward to seeing you all for the MASCON in 24th and 25th of October 2025, and also at the NaviCon. That is 2 Sundays hence. So you can have a Sunday in between as a gap, and then we'll see you on 21st. Thank you so much, and I'm sorry for the time, but I really appreciate you sitting and making up on this. Thank you so much.
Thank you, Vijay sir, for an extremely engaging talk. May I request Dr. Vikram Vaghalkar to please felicitate Dr. Vijay Shetty, sir.
So Vikram is our old friend from Fortis Hospital. He and I spent many years together. Thank you, Vikram. It's a very great honor for me as well.
So as we conclude this session, may I request Dr. Jessie ma'am to please come on stage and felicitate our esteemed chairpersons. Dr. Olvina D'Souza ma'am. Dr. Vikram Vaghalkar sir. Dr. Shwetali Wadke. Dr. Ajit Pillai sir. Can we have all the speakers of this session and all the chairpersons for a quick picture on the stage, please? I now request Dr. Saurabh Tiwari to give the vote of thanks.
we have a workshop still remaining, but I would like to, I know it is a very exhaustive day and you all may be tired. We have a brief tea session first, and after that we will proceed for the workshop. To organize this big SEMI, we have at least 140 registrations, and for workshop the registrations were full, and it was still 80% who have registered for the workshop. Now it's time, it's 4 o'clock, and still you all are still sitting over there and patiently listening is a very big thing. I want to give a big clap for all of you. I would like to thank the sponsors of this event, BD, Fresenius, Neon, who have sponsored the event, and would like to felicitate them. My team members, the consultants and DNB students, my juniors of Anesthesia department who have worked tirelessly to make this workshop a successful event. I would like to call them one by one on stage. Dr. Shantanu, please give a big clap for them. They are the people behind the scene who have done a big thing for making this event a success. I would like Dr. Ajit to come on stage and felicitate all our team members. Dr. Shantanu, Dr. Susanna, Dr. Dr. Susanna, Dr. Ajit, please do the formalities. Dr. Surovi, these are the people at the backstage who have made this event flawless, and all the sessions were conducted flawlessly. Thanks a lot. Dr. Surovi. Dr. Trishna, please come, everybody here. Dr. Trishna. Dr. Siddhi might have called all the speakers. He might have troubled you for your CVs. Dr. Siddhi Sawan. Our ISA treasurer, Dr. Manoj Adhav. Please come on stage. Dr. Preeti from Registration Committee, please come on stage. My dear DNB students, Dr. Shirag, Dr. Audric, Dr. Rasika, please come on stage. Audric. So Dr. Audric and Dr. Rahul are still busy in Kotlab. Yeah, he is the person. Our stars, our rising star. Along with that, I will thank the FNB team. Ravish, our photographer, you will see his efforts. When you get the photos, you will say, wow. Ravish, please come. Unka photo aur koi nikalo. These people have made our program a success. We are indebted to them. Dr. Ravish from the photography team, from FNB team, Sushil Bhujbal, is he there? And from IT team, Mr. Kundan, please give them a big clap. They are the persons who have worked tirelessly for the success of this program. Please, my photo. Mr. Kundan has uploaded the slides, everything's flawlessly. So the FNB guy is not there. I hope you had enjoyed the food. How was the food? Okay, so after that, I would like to thank my whole department, ACTA and ISA committee members. Dr. Olivna madam is there, Dr. JC madam is still there with us. With the support, this is the first time we have done a program with ISA and Navi Mumbai. And please give a big clap for the ISA and ACTA together. All our ACTA chairpersons who are still waiting for the workshop, I would like to thank them. And we would like to conduct the program in Apollo every year with all your support and blessings. We will have a tea break for 15 minutes. After that, we will proceed for the workshop. All the faculty for workshop, please stay back after the workshop. Dr. Shailesh, please come on the stage. We have to felicitate you. Dr. Shailesh is a faculty for workshop, but I will felicitate him. Dr. Vijay, please come on. Please felicitate Dr. Shailesh. Dr. Shailesh is a faculty for hemodynamic workshop. Thank you, sir. Dr. Rahul has just come from Cathla. We want to felicitate him also. Dr. Rahul, please come on stage. Dr. Suhas will felicitate Dr. Rahul. He is our student, our JC from Cath Lab. Lastly, I would like to give a thanks to our volunteers who will be there for our workshop, and all the delegates who have come from long and waiting for there. Big thank you to all. Just we'll have a brief tea break, and after that all will come for a workshop. For workshop, we have divided ourselves, the members, into 6 groups: A, B, C, D, E, F. A, B, and C will go for the POCUS workshop. C, D, E will be there for the hemodynamic workshop. The POCUS workshop will be carried in the back, and the hemodynamic workshop will be arranged in the front side. We have, at the time of registration, we have divided into groups. If you have confusion, we can again recreate the groups when you come after the break. Please try to come after 15 minutes again here. Till that time, we'll do the arrangements. Thank you all.
And just 1 minute, the final felicitation of the main person who has organized this whole thing very effortlessly. Over the last 2-3 weeks, I've seen him work very hard. Dr. Saurabh, I've seen him work tirelessly, and the amount of phone calls at weird times of the day and the number of messages I've gone through. Okay, we'd like to thank him and facilitate him. Sure.
The moderators of all the sessions, please come on the stage. We have to felicitate them also. Dr. Leena, Dr. Garima, Dr. Kanchan, Dr. Kalpana. Dr. Vijay sir, I want to trouble you again. Please come on the stage to felicitate our moderators.
Dr. Meena.
During the workshop, we will project a IOCON conference which is to be held. Dr. Reena Gautam has requested to put the flyer. During the workshop, we'll put the flyer and you can see in the program.
Because you are in charge. Somebody must have told you. My tea coffee is here. My coffee is here. I'm saying I got it.
cardiac index, right? And SPV तो पता चल able to form the proper cardiac output to maintain the cerebral output. There are various reasons. Hypertension हो गया, stroke हो सकता है patient को, stenosis हो सकता है. Second reason is कि बहुत ज़्यादा deep anesthesia कर दिया है, तो patient is going through the whole brain damage हो रहा है. तो वही cerebral occupancy तुम्हारा 80 के ऊपर जाएगा, 90 के ऊपर जाएगा. That means one is the एक तो anesthesia बहुत deep है, brain को oxygen requirement बहुत कम कर दिया है, इसलिए extract नहीं हो रहा है. That's why cerebral occupancy ज़्यादा बढ़ गई. समझे मैं क्या बोल रहा हूँ? Brain is brain dead, so he is not use the oxygen. Whatever the going it is not utilized and it comes to the tissue perfusion. So होगा. Same thing happens with the deep anesthesia. So you need to adjust on time cautious कि मेरा बीस कितना है, depth of anesthesia कितना है, कि patient को stroke तो नहीं आएगा. Yes, simple. Like, yeah, so like connectivity, right. आपने जो सिंपल प्रेशर मॉनिटर के सेंसर प्रेशर मॉनिटर के जो सेंसर यहाँ पे ठीक है that's why they predict the value. You already your so one is to go to pressure monitor to the second so it will not disturb this both. Arterialize on the direction as well as in the simple scenario, patient already you have visualized. Now you want to monitor the cardiac output. You can just get the gadget there. You just change your sensor with this one. You extract the data from here. This is a slave value. Right? You put the artery line, heart rate, whatever it will assess the data. This hypertension after counting so many of cases, they have come to the conclusion that this is a very predictable pattern with the AI, which is hypertension will happen. Why it will happen? That means you have to predict the because of low cardiac contractility, low SVR. What is the problem? You have to find a solution for it. You have to take it, then you charge for it. HPA, it is again, it is like I think 10 to 15. It is Viscerovascular resistance is SVR in an afterload.
What we saw was the frontalis and the mitral distance. Now see first is the hyoid. Now you keep the orientation marker laterally on the right side, right side. Keep the, how will you hold the probe while you are scanning? Not like this, right? Just see whenever you are scanning for all of you, the probe has to be held like this. The runner has to rest on the patient's body. Okay? Start now you can just go little up or down. Go little up, down. Great base of tongue. Now you start coming down. Slowly. Keep this in the center of the screen. नीचे आओ, जल्दी थोड़ा. Slowly नीचे आओ, नीचे. Now the angle changes. Here it is the higher one. Okay. Can you all appreciate the bone? Just have to tilt a bit. Just tilt a bit. So this is the higher one. It's a bone inverted U shape, casting a black shadow. Okay. Now you can start moving more down. नीचे जाओ, नीचे. Before you reach thyroid, what structure you will see? Go up. Slow movement. नीचे आओ. Slow. Wait. Now this is the epiglottis. I just place for all of you. These are the two strap muscles. This is the pre-epiglottic space. This is the epiglottis, like a neonatal phase. Okay. So here you measure the distance from scale to epiglottis. If it is more than 2.54, again there's a more chance of vertical damage. Now the next person is. So we saw thyroid bone, we saw epiglottis. Now you will keep the probe at the level of thyroid cartilage. Okay, so now thyroid cartilage is an inverted V-shaped structure. It's an inverted V-shaped structure, okay? And you will see the vocal cords of it. Can you all see? See, these are the false vocal cords. Ebola. Just keep the probe in that. Can you all see the two are more deeper with a hyperechoic ridge are very faintly visible. These are the false vocal cords. Can you all see? These are the two. Can you all appreciate this with the hyperechoic ridge? So that way you are visualizing the thyroid cartilage and the vocal cords. Okay. Now you can start moving downwards and you will be identifying the glycothyroid membrane between the thyroid and the cricoid cartilage. So now your probe has to be on the thyroid cartilage. Come slowly down, slow moving down. Come a little bit more, slow. See now this is the air mucosa.
Hello.
Okay. Direction, see that depends on the angulation of the probe. Acha. Okay. Just a second, can you please hold? Hello. Diva, Papa is busy. I'll call you after some time. Papa is busy. I'll call you. Wait.
looked for the cricothyroid. Okay. Yeah. So now you can come down more. We'll just remove the center line. So this was the cricoid cartilage. Okay. So now we'll be doing the suprasternal. On the left side above the suprasternal notch, identify. Yeah. So now your probe angulation, it has to be, see, you are seeing the esophagus. Just hold the probe. Can you see this is the trachea and this is the esophagus? Okay, this is the right side, this is the left side, this is a muscular tubular structure. So now I will tell him to swallow. Thunki Gida, please. Can you all see, appreciate the change and the movement in the esophagus? So now there is a drastic difference in the sonographic appearance, right? So if there is an endotracheal tube into the esophagus, it will look similar to the trachea, and that is also called as a double tract sign. Okay. So now this was with the linear probe horizontal. Now what we can do is you can turn the probe longitudinal. Next person, aa jao jaldi jaldi. Now we'll see the string of pearls appearance. So you can keep the orientation probe longitudinal with the orientation marker cranially. Cranially, नीचे. String of pearls इधर आएगा. Listen, here. Trachea इधर है ना? यहाँ पे. Hold this. So you just hold the probe in a longitudinal way. Orientation marker cranially नीचे. So you always start from the suprasternal. Okay. Now you are not seeing any tracheal rings, but with little movement, can you all appreciate now? I'll just move my hand. We can reduce the depth a bit because those are superficial. Okay. Now you all can appreciate it more better. These are the string of pearls appearance. Now you start moving more cranially. Slowly, slowly. See now, these were the tracheal rings and this is the, can anyone say what? This is the cricoid cartilage. Okay, so the step up sign, what I said, or step down if you come from above downwards. So these are the tracheal rings. You can count each of them and then mark it for percutaneous dilatation, surgical tracheostomy, what they want to do, or in the ICU. Okay, now this is the cricoid. Now you start moving little bit more cranially. And for all of you, this is the wrong technique to hold a probe. Your probe has to be held in this manner. Okay, your ulnar aspect has to rest on the patient's body, because when you want to do the movements, they have to be very fine. Okay, see now this is the cricoid cartilage, and now I'm just moving up. So this is the cricoid and this is the thyroid here, and between these two is the cricoid thyroid membrane. Next, आ जाओ एक जन, किसका बच्चा, आ जाओ, come from here. The main thing is identification of each and every structure. Okay, show me the string of pearls. Yeah. What is this structure? ये ऊपर क्या है? What is this hypoechoic grainy structure दिख रहा है, वो क्या है? ये नहीं, ऊपर रिंग्स के ऊपर दिख रहा है, वो क्या है? नहीं, फेशिया इतना थिक थोड़ी दिखेगा. इट इज ऑलमोस्ट 1 सेंटीमीटर. थायराइड ग्लैंड ना, ट्रेकिया के ऊपर क्या है? वी आर एट द लेवल ऑफ थायराइड ग्लैंड, राइट? सो नाउ गो अप. So this is the thyroid gland here. Okay, so this also helps if there are vessels. Some patients might be having hypervascularity, and if they want to do a percutaneous tracheostomy, you can put the color and identify, and you can avoid that space. Okay, now go little up, thoda up, or thoda up. See now, while going up, you are supposed to keep the string of pearls and the cricoid. See now, this is the cricoid. यहाँ पे आ गया thyroid. Okay, so between the cricoid cartilage and the thyroid is the cricothyroid membrane. So here you can do the marking again, and you can give the block, or you can do a needle cricothyrotomy. Okay. See, it's a parasagittal. Okay, it's not exactly at the center, little bit more lateral. Yeah, you have to angulate depending on how the vision is. Okay. Next, कौन आ रहा है? आ जाओ. Who wants to come? Come fast. So I want you to scan little bit more up between the cricoid and the hyoid. So for the identification of the between the thyroid and the hyoid, not just cricoid, thyroid membrane. Okay, we identified the cricothyroid. So now show me again the cricoid cartilage first. Slow, 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 slow. वैसे नहीं. See, cricoid इधर रहेगा ना. So you just tilt it. Slow tilt. नहीं, you came on another side. See, just have to tilt. या तो ये बाजू या ये बाजू, दोनों में से एक साइड ही दिखेगा. वो go that side. नहीं. So see now, little bit of clinical also you have to see. So now if you go this lateral and do this, then also you will not be able to. So you come little bit medial. This is the cricoid. Okay. Now here it will be the thyroid, and if you go little bit more up, this is the thyroid membrane here. Okay. Hold between the hyoid and the thyroid. No, you're quite down, little up. First see, while going up you have to see the cricoid cartilage. Your cricoid is not seen. This is a string of pearls. Go little up, up, up. This is the cricoid. Now go up, go little up, up slow. Now try to identify the thyroid. See, this is the thyroid. Okay, but your cricoid is going. So here is the cricothyroid. Now you go little bit more up. थोड़ा और ऊपर. ये थायराइड खत्म हो रहा है, इधर आएगा थायरोहाइड मेम्ब्रेन, ऊपर इधर आएगा हाइड बोन. You just have to tilt a bit. Yeah, see now superior laryngeal nerve block. If you want to give the superior laryngeal nerve, you just pierce the thyroid membrane. Here it is quite lateral. See now, I show you. See, these are the string of pearls. This is cricoid. Okay, now this is cricoid. I'm going up. This is thyroid. Okay, now this is thyroid here. Okay, now ये इधर bone आ गया. See, this is hyoid. This is thyroid. So here. Okay.
So bone and gland look same.
No, bone is hyperechoic with a black shadow. No, gland is hypoechoic.
Okay.
And gland is different. We are looking for the cartilages.
To put them, where the PA pressures might be high.
So simple like an take home message is like an always remember the simple formula: cardiac output is equal to heart rate into stroke volume. So increasing stroke volume by giving preload or the increasing the inotropic contractility, or you want to increase the heart rate, always think, remember and take the action. So when you are giving frenin or the mefentrine, that means you are increasing the SVR. By increasing SVR, you are increasing preload. You are increasing preload. It is like an as good as you are giving fluid to the patient. So it is, and there are already studies like in the spinal anesthesia, you can manage hypotension, spinal anesthesia by giving fluid or the increasing the SVR. So both will, because even straight leg test ना, जैसे हम लोग लेग रेज टेस्ट करते हैं, जैसे हाइपरटेंशन हो गया तो पैर उठाया हमने पेशेंट को, तो स्ट्रोक वॉल्यूम होने के बाद उसका बीपी बढ़ गया, दैट मीन्स पेशेंट इज रिस्पॉन्डिंग टू द फ्लूइड. दैट इज वेरी सिंपल टेस्ट, बेड साइड यू कैन डू विदाउट मॉनिटरिंग.
तो उसमें यहाँ पे तो क्या तुमको एसपीवी दिख जाएगा, एकदम कुछ हेड लो हेड डाउन करने की जरूरत नहीं. एसपीवी 16 मतलब बिंदास, यू कैन कॉन्फिडेंटली से दैट द पेशेंट इज फ्लूइड रिस्पॉन्सिव एंड यू कैन गिव फ्लूइड एंड यू कैन सी दैट द एसपीवी कितना फ्लूइड देना है. हमेशा हम लोग अभी हाइपोटेंशन हो गया स्पाइनल के बाद दो पूरा
फ्लूइड दो, हेड लो करो. हेड लो करो मतलब क्या करते हैं हम लोग?
एसपीवी 9 तक आ गया, 10 तक आ गया, मतलब माय पेशेंट इज ऑप्टिमली फ्लूइड. So as we are moving, we can do nice, no? We can do fluid management. अच्छा, 200 ml वॉल्यूम दिया, SUV came to 9. पूरा ऐसे बॉटल एम्प्टी करने की जरूरत ही नहीं है जब तक आपको 110 या 20-30 प्रेशर.
You must came across the consultant after giving spinal anesthesia, hypotension. Some people की हेड लो दे दो, कुछ बोलते कि नहीं फ्रेनिन या फिर ये दे दो करके. So ultimately both are increasing the preload, but with different way. By giving head low also you can increase the preload or giving frenin.
We don't know, हम लोग क्या ड्रॉप देखते हैं. बट पोस्ट ऑप में इफ यू सी, अगर बहुत सारा फ्लूइड दिया है, अगर बहुत सारा इवन फॉर अ प्रेग्नेंट पेशेंट बहुत सारा फ्लूइड दिया है, पोस्ट ऑप में दे हैव लॉट ऑफ edema. Have you seen? Even I only had lot of edema. After my surgery I had so much edema.
Actually so many times we just inadvertently म्हणजे
that is because हम क्या सोचते हैं प्रेशर 70 है, अच्छा फ्लूइड दे दे 500.
IV fluid we don't treat as a medicine only.
इतना फ्लूइड लेने से उसको कुछ हुआ नहीं, लेकिन पोस्ट
yes done.
the outcomes are good.
So use fluid as a medicine, not as a just कि दे दो कितना है. इडिमा होता है, इसका मतलब पेशेंट का मॉर्बिडिटी पोस्ट ऑफ बढ़ता है, चांसेस ऑफ इन्फेक्शन, आईसीयू स्टे, वो हॉस्पिटल स्टे बढ़ जाता है.
Literally, they have a lot of edema, heart there, and all. They get a lot of edema. First time when I run. First to second time.
नहीं
But we need to go above that. No? We need to treat above that, right?
चलो चलो या
This is the last batch, no?
लास्ट वी डन नाउ. चलो ओके.
चलो अभी सब फोकस देख के आए हैं, इन्वेजिव मॉनिटरिंग देख के आए. अभी तुम्हारा तो हो गया. इन्वेजिव मॉनिटरिंग देख लिया ना?
नहीं देखा
नहीं देखा नहीं. इन्वेजिव वाला नहीं हुआ.
क्योंकि ये नहीं हुआ है क्या, फिर और एक बैक आएगा.
नहीं. I don't know. इन्वेजिव
एक रह गया शायद. ठीक है, बट एनीवेज चलो.
चलो बोलो कार्डियक वाले.
सो
Students, all students. Okay, great. Fellows of cardiac? Okay. So then you must have seen this monitor.
what it is called? Monitor? Cardiac output monitor, but it has its own name also. Hemosphere monitor. Okay. Okay. What are the parameters there? Yes. Yes. Yeah. Tell significance of each everyone. Cardiac output and cardiac index is a proper cardiac output. How much heart is pumping into the systemic circulation, and index is a surface area divided by. What is about the stroke volume? Is an M ejected per, and stroke volume variation SVV. Yeah, how much change is there per beat, like every beat is in. So what is the normal value for stroke volume variation? Stroke volume तो सबको पता है, right? Everyone knows stroke volume कितना है normal. Stroke volume variation. Normal value. If it is 5 or 6, is it normal or abnormal? Or if it is above 15, it is normal, abnormal. And what will be the action you will take? Stroke volume variation is one of the parameters where you can predict the patient's response to fluid. Okay. So the normal value range between the 7 to 13, 12. Okay. Above that, that means patient is fluid responsive, and lesser than that means patient is not responsive. So patient with the normal ejection fraction, if SVV is more than 10-15, so you are happy to give the fluid, because this patient is a fluid tolerance. Patient responding to fluid is different thing, and fluid tolerance is something different. Okay. And the same patient with the ejection fraction is suppose 30%, and the SVV is again still 15. Will you give the fluid or not? Ejection fraction is 30%. You will give. Why not? Because your stroke volume prediction, it is predicting you, na, he will tolerate. How much fluid he will tolerate, it will not be predicted. Maybe जो normal patient का ejection fraction है, he will tolerate whole 500. ये patient 100 ml में ही उसका stroke volume variation एकदम 7 हो जाएगा 15 से. Because only capacity of this weak heart is to tolerate this much fluid. But if the hypotension is there and a stroke volume variation is a 6-7, whether you will give fluid again?
6-7 पे कैसे देंगे? अच्छा, let us have a scenario. रात को 2 बजे तुमको लेप्रोटॉमी आई, सबको आता है ना 2 बजे रात को, ऑल जनरल भी है सारे, 2 बजे लेप्रोटॉमी आई, ठीक है? तुम ही हो रात को पोस्टेड अकेले, तुमको बोला जोकर में करो, 8 लाइन डालना है, सेंट्रल लाइन डालना है, वो तो सब डाल लेते हो, ठीक है? ये मॉनिटर है, इसका यूज़ करना, ठीक है? अब ये मॉनिटर है, इसको दिया यूज, लेप्रोटॉमी है, बट पूरे डिटेल देखने के बाद पता चला पेशेंट इज अ नोन केस ऑफ हार्ट प्रॉब्लम, उसका इजेक्शन फ्रैक्शन लास्ट ईको में 25%. Are we going to deny the procedure? No. We are going to still go ahead for a laparotomy. 25% clear है, लेकिन now we have to manage it. फ्लूइड भी देना पड़ता है, obviously.
फ्लूइड रिससिटेशन करेंगे.
बट हम फ्लूइड बहुत ज़्यादा भी नहीं दे सकेंगे, तो 25% ऑप्टिमल देना पड़ता है. तो हम क्या करेंगे, इसको अटैच करेंगे.
So hypotension है तो you will put a central line. At line तो डालोगे, ठीक है?
8 लाइन सेंट्रल लाइन तुमने अच्छे से डाल दी. All you have to do is ये मॉनिटर को जो है वो अटैच कर देना. Now you have all of these values. ठीक है? Now we talk. If the cardiac output is low, ठीक है? अब लो है मतलब कुछ तो करना पड़ेगा. प्रेशर इधर दिखा रहा है 160 वगैरह, but the cardiac output is on the lower side. Means we know that something has to be done to bring up the cardiac output. And the patient is a MI का patient, मतलब सब उसको poor ejection fraction का history है. So that's why your surgeon or anybody has told that this सब done. Then we see the stroke volume. Stroke volume is also less, maybe 30 या we need to do something, right? We are worried because अभी थोड़ी देर तक कुछ नहीं किया तो और
हाइपोटेंशन हो जाएगा, क्राइसिस सिचुएशन आ जाएगा.
तो हमारे सामने प्रेशर 100 होता, हम सोचते चलो ठीक But because you have this, you see that my cardiac index is low, my cardiac output is low, my stroke volume is low. Now we want to increase the stroke volume. तो कैसे हम increase करेंगे? Cardiac output is equal to
How will
stroke
you-
volume into heart rate. ठीक है? तो हीमोग्लोबिन का कौन सा फॉर्मूला है cardiac output में जो आता है?
So to increase the cardiac output हम लोग क्या क्या करेंगे?
क्या
स्ट्रोक
क्या
वॉल्यूम
करेंगे?
इंक्रीज करेंगे और हार्ट रेट इंक्रीज कर सकते हैं, ठीक है?
हार्ट रेट भी एक लेवल तक इंक्रीज कर सकते हैं ना. We can't
अभी जैसे
increase a
मैडम
lot
ने
because
बताया कि
it is the
एमआई का
oxygen.
केस, एमआई के केस में 100 हार्ट रेट अच्छा है क्या? नहीं है. So above 100 heart rate in a MI patient is not good.
It will
Heart rate
consume more
control,
oxygen,
yeah,
right? We have to balance. So what is the aim here? To balance oxygen demand and
supply.
तो इसमें हमको ऑक्सीजन डिमांड एंड सप्लाई में क्या क्या दिखा रहा है? कार्डियक इंडेक्स हमको लो दिखा रहा है. ये वैल्यू दिख रही है SVOT. ये क्या दिखा रहा है? What is this showing? Yes. What is that? Is it telling us the tissue extraction of oxygen, right? So if that is low, that means मैं क्या कर सकती हूँ कार्डियक आउटपुट बढ़ाने के लिए? क्या मंगाऊँ फटाफट से?
एक तो ब्लड आ गया है, ठीक है.
Blood.
अगर उसको एनीमिया है तो ब्लड इंक्रीज करेंगे,
So
ठीक.
we will try to give blood. So मेरा कार्डियक आउटपुट सबसे पहले ब्लड से इंक्रीज होना चाहिए.
मतलब हम लोग प्रीलोड बढ़ा रहे हैं.
Preload बढ़ा रहे हैं, right? Then we see the SPV. SPV में क्या रहता है? Normal value is 12 to 16, right? Sorry, 12, around 12. 12 to 16 means there is fluid responsiveness. So if it is around 14, 15 मतलब हम दे सकते हैं fluid, right? Fluid दे सकते हैं. Fluid में क्या देना चाहिए मुझे? मिक्स वीनस फ्लो दिखा रहा है तो ब्लड देना चाहिए. अगर मिक्स वीनस नॉर्मल है मेरा मतलब मैं फ्लूइड से ही मैनेज कर सकती हूँ. करेक्ट? इतना आपको समझ गया? दैट मींस वी आर हाफ वन द बैक. ठीक है? तो हमको यहाँ दिख रहा है कम है मतलब हम लोग को कुछ तो ब्लड जैसा. अभी सर्जन ने पूछा क्यों देना है ब्लड? मॉनिटर, राइट? ये कम है मतलब वी विल गिव ब्लड. फ्लूइड भी रिस्पॉन्सिव है. ऐसा नहीं मैं कि 25% है तो मैं कुछ भी कर रही हूँ. उधर फ्लूइड रिस्पॉन्सिव है. अगर 9 है 10 है दैट मीन्स इट इज ऑप्टिमली बैलेंस. तो अब मैं क्या दे सकती हूँ अगर मैं फ्लूइड नहीं दे सकती हूँ?
हमको कार्डियक आउटपुट इंक्रीज करना है.
ब्लड लॉस है तो प्रेशर दे सकते हैं. बट अभी मेरा SVR
प्रेशर्स दोगे कि आइनोट्रॉप्स दोगे?
हाँ वो इस पे देखेंगे.
ओके.
अब वो कैसे डिसाइड करेंगे? यस. व्हाट
Yeah.
इज SVR? यस. व्हाट डज इट टेल यू?
नॉर्मल वैल्यू. हाँ. हाउ मच इट इज? 800 to 1200. ओके.
Dynes per centimeter per 5 something whatever, right? तो उसकी वैल्यू में what does it tell you? That is the optimal resistance with which the heart will give you a pump to give a particular stroke volume, right? अगर ज़्यादा हुआ तो प्रॉब्लम है, right? और अगर कम हुआ तो भी प्रॉब्लम है. ज़्यादा हुआ तो हम उसको नीचे लाएंगे with some dilator, right? पर हमारा कार्डियक इंडेक्स भी कम है तो हमको क्या चाहिए? आइनोडाइलेटर, right? So we'll try to optimize with some आइनोडाइलेटर. Also we will be along with some ionizers.
Which are the inodilators? Which are the inodilators? One है. डोबुटामिन भी अच्छा है रे.
सीधा मिलरिनोन पे जाते हो. किसने किसने मिलरिनोन यूज किया? अभी डोबुट तो यूज करो. हाँ ठीक है.
ओके.
हाँ तो फिर एंटीजी भी हमारा बहुत अच्छा है. ऐसा इतना एंटीजी को पीछे मत करो. बहुत ही बढ़िया डायलेटर है. ऑफकोर्स उससे बहुत ज़्यादा डायलेट हो जाता है लेकिन
वेनोडाइलेटर.
करेक्ट.
बट वीनोडाइलेटर का आउटलोड कम नहीं होगा. प्रीलोड ज़्यादा होगा.
प्रीलोड ज़्यादा. प्रीलोड तो किसी से भी ज़्यादा होगा लेकिन आइनोडाइलेटर और ये इसमें क्या रहता है? आइनोट्रोपी भी अफॉर्ड करता है. वीनोडाइलेटर से इट विल कंप्लीटली ब्रिंग डाउन द SVR वेरी रैपिडली because it is the venous compliance of the body is more. Arterial dilators are separate. Venous dilators are separate.
You want to keep the SVR little bit towards the lower side, and at the same time increasing the cardiac contractility. That's how the milrinone is the best choice in that case, or the dobutamine is the best choice. Okay.
And regarding these nitrates will increase the peripheral, मतलब increase the preload number, the venodilation number. So systemic vascular resistance won't come.
So venodilator means it will bring down your blood pressure ना. It will bring down your blood pressure. So SVRI भी कम ही होगा ना. Systemic vascular resistance कम ही होगा.
Comparatively venous बहुत ज़्यादा होता है, but there is a systemic effect also. Okay, with the NTG, it is not like NP that one. For but the low ejection fraction, it's act in a very good way.
Yes.
At the same time, it will reduce the SVR also. At the same time, अभी ejection fraction कम है, heart को कम pressure के against काम करना है, तो you need a lower side of SVR. And at the same time कि
तुम ज़्यादा पढ़ाई करते हो कम पढ़ाई करते हो.
इवन प्रीलोड भी कम. वीक हार्ट को प्रीलोड कम है, दैट इज ऑल्सो हैप्पी. ही इज हैप्पी कि उतना प्रीलोड आ ही नहीं रहा है तो उसको उतना पंप नहीं करना है. तो एनटीजी इज मोर बेनिफिशियल इन दैट केस.
जितना वॉल्यूम लैप्रोटॉमी में तुम्हारे को 5 लीटर या 2 लीटर जो तुम नॉर्मली भर भर के देते हो वैसे तुम ये हार्ट को नहीं देते इन शॉर्ट. बट अगर तुम्हें देना है तो तुम थोड़ा सा प्रीलोड इसका एनटीजी वगैरह देके कम कर सकते हो सो दैट यू कैन गिव सम वॉल्यूम बिकॉज यू नीड टू हैव सम फॉरवर्ड कार्डियक, राइट? So that's why you would want to dilate a bit so that you can give some volume, because if there's an ongoing blood loss, you need to correct that also. So then you give blood, watching your cardiac index and your tissue perfusion, watch your SVRI so that it is not very high or very
So
low.
with this monitor, we have coming with the
Non-invasive.
minimally invasive and non-invasive. So these two are for the minimally invasive, where you require only arterial line, where it will predict all the parameters as we discussed here. According to parameters, we take the action whether it will require the vasopressors, inotropes, or inodilators, or the just venodilators. Okay, there is another technology, what is called finger cuff technology. There is like a BP cuff with two fingers. It will compress and dilate the fingers 1,000 times in a minute, and it will predict all the parameters again. Okay, and then these patients again the same, the high risk patient, you will apply in whether this patient will require inotropic management intraoperative or in ICU. We can predict very fast that way. There is one HPI index also with the Acumen IQ. It is a different sensor for it, which will predict the hypotension 10-15 minutes prior to the event actual hypotension happening. And we, again, if you have all these parameters, you can take the action and will prevent that hypotension to happen.
Now, if you put this, I'll give you a scenario. Cardiac index is showing 3, 4, whatever, 4 maybe. Okay, normal and slightly higher. SVO2 is showing higher. SVRI is very low. SVRI is low. What will you do? What is the scenario called? Vasoplasia, but क्यों हो रहा है? कौन सा सिचुएशन में होता है? क्या करें? Sepsis. So this is sepsis. So this is a very good monitor to detect laparotomy और ऐसे complicated cases है जहाँ पे sepsis है, low cardiac output, distributive shock. Yes. So these are all the differential diagnoses that you can give, and this is very important for such kind of cases. Septic patient है that you would take for laparotomy, or like poor ejection fraction patient taken for laparotomy. So these parameters will tell you. So क्या start कर सकते हैं? Some noradrenaline, right? Noradrenaline is a drug of choice for starting, so that we improve maybe the whatever vasoplasia is there, right? So these parameters देखने से, otherwise अगर ये सब नहीं होता, you would be just seeing maybe 110/70, and you never know when is the next hypotension or crash going to happen. Next what you see is urine output कम हो रहा है, अरे पता ही नहीं चला क्या हो रहा है, मैं तो fluid दे रही थी, मैं तो fluid कर रही थी, right? So with these parameters, we can actually calculate the cardiac output, we know the cardiac index, tissue perfusion, and these things are very important to watch on microcirculation.
So with the keeping the same clinical scenario, this patient is having COPD component also. Suppose ischemic heart disease for the perforation and all these things with the COPD component. We apply these parameters. आपने fluid दिया, inotrop किया, तब भी BP ऊपर नहीं आ रहा है, and the cardiac output index and cardiac output remain in the same range. Patient is still in hypotension. So what may be the cause then? In sepsis scenario, what we are discussing. That means a COPD component has all this problem which is not covered with this monitor. In the sense, this sensor. You need a more invasive things like in having PA catheter also. So that means your RV is something problem, because we are monitoring on the left side of the heart, not on the right side of the heart. Okay. So ultimately, to full monitor, you need to monitor on the left and right side of the heart, because in normal patient it is equal. Cardiac output of right is equal to the left. But when the discrepancy is there, left or the right heart failing is there, the scenario get deranged, because these systems are not remain in a parallel as it was usual. So if patient is on RV dysfunction, RV failure, fluid दे सके कुछ फायदा नहीं होगा, क्योंकि RV is not able to push the blood toward the left side.
This is all when they are considering जो case का decrease हुई है, or in the case when there is a decreased LV ejection fraction, right? If there is a decreased RV ejection fraction, then you have to put in a PA catheter, but then the morbidity of the surgery is very high.
Okay, so
what you should do? Prognose the patient that there is a RV dysfunction.
So when you are seeing the echo
when
reports,
you give so much of volume, it's not going to come up. Already tell your surgeon, tell everybody around you.
तो जब echo report देखते हैं तो सिर्फ ejection fraction नहीं देखना है, तो ultimately you see the right heart कैसा है करके. So RV function should be normal. Okay, good biventricular function लिखा रहता है ना, तो वो उसको बहुत importance है, ठीक है. LV compromise रहा है तो LV we can manage LV very nicely, but if it is a RV problem, then it is very difficult to tackle. So with the TR having in echo moderate to severe TR, then you should have an. Okay.
Which you should put, because then it will be like a highly morbid surgery, right? But in general scenarios, when you have some sepsis or something, this monitor should be adequately enough for you.
Like I
because
said,
that is highly invasive, and that's going to have its own complications.
So when patient is having same kind of surgery with the lung fibrosis case and all these things, this is not a good monitor. Invasive monitor will be more good for. Okay, because it is managing your right side of the heart. Because once right side of the heart is pumping good, and you know that on echo right left is good one, so it is going to give a good parameters to you.
Right?
Any question?
Yeah, must have used this for pulse
Yeah, pulse pressure variation. PPV.
So they don't
Yes,
say
agree.
that, but we use it. We use it. We are using for all cardiac surgeries. We are using for all the cholecystectomies or open water surgery.
So yeah, so ultimately only thing is the predictability, the percentage of probability just get reduced. It will not vanish its importance.
And what you are seeing is the trend. एक बार मुझे 70 हो गया, that means the patient is problematic. No, you see now the trend is important, right? So with any parameter you have to use your this thing. If the hypotension prediction is saying 95%, then this is this. But you still are using your acumen, right? At every point of time you have to use these values to your use, like so it won't be completely this thing.
So
Maybe the values may not be as correct, but 90% it is always correct.
so
the
not
trend is important.
not just on chest open. Suppose patient is in AF or some arrhythmia. Again, that cardiac output is not that reliable. But it is not like it is absolute. You can't
Absolutely.
trust on
We
it.
use it for cardiac surgery
Okay.
whether there is AF or whether there is anything for heart transplant. So we don't completely define it. We say that it's the trend that is more important.
Yeah. इसमें में आ सकता है, but when you are getting more refined stroke volume variation, why you want to go for the pulse pressure? Pulse pressure तो अभी तो normal monitor में भी Philips के इसमें भी आ जाता है.
हो गया और भी है डल ना
ये एक और है क्योंकि वहाँ पे 3 थे
तो हो गया, इधर का हो गया ना सब अभी. So there are 2 finger cuff here which will be applied, which work for the 72 hours. By that time you know that कि patient का improvement कौन से side में हो रहा है और whether yeah continue.
Yes, of course. अभी तो we have invested in it, then why not?
What is the cost?
Cost.
Cost is like dependent upon the number of models you buy. Start from 40 lakhs.
नहीं, आपको कौन से पैरामीटर्स देखना है, राइट साइड, लेफ्ट साइड, फिंगर कफ चाहिए, सेरेब्रल ऑक्सीमेट्री चाहिए, तो वो सब.
This is flow track, this is swab, this is full side, and this is non-invasive. So depending what you are buying, so the cost varies, but we'll start at 40 lakhs.
The hospital has to be convinced. They are convinced.
So for flow track, acumen, everything has a different parameters.
Yes. So this one is something which is old one there. They come with the Acumen IQ right now,
These
which
are non-calibrated devices. These are calibrated devices. So we are changes the non-calibrated.
हाँ, that is hypotension prediction index extra मिल जाएगा उसमें. Thank you. On this finger cuff technology is something again newer one, which is more good. Equally reliable. So it is when not reliable is one is an arrhythmia. Second thing is when too much of inotropes are required कि यहाँ पे patient को necrosis हो रहा है अभी, तो perfusion ही नहीं हो रहा है तो वो क्या predict करेगा? So that at least moderate inotrope तक up you can trust on it. Okay. So when inotrope requirement is too much high, then definitely it's an indication you have to shift from the non-invasive to invasive. So at least in between you can go with the arterial line, and then if it is still more, you can go with more advanced cardiac output.
The pulsatility index PA will be coming on that. The invasive monitor, this also.
Yeah, this one is. Yeah.
Cerebral oximetry also will become.
Yes, yes.
Yes, this you can see.
It has different
This is the right and left hemisphere.
modules will be
You can
there.
see the
So it is not just a cerebral oximetry. Whenever you keep the sensor on that part of the body, it will predict the perfusion on that side.
नीचे का भी we show that
So suppose in ECMO, whether you are
Real-time hemoglobin, that can also be coming.
रियल टाइम हीमोग्लोबिन इसमें है क्या?
We upgraded it, sir.
है इसमें?
Not real time hemoglobin, real time change in hemoglobin.
Hemoglobin.
It will not give the exact hemoglobin, it will show you the what is the change. Suppose it was 10, 5 minutes later, has it gone 5% up or 5% down?
Okay.
Done.
Yeah.
मेरा भी ले सकते हो क्या एक वीडियो? ये आएगा ना वीडियो?
ऑडियो नहीं आएगा, लेकिन ऑडियो इसमें ही आएगा।
अच्छा, आपके इसमें कनेक्टेड है क्या? अच्छा, एक्चुअली मेरा माइक भी है, मैं लाया एक्चुअली माइक भी। Good. Yeah, that's it. Finished. So you can still decrease the depth. The depth is at 9.9 centimeter. Spine is seen. उल्टा उल्टा ऊपर वाला. हाँ करो और करो. आपने को area of interest देखना चाहिए, not the other area of interest. Exactly opposite. So this is your superior mesenteric artery. Anterior to the superior mesenteric artery. So freeze करो. Freeze the image. हाँ. So previously the image was like most of the dark shadow was seen, which we don't want. So now you have to see nicely the aorta, nicely the superior mesenteric artery, nicely your liver, rectus. This is your gastric antrum. This is your pancreas. Okay. So sometimes at the depth, if you are little cranial, you can see the celiac trunk also. नहीं अभी ये sagittal scan में नहीं दिखेगा, transverse scan में दिख सकता है. See, the pregnant female, what happens is, the pregnant female like this, it is there, right? So now you cannot keep the probe only. Because area has become full like this, correct? You cannot keep the probe. So that is one difficulty that you will face. So in those patients, what you do is put the patient is, you put the patient in right lateral decubitus position, or you put the patient in right semi-recumbent position, like that. That you can do. You can push manually the gravity uterus that side. That also you can do. But it is very difficult. So why you have to do? Unless patient is very much high risk for spinal, you cannot give spinal anesthesia. You have to give only GA. Then you measure that time. Otherwise GA dena hi to we know that it is full stomach only. Full stomach only. So that is one thing. Then you will have the fetus. Then you have the uterus. Then you will have the fetus moving. Fetus will be moving. So you will not be able to see the image properly. That is one thing. Second thing, patient will have fast breathing. Tachypneic रहेंगे ना, तो वो fast breathing में भी आपको दिखेगा नहीं. एक चीज़. दूसरा चीज़, antrum would have gone cephalad. So that time also you will not be able to see. That is why you put the patient in. If at all you are going to examine the pregnant patient, put it in the right lateral decubitus position, push the gravity uterus, and see. Celiac artery. वो दिखेगा क्या? देखते हैं. Celiac trunk कहाँ पे टेक ऑफ होता है? T12. Sure. उतना नीचे. Second rib कितना है? T4. Second rib is T4, na? Angle of Lewis. What are the changes that happens at angle of Lewis?
Branching of
There are many things. That is one.
bifurcation of trachea, the arch of aorta starts
Spine level क्या है? Angle of Lewis. T4. Correct, T4. So T4 से approximately यहाँ आओगे. देखिए. Now see, you can see one vessel coming out like this. You can see the pulsation here, right? There is one vessel here. I go up, you can see from here a trunk arising here. You see it? You can see the artery taking off. So it could be celiac, we don't know. Superior mesenteric artery is still little down, huh? Yeah, it could be superior mesenteric artery also. We don't know. But immediate होता है. Celiac then superior mesenteric artery. Immediate take off होता है. So I am not able to tell you which is celiac and which is superior mesenteric artery. So from here in this sagittal scan, it's very difficult to tell. But gastric antrum दिख रहा है, so mostly it is superior mesenteric artery only. Because in this place, the scan will tell you superior mesenteric artery. Yeah, okay. 1 minute. इनका इसका होने दो. ये अभी तुम जो देख रहे हो वो IVC है. आयोटा के लिए थोड़ा उस तरफ जाना है ना. ये देखो सुपीरियर मेसेंट्रिक आर्टरी आ रहा है. हाँ, तुम ऐसे देख रहे थे तो वो IVC है, ये आयोटा है. ओके, सो नाउ थोड़ा सा नीचे आओगे, गैस्ट्रिक एंट्रम दिखेगा. दिख रहा है गैस्ट्रिक एंट्रम? पता होगा किधर? यस, बस यही इमेज चाहिए अपने को मेजर करने के टाइम पे.
Superior mesenteric artery, again, gastric antrum.
Liver. ठीक है, you can still acquire the image very well. थोड़ा सा. अभी ये इमेज देखो, ये इमेज कैसा लग रहा है? हाँ, it takes time to acquire the image. You need some little patience. That's it. अभी ओके? हाँ. अभी देखो मेरा लिवर पूरा दिख रहा है, IVC दिख रहा है, स्पाइन दिख रहा है, पैंक्रियास दिख रहा है, सुपीरियर मेसेंट्रिक आर्टरी दिख रहा है, गैस्ट्रिक एंट्रम दिख रहा है. दिस इज व्हाट. फ्रीज करोगे? फ्रीज किया है क्या? सो दिस इज द टिपिकल पिक्चर दैट यू विल रिक्वायर. एक मिनट, एक फ़ोटो ले लेता हूँ, मैं आपको दिखाता हूँ. ये आ गया जाना नहीं आएगा. मुझे भी मेरे हॉस्पिटल में बच्चे को दिखाना है. ये ऐसा इमेज आना मांगता है.
बढ़िया पेशेंट नहीं मिलते.
ओके, आपको मैं बताता हूँ.
सर एक बार ये इमेज में बता.
हाँ, ये इस तरफ आ जाए कैमरा. उनको चाहिए शायद वीडियो रिकॉर्डिंग. So basically, what you require is to see the gastric antrum.
Yes.
So now the gastric antrum lies between the liver and the pancreas. That is liver little cranial anteriorly. This is your liver. The liver is hyperechoic, echo texture. Okay. Now pancreas, how will you know? It is also a hyperechoic structure. You can take this superior mesenteric artery as the depth. So the most probably this is the pancreas. You can see this pancreas? So this is the aorta. So how will I know this is aorta? My orientation is towards little right side. I will left side. Patient left, like this. If I take the probe this way, right side, then it is IVC. You can get the same image with the IVC at the background. But when you want to measure the gastric antrum, you need aorta as the background. Okay. Now see the shadow like this.
Yes.
So this is your spine. And this is your aorta. This is the superior mesenteric artery taking off. Okay, so now this is the gastric antrum. This is your rectus muscle. You can see the rectus muscle? Yeah, this is the rectus muscle. So now what we will do is, we'll scan now again. Now you keep the probe, hold like a pencil like this, parasagittal or sagittal, below the xiphoid process, epigastric region. So now you can see the liver. So what happens is that my main focus is become the liver. So now you adjust. You can see the spine also. Can you see the spine? Okay. Now the main focus is on the liver, so I have to adjust. So adjust, come, see where am I moving the probe? See, you have to rock the probe like this. You can do the lateralized motion like this. See, you can do a healing over, towing over movement like this. So that is how you get the image. Now you can see this. It looks like gastric antrum, but not the antrum. It's bowel because of the bowel gas shadow. It's casting a shadow. So air will not conduct the ultrasound. So now what you need exactly is this. So you can see the aorta and the superior mesenteric artery. Now that I can see the takeoff of superior mesenteric artery.